study upon war prisoners of Vietnam. 14 years of war between America and Vietnam. Levels Bond program. Have you heard it? Levels Bond program was another program of Hitler where new race of German will be created by unethical Hitler where new race program of German will be created by unethical because Hitler where new race program of German will be created
who are the bloodline of Aryan race.
Hitler where
And deadly human experiments by Nazi doctors. I'll show you some pictures who are the bloodline of Aryan race. Forget about this. Lastly, the deadly human experiments by Nazi doctors. I'll show you some pictures. The debatable subject throughout the world of Aryan, not legalized even in India, and then legalized only by Nazi doctors. I'll show you some pictures. The debatable subject throughout the world of Aryan, not many of you have seen the Schindler's List. I'll show you the picture of that. Just who are the bloodline. You see the unfortunate prisoners. See what their experiments legalized and how I'll show you the picture of that. Just who are the bloodline. You see the unfortunate prisoners. See what their experiments legalized and how I'll show you the picture of that. Just who are the bloodline. You see the unfortunate prisoners. See what their experiments legalized and how I'll show you the picture of that. Just who are the bloodline. You see the unfortunate prisoners. See what their experiments legalized and how I'll show you the picture of that. Just who are the bloodline. You see the unfortunate prisoners. See what their experiments legalized and how I'll show you the picture of that. Just who are the bloodline. You see the unfortunate prisoners. See what their experiments legalized and how I'll show you the picture of that. Just who are the bloodline. You see picture of that. Just picture of that. Just treated by the plastic. It is as good as untreated. You see, white doctors are doing the experiment and the subject by the black Americans. So there was a racial distribution, you see, and how white doctors are doing the experiment, and the sum of 1932 ended in 1972. So there was a racial distribution, you see, and how one journalist in the experiment, and the sum of 1932 ended in 19 put it into the print. See the Vietnam and the subject by the black underworld. So there was a radiation, you see how it optimizes the experiment, and the sum of radiation you can see to the particular spectrum, it produces cancer. So these were the experiments, these were the places where the subjects were being kept. You must be having the name ghetto. This is a ghetto. Ghetto means where radiation prisoners used to be kept. There was no hygiene, and the sum of radiation you can see to the particular spectrum, it produces cancer. So these were the experiments, these were the places where the subjects were being kept. You must be having the name ghetto. This is a ghetto. Ghetto means where radiation prisoners used to be kept. There was no
or in front of the firing squad and used to kill them. So unfortunate.
Places where the subjects were being kept, you must be having the name ghetto.
All conditions. These are all conditions. With wires, there is a video called Holocaust Administration. All conditions relax on these places. And there is a video called Holocaust Administration. Concentration camp. This is the office concentration camp. Where the film. This is a gas chamber. You see, it's a closed one. Brought here together and gas from outside inside. And the gas was nothing but carbonyl chloride. That's called phosgene. And people used to die in the gas chamber. You see, it's a and that was the easiest method of killing a huge number of pressure and gas together. And the gas was nothing but carbonyl chloride. That's called phosgene. And people used to die. Same gas chamber. Huge number of liberation of there was a stand. Documents and 20 plus that time you so those stand
even through stamps. Now this doctor, he was a pediatrician. He is a black sheep pediatrician of Germany. His name is Dr. Joseph Mengele. Even through stamps. Now this doctor, he was a pediatrician. He is a black sheep pediatrician of Germany. His name is Dr. Joseph Mengele. Even through stamps.
Select them from the parents.
Now this doctor, he was a pediatrician.
Again, one for plus.
He is a black sheep
That is the
pediatrician
control,
of
another for the test.
Germany. His name is Dr.
Ultimately,
Joseph Mengele.
who knows what happened to those children? Whether they died from the parents. Nobody knows.
Now this doctor, he was a
The
pediatrician.
same person on the same children, group of children, will do an experiment.
His name is Dr. Joseph Mengele.
Ultimately, study. Was conducted workshop. Junior workshop. Whole life. The same person on the same children, group of children, tried to experiment. This group of children tried to food and drinks for period of workshop. And they got imagined. And the objective of the study is how much time to kill them. How much time to food and drinks death. This is a malnutrition fixed by the study. Imagine conduct. The objective of the study is how much time to kill the situation. Ethics is there, but violation of ethics is you see, the points what you will conduct medical council, they are the custodian of medical ethics. Again, ethics is there. Please apply violation of ethics, apply your consent, apply your wisdom. The points what you will conduct, not that somebody will tell you, a doctor will come and tell that I will give you. There are many examples. Doctors are kickback money and so. So all these things cannot be not the medical ethics. So medical ethics is a that I will give not. There are many examples. Doctors practice and not a very hard kickback practice. It is a sweet will. All these things. Unfortunately, this medical ethics is not taught in undergraduate ethics. I was 20 years professorship in a medical institution, so it is a sweet will that we could not make it. Unfortunately, this now probably they have started in the last year medical ethics. One was still there. 2 or 3 classes allotted for that. So if you cannot switch it for the younger age, I will see now probably the doctor of the lecture in the last year medical ethics is a bit too often try to show your people around. So if you cannot learn from that, this is a very unfortunate. I will tell you that all ladies are not in the concentration camp. So these few words, then I will show you what your people around told in 30 minutes and learn from that. But this is the pillars are autonomy, justice, beneficence, and confidentiality. So these few words. Thank you very much for thinking out of the box, because my job was out of the box. But any questions, I'll be available and confident till lunch. So you can ask me. Thank you very much for thinking out of the box. Any questions? Because my job was out of the box. But any questions? I'll be available till lunch. So it's called code of conduct. And ethics is a guideline. Those are two things. Ethics is not a guideline. Ethics is whenever you see some seniors, you just stand up. It's called British people, European people. They always take a guideline, not in the sitting posture. They just stand up and do it. That's an ethics. Whenever you see some seniors, sometimes you just stand up. Overlap. If you see a female patient, you'll have to take a female nurse or somebody. Even if you not get a nurse, at least you find out your husband of the sitting posture. This is an and this is possible. Again, it is. Other way overlap. Any other question? If you see a female patient,
right here.
you'll have to take a female. Yes.
Because many of the students in a drug
nurse or somebody.
you know that. And we are the end consumers of
Your
that.
husband of
we could become consumers of some vaccine which had an unstable trial. But now it has come out well and the whole world is using it. Do you think this information needs to be circulated to the end consumers that this had a dark side here? Or should we just keep them both?
Yes, this is again a very important thing. Whenever a drug is developed, it takes 20 years to develop from laboratory to practical. And at least billions of rupees are being spent to develop it.
The whole world is using it.
But
Do you think this information
consumers are prescribed. But the drug trial or clinical trial is not in time. Clinical trial is not in after the marketing. That is called pharmacovigilance, which is mandatory to all medical colleges. Yes, this is called pharmacovigilance. That's why I brought out mandatory to today medical college. I hope that many of the doctors have not known this. That's why I brought out mandatory. I hope yes and story keep that. Anything more? Yes and story keep that. Tomorrow has a question. Anything more? Tomorrow has a question. Unethical practice is punishable or not? Yes. There are code of conduct which has been published by Medical Council of India where you do's and don'ts. There are code of conduct which has been published and there are some conduct in India like that do's and prescribing a banned drug. And there are like when we were students, like the pain of someone is one of the banned is the drug of choice. Unconditionally consumed. But Malala is no longer used because of it is banned because of the doctors, many doctors. But Malala no longer used because of the market. Now, as a doctor, if you prescribe barreldoxin and inject many doctors, patient that comes to the mind of the government or the drug control department. Now, as a doctor, there are because I was a drug controller post for 3 years. So I had to do all that. I tell you a story as a doctor. Because I was a drug controller.
1 minute, 2 minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here? 1 minute, 2 minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here?
Am I correct?
2 minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here?
There was a report came in
2 minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here?
there was a report came in
2 minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here?
so anti-cancer drug is
2
given
minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here?
so anti-cancer drug is
2 minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here?
started like anti-cancer drug is
2 minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here?
started like anti-cancer drug is
2 minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here? 2 minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here? 2 minutes.
Okay.
The story is very interesting. Very interesting. How many gynecologists are here?
so we are also starting
Okay. The story is very interesting. Very interesting. How many gynecologists are here?
Okay.
The story is very interesting. Very interesting. How many gynecologists are here?
Okay.
The story is very interesting. Very interesting. How many gynecologists are here?
Okay.
The story is very interesting. Very interesting.
adverse reactions later. So post
Okay. The story is very interesting. Very interesting.
we relate to that. Adverse didn't go to the press.
Otherwise, you will know, knew that because that time the health minister was a doctor. He told me not to divulge it to press. Otherwise, you confidence knew that because outcome was good. The health minister was good for me also. I lost my chair of not to diverge into percentage. Thank you very much. Otherwise, you confidence knew that the outcome was good. The health minister was good for me also. I lost my chair of not to diverge.
I think there we will discuss it in the
Otherwise, you
lunch time.
confidence that
So few
the
comments
outcome was good.
this
The health minister
formatting
was good for
as
me also.
Nangsu was
I lost my chair of
now.
not to
I think
diverge.
there we will discuss it in the medical committee. So do am I am on the member of the medical committee and not at the now. I think there we will discuss it in the medical committee. So do am I am on the member of the medical committee and not at the now. I think there we will discuss it in the medical committee. So do am I am on the member of the medical
very basic thing. Number one, those who are opting. Number one is the consent. Number two is the writing of the death certificate. Number three, explanation, and number four is the end date. Consent, you know, everything is what you are doing on the death certificate. Number three, explanation, and that has to do with the end date. Consent, you know, everything is what you are doing on the death certificate. Number three, explanation, and that has to do with the end date. Consent, you know, everything is what you are doing on the death certificate. Number three, explanation, and that has to do with the end date. Consent, you know, everything is what you are doing on the death certificate. Number three, explanation, and that has to do with the end date. Consent, you know, everything is what you are doing on the death certificate. Number three, explanation, and that has to do with the end date. Consent, you know, everything is what you are doing on the death certificate. Number three, explanation, and that has to do with the end date. Consent, you know, everything is what you are doing on the death certificate. Number three, explanation, and that has to do with the end date. Consent, you know, everything is what you are doing on the death certificate. Number three, explanation, and that has to do with the end date. Consent, you know, everything is what you are doing.
four things you judge and then you declare the brain death. So this is the ethical thing. So many things we four things you judge and then you declare the brain death. So this is the ethical thing. So many things we session judge.
So now may I request
So this is the ethical thing. So many things we session judge.
So now may I request
So this is the ethical session judge.
So now may I request
So this is the ethical session judge.
So now may I request
So this is the ethical session judge.
So now may I request
So this is the ethical session judge.
So now may I request
So this is the ethical session judge.
So now may I request
So this is the ethical session judge.
So now may I request
So this is the ethical session judge. So this is the ethical session judge. So this is the ethical
So we welcome Dr. Abhikar, our. Is it working?
Yeah,
It's.
it's working.
Hi. So hi Avik.
Thank you. So this is something you can lock the doors. I don't want anybody to get out of this house now. So this is concern everybody in your, probably you, your family, and so this. I intend to visit this place. It's a lovely place. My friend practices somewhere close to that. So the only problem is I think it was so this similarly in arthritic joint. I intend to visit this place. It's a lovely place. And my friend talk about how it's so difficult to the only problem is I think it was and then similarly the arthritic we have. I intend to visit any way of doing that. And my friend talk about how it's so this is your I continue to be honest. And similarly, the arthritic we have right now is anyway joint that gives us flexibility. Talk about how so this is your coefficient of infection. And similarly, the arthritic we have right now is anyway joint that gives us flexibility. Talk about how so this is your coefficient of infection. And similarly, the arthritic we have. They had a pipe burst and the whole hostel was flooded and they made use of it by decreasing the friction and converted into a they had a pipe burst so and the whole hostel was flooded and they made use of it by decreasing the friction and converted into what happened it's painful they had a pipe burst very painful and the whole hostel was flooded and they it's an nagging pain, it's a chronic pain. And when you have healthy cartilage, you can do anything in your life. You can go chronic pain, holidays, to Darjeeling, climb the mountains, play sports. You can do otherwise you end up in a mountain riding, holidays, cartilage there, gone there. Now, why doesn't it regenerate? What is the issue here? The cells are spacely spaced, and on there you have one cell here, doesn't it regenerate? Another cell there. What is the issue here? In between, there's a lot of this connective tissue, collagen fibers there. You have one. There's lack of blood supply there. The cartilage does not have a direct blood supply. There's a lot of only tissue, collagen fibers there. You have one. There's lack of blood supply there. The cartilage does not have a direct blood supply. There's a lot of only tissue, collagen fibers there. You have one. There's lack of blood supply there. The cartilage does not have a direct blood supply. So traditionally there have been these medicines which are there in the market for regeneration. So traditionally there have been these medicines which are there in the market for regeneration. So traditionally there have been these medicines which are there in the market for regeneration. So traditionally there have been these medicines which are there in the market for regeneration. So traditionally there have been these medicines which are there in the market for regeneration. So traditionally there have been these medicines which are there in the market for regeneration. So traditionally there have been these medicines which are there in the market for regeneration. So traditionally there have been these medicines which are there in the market for regeneration. So the avocado oil is known to be an anti-arthritic joint. Then you have all the seeds. Green leafy vegetables are very important. Avocado oil, fish, and any oily and anti-arthritic for your. Then you have all the joint there. Green, and this is where the bad food are very important. Avocado oil, this is where today we will be having all the bad food. By the way, we had it for breakfast. Green, and this is where the bad food are very important. Avocado oil, this is where today we will be having all the bad food. By the way, we had it for breakfast. Green, and this is where the bad food are very important. Avocado oil, this is where today we will be having all the bad food. By the way, we had it for breakfast. Green, and this is where the bad food. With all these colors are all pro-inflammatory food. Coming to exercises. So what are the exercises which are all these colors? How many of you did exercises in the morning today? One. Coming to exercises. So what are the exercises which are all these colors? How many of you did exercises in the morning today? 7. Coming to exercises. So what are the exercises? So let's talk about what exercises are good. Cycling, the number one exercise. Any kind of cycling. Then you have rowing, cross trainer, swimming, and walking. Walking is down the number one exercise. Any kind of cycling. It recruits stem cells, cross trainer is important for cardiovascular regeneration. It also produces growth factors and reduces your cycling. It recruits stem cells, cross trainer is important. And I love cycling. I do twice a week there, whether it's in the gym or anywhere else. And it has improvements that your cartilage is enhanced. I love cycling. I do twice a week there, whether it's in the gym or anywhere else. And it has improvements that your cartilage is enhanced. Other things are cross trainers, cycling there, whether it's in the gym or anywhere else. And it has improvements that your cartilage is enhanced. Other things are
strength because you have good core muscles, UPR muscles, calf, thigh muscles, then you are actually offloading the joint. Similarly, maintaining a flexibility muscles, for the flexible joint. Similarly, maintaining a flexibility muscles, for the flexible joint. Similarly, maintaining a flexibility muscles, for the flexible joint. Similarly, maintaining a flexibility muscles, for the flexible joint. Similarly, maintaining a flexibility muscles, for the flexible joint. Similarly, maintaining a flexibility muscles, for the flexible joint. Similarly, maintaining a flexibility muscles, for the flexible joint. Similarly, maintaining a flexibility muscles, for the flexible joint. Similarly, maintaining a flexibility muscles, for the flexible joint. Similarly, maintaining a flexibility muscles, for the flexible joint. Similarly, maintaining a flexibility muscles, for the helps stronger liver cartilage. Across different scientific literature, which helps stronger liver cartilage. Across different scientific literature, which helps stronger liver cartilage. Across different scientific literature, which helps stronger liver cartilage. Different scientific literature, which helps stronger liver cartilage.
No more inflammatory foods there, and stem cells are there. If you have patients, if you also want to try, read about it, and you can take it.
Which helps stronger liver cartilage.
No more inflammatory foods there, and stem cells are there. If you have patients, if you also want to try, read about it, and you can take it.
Which helps stronger liver cartilage.
No more inflammatory foods there, and stem cells are there. If you have patients, if you also want to try, read about it, and you can take it.
Which helps stronger liver cartilage.
No more inflammatory foods there, and stem cells are there. If you have patients, if you also want to try, read about it, and you can take it.
Which helps stronger liver cartilage.
No more inflammatory foods there, and stem cells are there. If you have patients, if you also want to try, read about it, and you can take it.
Which helps stronger liver cartilage.
No more inflammatory foods there, and stem cells are there. If you have patients, if you also want to try, read about it, and
has got temporary effect in reducing the pain. It does not change the course of your disease. It does not alter the disease course. Similarly, with rheumatoid arthritis, it gives pain relief. That's all. Has got temporary effect in reducing the pain. It does not change the course. Asking what does steroid? It does not alter the disease course. It doesn't. Effect in reducing the pain. It does not the course. Asking what does steroid? It does not alter the disease course. It doesn't. It does not the course. Asking what does steroid? It does not alter the disease course. No, it doesn't. It does not the course. Asking what does steroid? It does not alter the disease course. No, it doesn't. So it's when I think you should saying that. We compare what does steroid? It does not alter the disease course. No, it doesn't. So it's when I think you should saying that. We compare what does steroid? It does not alter the disease course. No, it doesn't. So it's when saying that. We compare what does steroid? Oh yes, alter the disease. Other kind of saying that. We every kind of disease. Oh yes, alter the disease. Other kind of saying that. We every kind of disease. Oh yes, alter the disease. Other kind of saying that. We every kind of disease. Oh yes, alter the disease. Other kind of saying that. We every kind of disease. Oh yes, alter the disease. Other kind of saying that. We every kind of disease. Oh yes, alter the disease. Other kind of saying that. We every kind of disease.
Thank you. Thank you, everyone.
Right, thank you so much. Next, let's move on to the metabolic side again. Ashish Mitro, Ashish, are you here? Okay, so Ashish will talk on two topics, one after another. One is the ULI action for physiological glycemic management, and he will also talk about how to initiate insulin in type 2 diabetes. So, two talks, one after another, and we have two esteemed people as chairpersons, Dr. Indrojit Shah. Indro, are you here? Indro and Dr. Saurabh Manna. Saurabh and Indro, please take your seats as chairpersons. And for the audience, if you have any questions, it will be after the second talk. So Ashish will have two talks, and all your questions will be answered later. So it's to the chairpersons, please. Thank you.
Good afternoon. Today's topic is under rapid action insulin, how to do glycemic control, and this will be said by Dr. Ashish Gibson. No introduction about him, no need of introduction. So let's start.
Thank you, Dr. Saurabh, for your kind introduction. So, respected chairperson, now the topic is insulin. So, in the morning time, we have discussed that in the case of the type 2 diabetes mellitus patient, when the metformin after the lifestyle and exercise the metformin, and then we have described the empalina combination. So, after metformin, empalina combination, still patient's HbA1c is more than 8.5. So how many of you are going to start insulin in this patient? And how many of you are in the opinion of adding sulfonylurea or Voglibos, acarbose, pioglitazone? So what is the rationale of starting the insulin therapy? As you know that there is an increasing prevalence of the diabetes mellitus in India. Now it is near about the 140 million diabetes. So when to initiate the basal insulin therapy? So that is the most important. So why we are using the basal insulin? So earlier we used the mixture, there is a premixed insulin, right? So if you use the premixed insulin, that is somewhat not physiological. There will be lots of ups and downs. What we call like the glycemic variability. So so the rationale of starting basal insulin to fix the fasting sugar fast. So to fix the fasting sugar fast, at least 40 to 50% patients. So automatically the post-prandial or post-meal uh, glycemic surge will be reduced. So that is the rationale. So additionally, practitioners have reserved insulin therapy at the end of they are using 3 OHA, 4 OHA, like that. But in the reality, so if you are using 3 potent oral hypoglycemic agent in their maximal tolerated dose, so there is no point of wasting time by adding fourth drug, fourth medicine, fifth medicine, or fifth oral OHA. So straight away, so after the 3 oral hypoglycemic agents, patient fasting blood sugar is high. Straight away add basal insulin at the bedtime with the idea that you have to fix the fasting sugar fast, right? So So when to start insulin, there is sign for already inadequacy. So you are using 3 oral drug at the maximum dose, still HbA1c is high. Significant insulinopenia. Sometimes in case of the uh, beginning of the type 2 diabetes patient, fasting and the postprandial plasma glucose and HbA1c is pretty high. So that time we use insulin temporarily to reduce the glucotoxicity. And sometimes patient has hyperglycemic syndrome, that is polyuria, polydipsia, and there is significant weight loss. So in these subsets of patients, you should not use the SGLT2 inhibitor or other drugs steroid. You start insulin, freeze the sugar, and automatically the beta cell function will begin. And HbA1c is consistently above the individual target, say around HbA1c is more than 7 in spite of getting 3 or 4 molecules. And the duration of the diabetes is more than 5 years. So natural history of the type 2 diabetes makes us is progressive decline of the beta cell. So at some point of time, it depends upon the how aggressively the patient has controlled his diabetes. It may be 5 years, 10 years, or 15 years. So at some point of time, patient may require insulin therapy, and the basal insulin is the best. So we have described so when we consider insulin in a partial type 2 diabetes mellitus, we have described instead of giving the three molecules, oral drugs, and sometimes there is significant side effects of the oral drugs, like you know that the GLPs may have some pancreatic side effects. So and SGLT2 inhibitors and the generalized colitis or general GTI or UTI in case of the so patients have side effects with the oral drugs or patients have hypoglycemia with the sulfonylurea. So in those patients, you can stop all the oral molecules and very well start with the insulin, basal insulin at the bedtime. Advanced hepatic or kidney disease. So if the patient is suffering from the advanced kidney disease, the CKD 3, 4, or 5, so there is basically insulin is a recommended therapy. Similarly, if patient has a CLD, chronic liver disease, so insulin is the best molecule. Special consideration, like the patient is getting steroids for some treatment of the chemotherapy, or patient is getting steroid for arthritis and the rheumatoid arthritis, and the steroid induced hyperglycemia. So insulin is the only recommended agent. Hyperglycemia is a hospitalized patient. So patient was getting oral molecules, but patient is admitted for the hospital for pneumonia or CVA. So in case of those patients, so insulin is recommended. And presence of severe hyperglycemia. So patient with blood sugar is more than 300. So that time insulin is recommended. So what is the need for early and timely insulin initiation? So type 2 diabetes mellitus is a progressive disease and insulin deficiency. So no oral therapy can alter the natural course of the disease. Poor glycemic control is an important driver of both microvascular and the macrovascular complication. And early insulin therapy is physiologically intelligent, will provide the long-term benefit in respect of the both micro and macrovascular complications. So these are the recommendations. I'm not going into details. So early insulin therapy overcomes the beta cell exhaustion. So natural history of the type 2 diabetes is progressive decline of the beta cell mass. So if you initiate insulin at the early stage, so there will be less exhaustion of the beta cell. So at certain point of time, beta cell can regain its function. So that time you can withdraw. It is not a, it is basically a need for the both patients and relatives that once we start insulin, it is for the lifelong. It is not true. So once you are using insulin to reduce the exhaustion of the blood cells, so once blood cells regain its function, you can restart oral drug. So what is the benefits of the timely insulin initiation? So HbA1c will be decreased by more than 1%. Diabetes related death will be decreased by the 21%. Atherosclerotic cardiovascular disease in the form of the myocardial infarction or HCS will be decreased by the 14%. And most importantly, the microvascular complications will be reduced by 37%. So these are what defined as the insulin. So what so we basically use basal insulin at the bedtime. There are basically two types of basal insulin. The fast rise of basal insulin, like the LPH insulin or gargling into 100. And there is second class of insulin, that is the insulin gargling to 300 and insulin degradation. What is the difference between the past generation and the second generation? There is a two distinct difference. So duration of action of the past generation insulin is low, it is around 14 to 16 hours, 16 hours, and chance of the hypoglycemia is high in case of the past generation insulin. And second generation of insulin, the duration of action is more, it is 24 to 48 hours. So that's why if you use the second generation of insulin at bedtime, so it is possible to control both fasting and the postprandial but because with one shot, and chances of the hypoglycemia, particularly nocturnal hypoglycemia, is very less. So when you initiate a message, so there are basically different type of insulin like biphasic insulin, mixed premix insulin, and the basal insulin. So listen, insulin is a chance of less hypoglycemia and a better control of the fasting glucose and less body weight gain and less fluctuation of the blood glucose, that means the glycemic variability is less in case of the basal insulin in comparison to the premix insulin. So look at this side. Basically, that downward is the normal, and the patient with the type 2 diabetes mellitus the blood sugar is high, both at the fasting and the post-meal blood sugar is high. So when we are using the resolution at the bedtime, the hyperglycemia is decreased. So the rule is fix the fasting sugar task. Now, how to initiate and optimize the resolution? There are basically different guidelines. So all the guidelines say basically the premix insulin is not used nowadays. So start with the basal insulin at the bedtime. There is a convenience of dosing. So you need not use the injection before the meal. So that is the beauty of the basal insulin. Safety and efficacy. It is more efficacious than premix insulin, and chance of the hypoglycemia is less. So that's why all the bodies like the ADA, ESD, or Indian guidelines, RSCCI, Canadian guidelines, all guidelines say whether basal insulin should be the starting insulin in case of the type 2 diabetes. So this is the algorithm of management of the type 2 diabetes mellitus according to the ADA guidelines. So consider insulin as a fast injectable when the HbA1c is more than 11 or fasting plasma is more than 300. There is ongoing catabolic the patient is suffering from the weight loss, polyuria, polydipsia, and other symptoms of the hyperglycemia means presence of patient is complete with the fatigue or patient has diabetic fetal cell or diabetic polyuropathy. So you need to reduce the HbA1c very fast. So start with the basal insulin. You can combine the basal insulin when the patients with the GLP-1 receptor agonist are not controlled by the GLP-1 RA alone. So you can combine GLP-1 RA and the basal insulin at a defined time or with the same spot. So how to this is the Indian guidelines how to initiate the basal insulin when the HbA1c is more than 8. So start with the 0.2 to 0.3 unit per kg body weight. So suppose patient HbA1c is more than 8, patient's body weight is 70 kg. So start with the 21 unit at the bedtime. When the HbA1c is less than 8, start with the 0.1 to 0.2, that is 10 unit or 14 unit at bedtime. So goal, the fasting partner goal is basically 90 to 130. So the fasting partner goal is more than 180 at 4 units, is 140 to 180 at 2 units, and one is 110 to 139 at over 1 unit. And if the patient is suffering from the hypoglycemia, when the fasting goal is less than 70, reduce the dose by 10 to 20%. So this is a basically titration guidelines. So why the gardening is superior to NPH? Because the glycemic control is a much wider. So 24 hours glycemic control and chance of the hypoglycemia is less in case of the gardening in comparison to the NPH. So why we are not using all the guidelines recommended the basal insulin, starting from the basal insulin and the basal. So if you use the earlier we used to basically the previous insulin. So if you would consider the HbA1c reducing capacity. So one sort of the insulin glargine at bedtime versus the twice daily previous. You see, the HbA1c reducing capacity of glargine in one is 1.6% and HbA1c reducing capacity of previous insulin is 1.3% with the two sorts at the defined time. And Borderline symptomatic hypoglycemia is lesser, much lesser with the bar diagram is much lesser in terms of the insulin glargine in compared to the previous insulin. So that's why all the bodies, including the Indian guidelines, recommended the basal insulin at the starting insulin is the starting insulin at the insulin when patient is not at his target, he's in spite of getting the key drug. So what is the key difference between the clinics and insulin? So clinics basically more than one injection per day, higher insulin dose is required. Needs need adjusted with the meals and exercise and associated with the more weight gain and the hypoglycemia. But the insulin glargine when is the insulin more commonly lower insulin dose required. Less inherent because it is pushing insulin at bedtime and less chance of the hypoglycemia and weight gain because of the previous insulin. So I'm not going to the this is the basically reading phobias the patient has seen. Now the most important thing is administering the injection. So sometimes so patient has a misconception that when patient is pushing that pen, so to hold that pen after pushing for 10 seconds. So if you don't hold that pen for the 10 seconds, the calculated dose may not be administered. So that is basically most important point. So this is basically how to administer the injection. You all know. So we have listed this. So this is the most important. Hold for 10 seconds after pushing the insulin pen. So count 0 to 10 like that. So once taking at bedtime, as students will take to 4 seconds. Another mistake is the insulin cannot be kept in the deep freeze. And once without that insulin and put in the pen, so pen should be kept in the room temperature, not inside the fridge. So that is a very basically mistake. So to conclude, early insulin initiation reduce the glucose effect of the hyperglycemia. The guideline recommends initiating basal insulin in the symptomatic patients with the HbA1c among the individual target and timely basal insulin dose titration is important to overcome the inertia. Thank you.
Any questions from audience? Start next topic. Ashish. Start next.
So we have discussed the basal insulin to control the fasting plasma glucose, and if you are using the second generation basal insulin, you can jolly well control both fasting and post-prandial plasma glucose. But as you know, that the Indian diet are predominantly carbohydrate rich. So after controlling the fasting plasma glucose, sometimes the post breakfast or post lunch blood glucose is high. So what to do in those patients? So there is basically basal plus approach like the basal insulin at bedtime and plus means administering a pre-meal insulin before your major meals. No, most of the Indians are lunch is a major meal and sometimes particularly in the those patients who are not very much adhere to the diet. So you may need to push three previous insulin. That is before breakfast, before lunch, and before dinner. Right. So that is called the basal bolus. So we have discussed the basal part. Now what is the bolus part? So what is the ideal bolus insulin regime? So what is the postprandial pathology? Basically, there is a basically gaps in the postprandial pathology. Sometimes you will see that your patient the postprandial pathology is normal, postprandial pathology is 2 hours postprandial pathology normal, but patient's HB1C is high. So what's going on with these patients? So you are not calculating the 1 hour pathology. So sometimes the 1 hour pathology was very high. So HB1C is counting that 1 hour high performance. Right. This is the gap between the postprandial performance and management. So what are the available insulin for pre-meal insulin? So basically there are ultra rapid acting bistro. It is basically modified version of the bistro. So if you consider the physiological insulin release from the pancreatic beta cell, there is basically the first phase is basically 0 to 10 minutes, and there is a prolonged phase. So when a patient of the type 2 diabetes mellitus is diagnosed, and after 10 to 15 years of therapy with the oral drugs, there is a progressive loss of the first phase of the insulin. So postprandial plasmapheresis, so it may be 2 hours postprandial plasmapheresis, it may be 1 hour postprandial plasmapheresis, is a strongly correlate with the HB1C and contribute significantly to overall control of the diabetes. And inadequately controlled postprandial plasmapheresis may be associated with the diabetes-related complication like the microvascular complication in the form of the diabetic retinopathy, diabetic neuropathy, and and the diabetic eye disease, and also macrovascular disease like the atherosclerotic cardiovascular disease, and also the heart failure. So you need to control both fasting plasma glucose, postprandial plasma glucose, and HbA1c. So what is the importance of the postprandial plasma glucose? Is the expert opinion for the India. So postprandial plasma glucose control the HbA1c throughout the HbA1c spectrum in the Asian patients, including the Western patients, because their diet is basically protein rich, but the Indian diet is basically the carbohydrate rich. So contribution from the postprandial pathology is much higher towards the HbA1c compared to our Western counterpart. So we need a significant strategy to control both fasting and the postprandial pathology. Not 2 hours, both 1 hour and 2 hour postprandial pathology to bring down the HbA1c to the 7. So the importance of the alcohol, which we have already discussed, is the fast phase insulin release from the 0 to 10 minutes. So this is basically loss early, followed by the steady, and longer lasting the second phase. So earlier insulin, like the human activity or regular insulin, so they cannot counteract this fast phase insulin release. So loss of the fast phase insulin release is not addressed by the earlier insulin, is the fast insulin, that is the human activity or disco like that. So how to address this fast phase insulin release? Because if you consider the 1 hour postprandial pathology, so you need to address this fast phase insulin release. So, so pattern of the post-peak glucose rise is a healthy individual. If you consider the pattern of the post-peak glucose rise in a healthy individual, we have to focus on the first hour postprandial pathology. So it depends. So normally it depends between the 70 to 100 milligram per day, and rarely exceeds 140, and usually equal to the pre-candidate levels after 2 to 3 hours. So this is for the healthy pattern. But yes, CGM study in the diabetes patient showed that the mean peak time after breakfast was 73, which was reached in less than 90 minutes in 80% of cases. A recent ITF research effort has highlighted that one of the postnatal parameters has a superior parameter for predicting diabetes and diabetes complications. So, what is the mean gap and it is variation of the postnatal pathology control? So, this is basically the breakfast, lunch, and dinner. So, determinedly, we control the baseline of fasting glycemic and the rapid insulin burst will control the post-peak pathology. Now, injection means interval for the pancreas insulin growth. So, the earlier regular insulin, they are using 30 minutes before meal. So, sometimes patients forget to take meal after using insulin, and there is a chance of the hypoglycemia. And when there is a maximum blood glucose, the insulin level is low. And when the insulin level is high in the blood, so the blood sugar is low. So there is a discrepancy, but it is an insulin mismatch. So the optimal time to administer rapid insulin is a 15 to 20 minutes before meal. So that is the idea. Now the injection and the meal interval in the real world setting. So this is basically multinational online survey of adult patients with type 1 diabetes, and this has meal time insulin dosing and the impact of the meal dosing 15 to 20 minutes before a meal. So 82% female insulin negatively affect the patient's lifestyle. Right. So 19% patient did not eat out at least once a week due to uncertainty about the bolus insulin requirement, and 91% patients worry about the postprandial pathology after eating to some extent. So female dosing was an extra burden for their patients, and the female dosing negatively affect the emotional well-being of the patients. So what is the injection interval? So there basically four times 21% takes a cereal meals before the meal. 44% use the insulin immediately before meal. 10% use insulin during the meal, and 24% like to use the insulin after meal. So most patients need to insulin need to put insulin either immediately before meals or after meals. Right. So these are basically gaps in the postprandial pathology management. So as you know that if you are using insulin too early or too late, there is basically glycemic variability will be high, and the onset of action does not match with the carbohydrate absorption. In case of the earlier insulin, that is the regular insulin, and PKPD does not mimic the physiological post-insulin secretion pattern for any subject to use the regular insulin. So why these ultra fast acting insulin are preferred over the regular insulin? The rapidly acting insulin preferred over the regular insulin due to lesser risk of the hypoglycemia and greater mealtime flexibility. But ultra fast acting insulin, like the ultra fast acting disco, closely mimic the physiological mealtime insulin secretion in comparison to the rapid acting insulin, and ultra fast acting insulin is better suited for the Indian patients with the high postprandial pathology because they will address the both the first phase and the second phase of the insulin loss. So what is the expectation of the newer prandial insulin? So it should be pushed very close to meal, either immediately before meal or immediately after meal, provide the closest physiological glucose control, and ease the patient's burden for allowing dosing as per the patient's own convenience and increase patient time in it. So, what is the difference between the ultra rapid acting disco from the regular disco? Basically, there is a
Ashish, we are running out of time. Please.
So cycle and the technology will direct the local vascularization without the systemic vascularization to increase absorption, and there will be ability of the and delayed. So So what is the difference of the performance from the alternative versus disco? So observation of the alternative disco was going to be exposed those minutes faster than disco. And during the last 30 minutes, post those alternative disco is 3-4 beta glucose was taken from the disco and the minimal glycemic variability and also the chance of the hypoglycemic is and then we can include the fast forward to the injection. So these are the phase 3 starting with the disco is a result plus regime. So alternative disco is compared to the disco. So this basically result is similar. So alternative disco was born here to disco. So what is the difference between the postprandial participation? So postprandial participation is lesser because of the alternative disco. So that is the beauty of this protocol. There is no difference in the hypoglycemia between the disco and alternative disco. So adverse side so adverse has more normalization. So the key takeaways are alternate disco was non-inferior to disco for the age towards just over a period of 26 weeks of treatment, and alternate disco significantly was the postprandial participation, particularly the half hour postprandial participation. There was no significant difference of the clinically relevant side effects on the safety profile and overall prevalence of the adverse events similar both the. Thank you.
Okay, thank you. This is the end of the session. Question will be discussed at lunchtime.
Thank you so much. Thanks for the session. May I request Dr. Kaushik Sen to please come and felicitate Dr. Ashish Mitro and our two chairpersons, Dr. Saurabh Manna and Dr. Indrajit Saha. Thank you, Indro, Saurabh, and obviously Ashish. Now we quickly move on to the next session. It will be on infections. Okay, so approach to treatment of persistent gram-positive infection. We have our esteemed speaker, Dr. Shomendranath Haldar. Dr. Haldar, I saw you here, right here. Dr. Shomendranath Haldar will be talking on this, and we have our chairpersons, Dr. Partha Bhattacharya, will be chairing the session along with Dr. Vivekananda Bera.
afternoon to all respected persons here. And special thanks to Karma sir for giving me the opportunity and the organizing committee. Approach to treatment of persistent gram-positive infection. So we'll be talking very few clinical scenarios where the infection is persisting or there is chances of the infection to be persistent. Most of the times we deal with the gram-negative infections in ICUs, in wards, very complicated equipment patient. I think respected professor's talk is there after that, gram-negative infections. So mainly the complicated gram-positive infections usually we deal in our daily activities are osteomyelitis, prosthetic joint infection, bloodstream infection, infective enterocolitis. In the evening, I think my talk is there on osteomyelitis. So, prosthetic joint infection, bloodstream infection, and infective enterocolitis. These are the three clinical scenarios. But if I want to discuss all these three things, it's not possible. So, I will give you some ideas. What should be the approach for treating these kind of complicated infections? So basically, what are the difficult to treat gram-positive infections? In our clinical practice, these three organisms are difficult to treat organisms. One is MRSA, methicillin resistant staph aureus. How we detect MRSA? By cefoxitin screen, we usually detect it as MRSA. Vancomycin resistant enterococcus. There are two species clinically relevant, enterococcus faecium and enterococcus faecalis. Vancomycin is a very effective drug and most trusted drug for treating enterococcus. But if there is vancomycin resistance, then there will be some problem. C. diff infections, first thing is clinical correlation. Never send a sample of for C. diff infection before 72 hours of hospital admission, or if the patient is having some loose motions on day 2 or day 3, don't send it because most of the times it is antibiotic associated. So, sending sample is more important than interpretation of a microbiological report. Always try to send the ideal clinical sample. And source control is very important because there is evidence that if the patient is having some abscess, it's very difficult to completely eradicate the thing without doing the abscess drainage. So these things has to be considered very critically. I will be talking a few words about certain new drugs which is upcoming and we are usually using like dalbavancin, prednisolone, levothyroxine, because it is not possible to cover everything within this very short span of time. This is a very important trial. This is the DOTS trial. So here, see, the dalbavancin was used versus standard of care. Induction antibiotic therapy was done. After that, for persistent gram-positive infections, standard of care is 4 to 8 weeks versus dalbavancin 2 doses, first on day 1, second on day 8. What is standard of care? Standard of care is for vancomycin. Standard of care is if it is vanco-sensitive, then vancomycin. If it is vanco-resistant, then you may use daptomycin. If it is sensitive, linezolid. If it is sensitive, so according to standard of care, primary endpoint was determined at 70 days and 180 days. But see, as I am using this data of the DOTS trial, we should know which patient was excluded from the trial because evidence for this subgroup of population is very less as these patients were excluded from the trial. So if you are having this kind of clinical scenario, you should be very cautious. CNS infection, right-sided endocarditis, most of the time we use for right-sided endocarditis. Presence of prosthetic joint and nerve hepatitis insufficiency, immunocompromised state, so if these kind of scenarios are there,
try to avoid the and in George's trial, they used criteria for desirability of outcome ranking. So not only the eradication of fungus, they have included everything: clinical success, infectious complications in a remote site, safety complications, mortality, and quality of life. And it was Dalbavancin was not superior to standard of care, but it was not inferior. Most striking part was the compliance. Very few patients will be very willing to take 4 to 8 weeks of IV antibiotic. So if we are giving just 2 doses, it is sufficient. But you should choose the patient right. Take is only few data that it is approved for skin and soft tissue infections with susceptible strains of MSSA, MRSA, streptobiotics, and its efficacy in the setting of neutropenia is not well established. So you should know when to use, but it's better to know when you should not use. So in the background of neutropenia, try to avoid it. Oral IV dose system, side effects are hematologic toxicity, lactic acid, painful and optic neuralgia. Resistance mechanism is 23S RNA, foreign mutation. And another resistance mutation it shares with linezolid is CFR mutation. And the advantage is it may demonstrate activity while CFR mutation linezolid resistance is there. So in very few cases, tedizolid may be effective in presence of linezolid resistance. This is a trial where basically it was restricted to skin and soft tissue infection. Now we are upgrading it to treatment of hospital acquired bronchial ventilator associated bronchitis. So here it was a randomized double-blinded non-clinical trial. Here the tedizolid was used versus linezolid. Primary endpoint was 28-day worth of mortality, and the mortality was 28.1% versus 26.4%. And clinical response at the end of treatment was 56%. So tedizolid is comparable for mortality, but not for POC clinical care. So it is comparable for cases of LITs or bone asymptomatic infection. Comparison with linezolid for skin infection dose is the non-inferior to linezolid. Drug-related side effects are less. So you know linezolid is a notorious drug for mitochondrial toxicities. But tedizolid is to some extent the intensity of the bone marrow suppression or mitochondrial toxicity is less. And it is a useful option for VRE strains even with linezolid resistance. No post-marketing cases of liver-induced lactic acidosis till date. Levothyroxine, it is also it is not a very new drug. 4 to 5 years back in Kolkata, it started use. It is active against gram-positive bacteria, flu gram. Spectrum of levothyroxine is wide. Mostly it is validated for MRSA, where the treatment options are limited, like a patient who is having CLD or CKD, where there is more chances of lactic acidity, there where you are not able to use the linezolid or tedizolid like drugs. At that clinical scenario, it is a rather simple. Effective in multiple antibiotic exposed patients. Like in our ICU, usually we see experience that the patient initially was followed by European so many exposed drugs, and after that patient developed the infection with MRSA like that. So at that point of time, the efficacy of levothyroxine in this subgroup of population is good. It is approved for infections. There are case reports where it is also effective against respiratory tract infections. But for complicated gram-negative infections and for complicated persistent gram-positive infections, need more RCTs to be validated as a very good effective treatment options for gram-positive infections. It is incorporated in CSI guidelines for MRSA and vancomycin resistant enterococci.
post-market surveillance data to be strengthened for this one. So these are the newer drugs, and if I go through by the chart, see, Orithavancin is effective against the all complicated gram-positive infections like prednisolone and umadacycline. Very ceftibuten, dalbavancin, and delafloxacin is not a very effective tool of treatment. So I will show you two charts. One is Enterococcus pyogenes, ampicillin sensitive. So what will be the drug of choice? Never use vancomycin if the strain is sensitive to ampicillin. So the treatment should be either ampicillin, or if it is complicated, resistance size is big, patient is sick, you may use combination of therapy. Options are gentamicin versus ceftriaxone. So ampicillin plus either ceftriaxone or gentamicin. This is an Enterococcus species, but this is ampicillin resistant. And here you see linezolid is sensitive. So if you are getting, this is VRE, vancomycin resistant. So if you are getting this kind of patients, you may use linezolid. Other options are daptomycin, but you should remember daptomycin is having some inactivity in the lung tissue. So if there is dislodge of septic emboli, or if there is an evidence of lung infection, type 2 pneumocytes secreted surfactants inactivates daptomycin. So its role is limited. Enterococcus PCM, this is definitely is an organism for complicated gram-positive infections. Mainly the resistance mechanism is to PPP5, vancomycin or dapto plus aminoglycoside for endocarditis is a good option. Aminoglycoside resistant case, daptomycin plus ampicillin plus ceftriaxone. So you have got a patient who is vanco resistant, you have started daptomycin, but the clinical response is not very good. So you can combine dapto with ceftriaxone. Very few cases we have used with good clinical response. De-escalation or reduction of antibiotics should be considered in a patient. Sorry. So for gram-positive infections, HIC should be followed in CTP infection. CTP is also a gram-positive infection. I will discuss one time later. Drug interactions to be considered in polypharmacy. Yeah. So this is a chart. So a patient clinical scenario is having diarrhea after 5 or 6 days of hospital admission. You have used broad spectrum antibiotics, maybe meropenem, maybe ceftriaxone, and patient developed diarrhea. So probably it is an antibiotic as well. So in these particular cases, you should send stool sample for both GDH and CD proxy. If both is positive, then it's a case of CD proxy. So what are the antibiotics which has the propensity for causing antibiotic associated diarrhea? So these are the causes frequently associated with these antibiotics. Occasionally these rarely associated with these antibiotics. So there is question of de-escalation of antibiotics if you are getting a patient with CD poison. Treatment options are fluid, pyridoxamycin not available in India. Vanco, metronidazole, combination therapy sometimes needed in very severe cases, specifically if it is having some toxic megacolon. Monoclonal antibodies, bezlotoxumab, not available in India. FMT, some institutes are using experimentally, some institutes are using but the problem is getting the ideal stool specimen to be used as FMT. That is very important thing. There are some criteria. Which stool sample is fulfilling the criteria to be implanted as FMT? So to conclude, specialized infection needs longer duration of therapy. Newer drugs to be used in proper clinical scenario, knowing that where it is contraindicated and what is the ideal clinical scenario where it has to be used. Prednisolone, dalbavancin, and pneumonatic properties should be utilized with their advantages. Like advantage of dalbavancin is only twice the dose. Pneumonatic properties usually renal friendly, hepatic friendly. Source control is needed in addition to antibiotics. Repeat culture to be sent for Staph bacteria. This is very important. If you are dealing a patient with a Staph aureus, send the repeat sample after 48 to 72 hours. Duration of antibiotic therapy should be 15 days after the first culture negative result, not the first culture positive. Combination of antibiotics. You know the gram-positive organisms sometimes form biofilms. Biofilms hinders the antibiotic to be reached to the organism. So you may use some drugs which is having some anti-biofilm activity. Like if a patient is having some prosthetic devices, having Staph aureus bacteria, prosthetic heart valve like that, prosthetic joint infection, you may use rifampicin as an adjuvant therapy with the antimicrobial therapy of Staph aureus to prevent the biofilm formation and for better clinical response. Thank you for patience.
Any question from audience? Thank you, Dr. Hazza, for your excellent speech. Now I would like to request Dr. Tibor Bandopadhyay to please come and felicitate Dr. Haldar and our chairpersons, Dr. Bhattacharya and Dr. Vera. Thank you. Cameraman is coming. Just bear with us a minute. Okay, yeah. Tibor, please felicitate Dr. Haldar. And now the chairpersons, Dr. Bhattacharya. And Dr. Vera. If you would kindly take a picture with Dr. Haldar. Thank you so much for great presentation. Right, so it's our honor and privilege. We have a distinguished Dr. Subhash Kumar Todi with us here. A round of applause, please, for Dr. Todi for kindly agreeing to come to our conference and talk to us on newer antibiotics in the horizon. To chair the sessions, we also have two distinguished people, Dr. S.N. Sarvadikari sir and our beloved Dr. Somoresh Gupta sir. So they will be chairing the session. Over to you, sir. Thank you.
Thank you, Dr. Todi. Please, you can start your speech.
Thank you, Santula. Okay, so a lot has been spoken about gram positive. I will concentrate mostly on gram negative. Most of the antibiotics that I will be talking about are available in the market. Many of you might not be aware of these antibiotics, but they are available. And some of them are life-saving. So it's very important you keep a note of this. This is a list given by Department of Health, Indian government. These are the bacteria, these are the killer bacteria which we should be aware of. Carba-resistant Klebsiella, carba-resistant E. coli, Acinetobacter and Pseudomonas, and staphylococcal resistance. You see, this is the map of India. You know, apart from cricket, I think this is where we are leading the world, unfortunately. E. coli resistant to cephalosporin. Ceftriaxone is not going to work against E. coli. 67%. This is all India. 67% of E. coli are resistant. So taxing O and all of these are not going to work. Klebsiella resistant to carbapenem. 50%. 50% of the time, if I prescribe meropenem, Klebsiella is not going to improve. Acinetobacter, 70%, even 80%. It's not going to get better. So one gets an Acinetobacter infection, it's like a death certificate. So that's the biggest problem we are facing. This is the ICMR data, 88% carba resistant. You see, bacteria are much more smarter than what we are. The most of the game is played in this periplasmic space by what is called beta-lactamase enzymes. They break down almost all the beta-lactam antibiotics. So these are the four enzymes. So how do we know which enzyme does the bacteria carry? If it is cephalosporin resistant and pictase and carba sensitive, this enzyme is ESBL. It's very important to know because there are some antibiotics I will be mentioning which are ESBL. Oxa 48, cephaloresistant, carba resistant. But ceftazidime, which is a newer antibiotic, it is still sensitive. NBL or New Delhi metallo-beta lactamases. They are resistant to cephalo, resistant to carba, even resistant to ceftazidime. They are only sensitive to aztreonate. And MC is sensitive to cefepime. So it's very important. These are the four basic mechanisms. And in our carba resistant, one third is oxa is sensitive to cefepime. One third. So it's very important. These are the four basic mechanisms. And in these figures. Now, if I get a patient with urinary tract infection, bloodstream, very sick patient with ESBL, should I give piperacillin tazobactam or should I give meropenem? Both are sensitive. This bacteria, both these antibiotics will work. But you see, this trial had shown if you give piperacillin tazobactam, the mortality is much, much higher. So even if it is sensitive, meropenem is better than piperacillin tazobactam because of certain enzymes this bacteria carry. So even if I get a patient with say E. coli, which is sensitive to piptase and meropenem, meropenem is a better choice. So shall I treat all my patients of E. coli infection with meropenem? That's a huge load of meropenem. That's why this antibiotic has come. It is available in the market. It is better than piperacillin tazobactam and cefepime N-metazobactam. It is works against ESBL, so it will work against cephalosporin resistant E. coli. So remember, now don't go to meropenem. If somebody has an ESBL, that is cephalosporin resistant, carba sensitive, and piptase sensitive. Piptase is not a good drug. This might be a better choice for these patients. So remember, cefepime N-metazobactam. I have not seen being used so often. Rather, piptase is being used more often. But this is the way in our country to go. There are clinical evidence, there are literature on cefepime N-metazobactam. It has been approved all over the world in European and it's UTI, HAB, VAP, you can give this antibiotics. The next is ceftazidime avibactam. You know, Oxa 48. This ceftazidime avibactam will work against ESBL. It is not going to work against NDM, this red box, and it is not going to work against Acinetobacter. But otherwise, it will work. So remember, if you have a carba-resistant organism, if it is OXA48, ceftazidime will work. So if it is ceftaz sensitive, you should give ceftazidime avibactam. But many of the bacteria carry metallo-beta-lactamase, which is called NDM. Now this is very peculiar. Ceftazidime resistant, aztreonam resistant. But if you combine both this, it becomes sensitive. So that's why this we are nowadays giving a combination of ceftazidime on one hand and aztreonam on another hand. Both has to be given at the same time. So let me know the time. 7 minutes. Okay. So this synergy is very important. So aztreonam will act against NDM, but it is hydrolyzed by ESBL, and that's why avibactam. So ceftazidime avibactam plus aztreonam. This is one of the most commonly used drug combination in ICUs in India. So there are literature on this. It is better than cholesterol and polymyxin, ceftazidime with aztreonam. It doesn't work against acinetobacter. Remember that. But the problem with ceftazidime avibactam and aztreonam, they are different molecules. They have to be given at the same time. They are different compounds. And ceftazidime doesn't have much role. It is the avibactam part along with aztreonam. That's why this molecule now has come into the market called aztreonam avibactam. It is available. It is costly. But if I can decrease the ICU length of stay by giving this antibiotic by 1 day, this will continue the full course of antibiotics. So remember, these are costly antibiotics, but can they remove the patient out of the ICU quicker? If so, then I think we should go for it. So aztreonam avibactam, as you can see, it's green most of the time, except acinetobacter. Doesn't work against Acinetobacter, but otherwise it's a very potent broad spectrum antibiotics, and it is approved by many of the societies. This is a new drug which will come in the market probably in 2 months' time. This is from the Indian pharmaceutical. This is a wonder drug, cefepime zidibactam. It covers everything. It covers all the bacteria. If you look at this, cefepime ZD is not in this list, but this is being approved very soon, and this covers everything. Acinetobacter, Pseudomonas, E. coli, Klebsiella, carba-resistant. So this is going to be a very potent drug. So remember cefepime zidibactam. It is made by Woka. It's going to come very soon. Another drug, cefepime teniborbactam in UTI. Again, a very good drug, teniborbactam. It also works against most of the bugs except Acinetobacter. So this is the problem, Acinetobacter. We see it in our ICU almost every day. What to do if you get an Acinetobacter? Now, these are the antibiotics which are being used for Acinetobacter. The dictum, the guideline is one must use sulbactam. Whatever combination we give for Acinetobacter, sulbactam should be the backbone. We can use it with combination with the other antibiotics. It's very peculiar. Sulbactam acts on what is called penicillin binding protein 3, which is very peculiar to Acinetobacter. So this drug, which is not yet in the market, sulbactam durlobactam, this is the one which is most potent against Acinetobacter. So durlobactam combined with sulbactam, and sulbactam durlobactam combines with penicillin binding protein. So look for this combination. If you get an Acinetobacter, once this come into the market, this is the best drug. And this is the wonder drug. This is the Sudyavanshi of antibiotics. cefiderocol, Fetroza. Why is this horse? This is called Trojan horse. It's a Trojan horse policy. You know, most of the antibiotics, they enter the bacteria through porine channels. And these porine channels get mutated very soon. So antibiotics can't penetrate the bacteria. And you know, bacteria loves iron. So that's why we don't give IV iron in patients who are heavily infected. So this antibiotic uses iron channel to enters the bacteria. Once it enters the bacteria, it dissociates from iron and then kills the bacteria. That's the Trojan horse. That's how it enters the bacterial space. Then it dissociates and then it binds to the penicillin binding protein. You see, cefiderocol is green all throughout. In fact, cefepime zidibacter is almost like this, but acinetobacter, cefepime zidi is not that good. But cefiderocol, it's one of the most potent antibiotic that will be coming very soon. So this is the armamentarium we have for the gram negative. You see, there is so much work being done for ESBL, for New Delhi Metallo, for Oxa, for Acinetobacter, for Pseudomonas. So I think we should be looking out for these antibiotics. As was mentioned, there are two new tetracyclines, omadacycline for pneumonia and eravacycline. These are very good tetracyclines. They work against Acinetobacter. This is available in our market, plazomicin. This is a very peculiar aminoglycoside. It works against penicillin binding protein 3 and NEJM article once daily. I have used it in few patients. Once daily plazomicin in complicated UTI, much better than meropenem. Just once daily, plazomicin, if renal function is not too bad and the length of stay gets shorter, 3-4 days, just one, it can be given at home as well. Once daily plazomicin, you see NEGM much better than carbapenem. So very bad urinary tract infection, think of plazomicin. It's available in the market. So that's on gram negative. So just to wind up on gram positive, this is been covered. I won't dwell much. Just a few words on this levonorephoxacin. It's available in the market, again an Indian product. We should be proud, you know, cefepime, zidibactam, levonorephoxacin, these are cefepime, enmetazobactam. These are the research product of Indian pharmaceuticals, which the world is accepting now. So is levonorephoxacin. It works against DNA gyrase and topoisomerase. Very broad spectrum. Works against almost all the gram positive bacteria. So I will end here and just to remind, bacteria are much more smarter. Whatever new antibiotics we can bring to the market, one day or the other they will become resistant. Thank you very much.
Thank you, Dr. Todi, for the very lucid and informative presentation. We are not having time for questions, so we'll discuss questions during the lunch hour, maybe the felicitation session. Thank you. Thanks a lot, Dr. Todi. I would like to request Dr. Shujoy Kundu to please come and felicitate Dr. Todi and our chairpersons, Dr. Shobhadikari and Dr. Gupta. Thank you. Thank you, Dr. Priyan. Now, Shujoy will felicitate Dr. Chomoresh Gupta. Thank you. Thank you so much. Right. So quickly moving on to the next presentation, I would request Dr. D.P. Bhushan sir to please come up on the stage. And the topic of presentation is osteoporosis and women's health. Dr. D.P. Bhushan sir, and to chair the session, we have Dr. Shorvisha Vishwas Didi, please come, and Dr. Rajat Banerjee. Shorvisha Didi and Rajat, please take up your seats as chairpersons, and request Dr. Bhushan to go ahead with his presentation. Thank you.
Why osteoporosis matters? Because 1 in 3 women more than 50 years develop osteoporotic fracture. Hip fracture lead to mortality and morbidity, and it's a silent disease unless your bone is fractured. Female health. Why gynecologists are central? Menopausal clinics, we do osteoporosis screening. HRT decisions are done in surgical menopause, in nutritional counseling. Early identification of high-risk women is important. So menopause leads to estrogen decline, leading to bone loss, leading to fracture. So bone formation. What is osteoporosis? What is osteoporosis? I'll come here so that I can point it out. See, it starts with a stem cell. Finally, this is your osteoid matrix, and the cell comes and sits. This is the mineralization. Mineralization occurs, the bone is formed. What are the things which are important in forming the bone? All our gynecologist friends, even physicians and others, we end up giving calcium. So it starts with calcium phosphorus, 1:2 ratio. Magnesium is important. It causes cementing of the calcium. Zinc is important. It takes care of vitamin D acting on the cells, and fluoride, iron, copper, manganese, silicon, boron. These all elements are important, and they are very, very important for managing it. And what happens in bone resorption? As we all know, osteoblasts, osteocytes, and osteoclasts. Osteoclasts sit in the house of lacunae, start from the mesenchymal cell through pre-osteoblast to osteoclast, and cathepsin and calcium phosphate, and there is a dent. And this dent keeps on increasing like a tunnel around which the new bone forms. So the risk factor of osteoporosis in women are non-modifiable nutritional factors. Nutrition factor we can change. Medications, the drugs which affect the bone formation, the body composition. Lean females are more prone. So zero figure is slightly dangerous. And others. Lifestyle factors, if you are not doing exercise, sitting on the computer, you are more likely to have osteoporosis with medical conditions. Now, the whole world knows about vitamin D. One simple question from all the audience, including the tea sippers. Sir, how many of you are vitamin D sufficient? Raise your hand. किनका किनका विटामिन डी ठीक है? 1, 2, 3, 4, 5, change? You all have got it measured and you feel that it is okay. आप सबों ने मेजर किया है. The percentage of West Bengal is reflected among the West Bengal doctors also. It is 85 to 90% deficient in West Bengal. And when the doctors, I can't see more than 10% doctors having normal vitamin D. What is the reason? Sunlight. Sir, wonderful answer.
Yes, because the deficient of exposing themselves to sunlight. This is one. They remain in AC room, they remain in car, and there is no exposure.
So it's a lifestyle problem. It is causing vitamin D deficiency. How much sunlight is needed? Sir, anybody? Yes? Daily 10 minutes. With clothes, without clothes, with sunscreen, without sunscreen. Yes, ma'am.
Without sunscreen.
Without sunscreen. Impossible to get in the ladies. With clothes, without clothes. Yes, please.
Factor that is at what time of the day you will get the maximum vitamin D under the ultraviolet rays. And I have found plenty of people not coming to know, but some must be knowing. But I just want to add it. That is 11 to 2 o'clock in the afternoon. That is a particular time when the ultraviolet rays in the Southeast Asia and Asia, it comes, and this is the particular time when you will be getting the maximum level of vitamin B through sunlight.
This is again very important factor. Now, sun exposure. How many of you expose yourself between 11 and 2? So only one person in the whole crowd is exposing himself between 11 and 2 for the ultraviolet B rays, and that too without sunscreen, with good amount of exposure, 25% of the body for 25 minutes. None of you, even if you get vitamin D in the skin, what happens after that? It is converted into cholecalciferol. Cholecalciferol goes in the blood. Now, on this blood, it sits on DBV, vitamin D binding protein. Then it goes to liver, converted to 25 hydroxy, and the vitamin D we measure in the blood. All the friends who have got the vitamin D measure, that is 25 hydroxy. That is the in between. And from 25 hydroxy, it comes out of the liver, goes to the kidney, that is converted to 125 dihydroxy. Then it is the calcitriol which is formed, comes to the intestine, absorbs your calcium, the calcium is taken, and now what happens? This calcium goes and it has a preferential predilection for the blood vessels. जो आप कैल्शियम खाते हैं सीधे जाकर ब्लड में जमा होता है, ब्लड वेसल में. It causes, sir. What happens, sir? What happens if the calcium is absorbed by vitamin D? हम ही जानेंगे. Once the vitamin goes in the blood, what happens? Vitamin D is absorbed from the intestine. There are 3 layers, from the endothelium, the body, then to the basal membrane, then in the blood. After it goes in the blood, where does calcium go? Calcium has a preferential predilection from the blood vessels where it is going to calcify your plaques. Here you need vitamin K2. Vitamin K2 causes decarboxylation and it shifts this calcium from the blood vessels to the bone. I have just written vitamin D, and from sunlight to 125, at every step you need magnesium. Magnesium is the carrier. So if you are low in magnesium, your vitamin D taken is useless. इसीलिए आजकल MGD3 आया है. You take magnesium along with the vitamin D. This is one. Once it is absorbed, then it goes to the cell. What does it do? This vitamin D on the cells. This goes and meets the cell membrane, then inside, and finally changes, does something onto the RNA. I'm not going into the details, I know it. But here, you need zinc. Unless there is zinc, your vitamin D, despite the fact that magnesium has taken you there, it won't act. So you need zinc. And what is VDR? Vitamin D doesn't act on the cell membrane unless it has VDR. 10 years back, the whole world was about 30% of cells of the body are having VDR. Do you know as per 226? 98% of body cells are having VDR, means 98% of cells are needed for survival vitamin D. And that is the reason your vitamin D is low. If your vitamin D is going up, those persons whose vitamin D has gone up, their magnesium goes down because it takes from the reserve to go to that level. So, sir, if you are taking vitamin D, take magnesium, take zinc, and take boron because it increases the half-life of 25-dihydroxycholinephrine. I am telling you in such detail because there is an Indian Orthopedic Association, and last year I was awarded with one oration on vitamin D in the national conference, and the orations are awarded to only 4 persons in the country. But you must know that your vitamin D must accompany all these 4 elements for becoming active, for doing calcification, and for proceeding further. So, if it is high normal, what should be normal vitamin D? Last question about vitamin D. Right, man? For a 70-year-old person, what should be vitamin D? For a 20-year-old man? 20 years is 50, for 70 years to 30. No, reverse. For practical purposes, if it is your wife, if it you are yourself, if it is somebody near and dear to you, remember, vitamin D age is your target level. 70 साल के हैं 70 रखिए विटामिन डी 100 साल का कोई नहीं होता है 100 के ऊपर हाइपरविटामिनोसिस होता है. Keep your vitamin D at your age level, you will never repent. Number 2, if you are fat, then just like me, I will not tell anybody. If you are fat, fat is the test, and the fat will not allow you. So what will happen? Fat will take your vitamin D, so you need more and more and more and more vitamin D. So if you are having no range of vitamin D, despite vitamin D, take care of your fat, take care of your magnesium, take care of your zinc. So why lean women are more prone to osteoporosis? My topic is osteoporosis because they do not have fat, and fat is doing aromatization. It is peripheral estrogen which is taking care of your. For osteoporosis, we do DEXA scan. We all know it. It measures your BMD, bone mineral density, and once you do the DEXA scan, you go for the fracture score. What are the chances of having fracture? Please, 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 if you are more than 45, you are checking your blood sugar, you are checking your BP, you are checking everything. Please check your fracture score. कितना चांस है कि आप बुढ़ापे में बाथरूम में गिरिएगा और टूटेगा? Osteoporosis is of not any significance unless there is a fracture. We know osteoporosis unless there is a fracture. So, early diagnosis, there are so many things we pointed out. There is one thing known as TBS, trabecular bone score, that is more important, and if possible, get your trabecular bone score done. There is a great lab workout, so many tests. All the tests are important. But if you are having anti-osteoporotic drug, then please remember these two P1, NP, and CTX. This is to be taken care of. टाइम हमको 20 मिनट मिला था लेकिन खत्म करते हैं. So, not all the osteoporosis in female is postmenopausal osteoporosis. Red flag should trigger evaluation for the secondary causes, and these are the red flag signs. अगर ये हुआ तो सावधान हो जाओ. All the females above 50, please be careful of all these facts. And the management is number one is lifestyle. As you can see, sunlight, no smoking, walking, good food, and resistance exercises, along with so many drugs. This is bisphosphonate and denosumab, teriparatide and abaloparatide, and romosozumab. These are the newer drugs. We all know about teriparatide. Every second company is coming with teriparatide के साथ 6 महीना भुगवाते रहिए, ठीक हो जाइएगा. Then came the abaloparatide. Abaloparatide, as you can see, its anabolic window is much wider and it is less risky. There has been active trial for this. The trial is known as FDA approved. Then comes a frame study for the romosozumab. I will like to see the G's, denosumab and romosozumab. Sclerostosis, von Buchan disease. Actually, the idea of romosozumab came from this place, the monoclonal antibody. You can see everywhere, just like osteopetrosis or the fluorosis, excessive bone formation is there. Why? Because sclerostin, which is produced by osteocyte, which depresses osteoblast and stimulates osteoclast, is not there. तो खूब बोन बन रहा है, खूब बोन बन रहा है. तो फिर हुआ कि ऐसा मोनोक्लोनल एंटीबॉडी बनाओ जिसमें रोमोसोजुमैब एंड ग्लोसोजुमैब दो आते हैं, and these two will take care of it. So then these two drugs came. Romosozumab is available in India in the name of Evenity in Kolkata. 2 ampoules, 105 milligrams. Take it at 2 places once a month for 1 year. And for the treatment of osteoporosis, you should have sequential therapy. First, increase your bone, then maintain it. Take either teriparatide or abaloparatide, or romosozumab or glosozumab, whatever you have to do. You take estrogen, HRT, you can take relaxifene, you can take fluoride for fluorosis, and then maintain with bisphosphonates or denosumabs. And if you do this, you will probably not repent. There is not something more senolytic therapy. It is antioxidant therapy. There are cells in the body which are important and they are known as CAPs. These cells are taken care of by dasatinib and quercetin, which is a cofactor for the dasatinib. अभी इंडिया में उपलब्ध नहीं है, but the day it comes and the phase 3 trial has been done, I will not find here old ladies or old people. They all will be looking young because these oldness causing cells will be taken care of. And last but not the least, local osteo enhancement. If you have fractured neck femur of left, there are 30% chances your right neck will also fracture. What do you do for that? You take drug when you are happy, you take vitamin D, you are happy, you take calcium, you are happy, or if you are very enterprising, you take P1 entry CTX. Get these things done, and teriparatide or abaloparatide or romosozumab or blasozumab, and you are happy. No, go to other side of the neck, which is totally gone, and there are triphasic calcium biomaterials which you should put in the neck, just like this, and it will incorporate and new bone formation will be there. So surgical rejuvenation is being done in India, and I'm sure Abhik is here. No. तुम करते हो, तुम तो ऐसे जिंदा कर देते हो, काटे वैसे देखने के बाद करेगा, ठीक है. So और कुछ नहीं तो कैसे वहाँ पे सिविल का हो भाई? There's nothing wrong with it. Dr. Bhushan. And fine, last finish. And this one. Forget it. And then a few exercises which I give to my patients. You can do it. And finally, before closing lines, the osteoporosis is a silent disease. You do not know unless it is fractured, bone is fractured, but the maintenance of bone is done by muscle. Please, please, please do not forget sarcopenia. Sarcopenia has no treatment other than high protein diet and exercise. Thank you.
Thank you, Dr. Bhushan, for your excellent presentation. You have not only opened up the audience by audience participation, but has provided a lot of information about a very relevant topic. Thank you very much. I think, does anybody have any questions? I think that's the gist of it. Thank you. Okay, thank you so much for the excellent talk. I would like to request Dr. Sujoy Kundu, no, sorry, Dr. Biplab Dunui, Dr. Biplab Dunui to kindly come and felicitate Dr. Bhushan and our chairperson, please. Thank you. Thank you. Thank you, Dr. Bhushan. Now, Biplab will felicitate Dr. Shobhishta বিশ্বাস and Dr. Rajat Banerjee. A group photo for all. Thank you so much. Great, okay, so that was an excellent talk. Now we quickly move on to next topic. That's the last presentation before our inauguration. Okay, I'd like to request Dr. Taposh Bandyopadhyay to please come on stage and present on cardiovascular kidney metabolic syndrome. And to chair the sessions, we have Dr. Shantanu Mollik and Dr. Chittaranjan Bhattacharya. Shantanu and Chitto, please come and take your seats as chairpersons and request Dr. Bandyopadhyay to proceed. Thank you.
Another please statistics. Thank you so much. First of all, let me thank the organizer and particularly my colleague Dr. Kamla Banerjee, who has given me this opportunity to discuss a very important topic, that is CKM. Probably few of you are physicians here. Mostly, as I assume that there are doctors from all the fraternities, including gynecologists, pediatrician, orthopedician. So I will make my topic as simple as possible and I will finish on time. So probably you have heard about syndromes like cardiopulmonary, cardiorenal, and other syndromes like combination of uh, two organs or more two organs. But this is basically a new concept by the American Heart Association, where the combination of cardiovascular system and kidney function, kidney disease is combined with obesity, which is now a pandemic. As you all know, it affects almost 30 to 50%, 40% of the total world population, and with each increasing year and decade, the number of uh, subjects suffering from obesity and as a consequence diabetes as well as other diseases like kidney disease is increasing proportionately. If you compare 2 decades or 3 decades earlier, the number of dyslipidemia is decreasing nowadays because of the awareness among the physicians as well as the general population, the hypertension being controlled with medications, although it is not up to the mark or as expected, but definitely it is now there is a tremendous amount of awareness among all the doctors, irrespective of the subspecialty. But this particular diabetes and obesity, which is a twin epidemic, that is diabetes, sometimes we call it, is actually affecting a very sizable proportion of individuals, and as a consequence, the organ systems that are being affected are not to ignore, like cardiovascular as well as the renal system. And now, on top of this, other than the cardiovascular or and the kidney, it is now also in uh, now there is a findings that these two diseases, which is associated with insulin resistance and diabetes, is now affecting the kidney. Other than kidney is the liver. So it is now called the CKM8, cardiovascular, kidney, metabolic, and hepatic disease. So I will restrict my talk to CKM. So let me start with a case. A 64-year-old woman, history of type 2 diabetes for 7 years and hypertension. She is fine and not interested in taking more medication. She is on metformin and antihypertensive hydrochlorothiazide. The examination revealed blood pressure of 145/85, BMI of 25, that is obese, other parameters being normal. And the lab value shows EGFR of 45, HbA1c of 8.1, that is poor control, LDL cholesterol 95, triglyceride 100, and urinary albumin creatinine ratio 350. Another case with a 50-year-old man with history of acute myocardial infarction 1 year ago and obese, suffering from heart failure with reduced ejection fraction, preserved ejection fraction, that is more than 55% ejection fraction, on aspirin, atorvastatin, and metoprolol, and the blood pressure is well controlled. He is obese, the BMI being 38, JVP elevated, lungs clear, abdomen soft, but there is edema suggestive of heart failure. And the NT-proBNP is elevated, GFR is 65, that is borderline, or it is normal, more than 60. Glycosylated hemoglobin being normal, the ACR being 150. I will come to the case to these two cases later on. So this is the overview. So what is CKM? It is basically a systemic disorder characterized by interaction of the metabolic risk factors, obesity, diabetes, kidney disease, and cardiovascular disease, leading to multi-organ dysfunction and a high rate of adverse cardiovascular events, which bothers us most. It includes both individual at risk of cardiovascular disease as well as those with existing cardiovascular disease that complicates metabolic disorder. Now we all know that the crux of the main problem is the obesity or ectopic fat, which is associated with insulin resistance due to and leading to hyperglycemia, dyslipidemia, visceral obesity, and metabolic syndrome, causing accelerated CKD and CVD progression. Now, this is the basically the holistic approach of CKD syndrome. And the burden of diabetes and obesity in CKM syndrome is diabetes prevalence is huge, that is 537 million adults globally, projected by 2045, almost 1.5 times, that is 783 million. And the obesity prevalence is more than 650 million adults globally. India is no exception to this and has a diabetic population of more than 77 million. It's second globally, maybe the first after second globally after China. And there is rising central obesity and metabolic syndrome in young adults. That is the most worrisome factor of this particular problem. And obesity related CKD is increasing due to other reasons like kidney problems. So the underlying mechanism is dysfunctional adiposity, stress, oxidative stress, and other factors. I'm not going to the detail. And the main risk factor of CKM is genetics, obesity, then diabetes, dyslipidemia, and the major cause of all these factors are inflamed adipose tissue. So this is the main reason of all these associated problems. I'm not going to the detail of insulin resistance, but just remember that insulin resistance is the key driver of this particular cardiovascular kidney metabolic disease syndrome leading to other problems. And dysfunctional adipose tissue promotes inflammation, and we all know that obesity is basically a disease. It's a basically chronic inflammatory condition, and that leads to endothelial dysfunction, worsening insulin resistance, and its consequences. I'm not going to the detail. Now, what are the stages of CKM syndrome or the cardiovascular kidney metabolic syndrome? Stage 0 is no CKM risk factors are there, and the recommendation is just screening, BMI and waist circumference measurement annually, and HbA1c or fasting glucose every 3 to 5 years. Stage 1 is excess or dysfunctional adiposity. So the recommendation is again like stage 0, except HbA1c more frequent, that is 2 to 3 years. And in this stage, if we lose more than 5% of the body weight, we can revert back to stage 0. So that is the most important part of this discussion. Stage 2 is when there are metabolic risk factors, and metabolic risk factors, what are they? Hypertriglyceridemia, hypertension, metabolic syndrome, diabetes, or association of chronic kidney disease. And the recommendation is what to do as per stage 1 with additional screening for liver fibrosis every 1 to 2 years, urinary albumin creatinine ratio measurement other than serum creatinine, and if possible cystatin C, which is a marker of chronic kidney disease, and consideration of coronary artery calcium or CSC and heart failure screening to rule out any accelerated ASCVD risk factors. Stage 3 is subclinical cardiovascular disease in CKM, and stage 4 is frank cardiovascular disease in the form of heart disease, heart failure, stroke, peripheral artery disease, and atrial fibrillation. So these are the 4-5 things that comes into the consideration of stage 4, that is clinical cardiovascular disease. And what to do? It is same as stage 3, like more frequent albumin creatinine ratio measurement, kidney function measurement, and individualized calcium score, coronary artery calcium score, along with heart failure screening. So these are basically the stages. You can easily appreciate that stage 0, there are no risk factors. So the focus is on primordial preventive, and preserving the cardiovascular health. Stage 1 is excess or dysfunctional adipose tissue, where there is obesity, and just losing 5% of the body weight can actually revert back to your stage 1. This is one extreme pain, and another is the stage 3 and 4, particularly stage 4. And stage 3 is also equally important because it is basically a subclinical state where there is subclinical coronary artery disease, like risk equivalence in CKM stage 3 are very high risk of coronary artery disease as well as chronic kidney disease. That is the stage 4 and 5 of KDIGO-HITMAN. I'm not complicating things. So stage 4 is the clinical cardiovascular disease. That is the extreme. There is heart failure, there may be peripheral arterial disease, there may be atrial fibrillation, and there may be stroke. So what is the importance of knowing all these things? Because if we can catch stage 0 or at least stage 1, you can revert back to stage 0, and in stage 0, it is the prevention, which is definitely prevention, as we all know, is better than cure. This is the algorithm where there is one important thing that I would like to highlight, that when we consider kidney function, we take into account creatinine as well as EGFR, calculating the EGFR from the creatinine. But sometimes what happens, EGFR may be normal. As you can easily see, as you can easily appreciate, if you go to this stage 3A, where there is mild to moderately decreased GFR, and the GFR is 45 to 60. So the GFR is not that much reduced. But if you can easily appreciate, if you appreciate that there is A1, A2, and A3, where there may be milder form, like the ACR is less than 30, GFR is not that much reduced, but if it is A3, that is the GFR is more than 300, and uh, the stage of this GFR is G3A. So at one end you have to be very vigilant, but at the other end you have to take appropriate correctable measure. When the ACR you are testing, it is coming more than 300. So while assessing a patient who is having chronic kidney disease, you must always look for ACR. But not all individuals will have accelerated urinary albumin creatinine ratio. In those cases, you have to take into account the GFR as well. So these are the biomarkers like HbA1c, ApoB, which is a new biomarker, lipoprotein A, and ApoB is a stronger predictor of cardiovascular disease. We need to use them in appropriate clinical setting and without overutilization of this particular biomarker, other than albuminuria. So the management strategy is lifestyle modification, like dietary modification. There is little scope of discussing this dietary, but you have to reduce the salt intake and increase the fiber intake. Exercise for at least 150 minutes of moderate intensity exercise per week, and weight management, that is less than 5% of body weight, can improve your metabolic and the cardiovascular outcome. And if the BMI is more than 40, then we need to consider bariatric surgery, and if it is more than 35, we need to consider medications like GLP-RA, that is semaglutide or tirzepatide. So this is the algorithm. I'm not discussing this. This very busy slide. There is a stage 1, 2, 3 and stage 4. But one thing you must remember, that in contrast to the previous belief that the fragmented approach of dealing with any disease is not there, you have to hit hard and hit fast. So you have to use GDMT or goal directed medical therapy, and you have to use all the medication that is there in the armamentarium, that is the SGLT2 inhibitors, the GLP-RA, and other drugs like mineralocorticoid receptor antagonists, particularly non-steroidal mineralocorticoid antagonists, that is finerenone. So these are the therapeutic advances in the sickle syndrome. These are the 4 drugs, and you have to, if you are not in the field of endocrinology or internal medicine, and if you can assess the patient is having obesity, metabolic syndrome, there is reduced GFR, or there is increase in the albumin creatine ratio, you need to refer to patient, and it is basically a multi-system approach, and uh, basically there may be the role of obesity medicine as well as the dietitian, other than the internist and the endocrinologist. Now, one or two slides regarding finerenone is basically a non-steroidal anti-inflammatory, mineralocorticoid receptor antagonist, and the finerenone. What is finerenone? It blocks mineralocorticoid receptor overactivation pathway. Finerenone targets directly and it has got proven benefit to reduce higher CV as well as renal events by reducing renal fibrosis. It is a non-steroidal, so it has got no side effects like the steroidal mineralocorticoid spironolactone. It blocks selective receptor and there is less severe hyperkalemia. So it is a safer drug than spironolactone. This is the study where Fidelio and Fidelio is the pooled analysis of fidelity shows the consistent benefit in type 2 diabetes as well as the CKD tests. This is the study and this has shown consistent benefits across all CKD stages and across albuminuria levels, moderate to very high, effective in patients on SGLT2 background therapy. So to summarize, early metabolic dysfunction drives chronic kidney disease and cardiovascular disease. Albumin and insulin resistance are crucial early markers. Combination therapy targets multiple CKM pathways. Phenol is a game changer for patients with type 2 diabetes and chronic kidney disease, providing cardiorenal protection beyond glycemic control. And remember that the diabetes and obesity go hand in hand. So the primary aim will be to reduce body weight and to reduce ectopic body fat so that we can prevent development of organ dysfunction including kidney disease, liver dysfunction and particularly the cause of mortality is cardiovascular disease. Thank you so much.
Thank you, Dr. Bandyopadhyay, for your excellent speech. Any questions from the audience? Thank you all. Thank you, Dr. Bandyopadhyay, for your great session. I would like to request Dr. Sumantro Sarkar to please come and felicitate Dr. Taposh Bandyopadhyay and our chairpersons, Dr. Chittaranjan Bhattacharya and Dr. Shantanu Molli. Thank you, Sumantro. Thank you, Dr. Bandyopadhyay. And now, chairpersons, first Dr. Chittaranjan Bhattacharya and Dr. Shantanu Molli. Dr. Bandyopadhyay, please come and have a group photo, please. Thank you. Thank you so much for the talk, and we'll now move on to a very important part of our program today. That's the inauguration program. But before I go there, an important announcement for all. Certificate distribution. People have been asking me, where do I get it? When do I get it? Okay, an important part is to get the certificate and CME points. So the certificates will be available after 3 p.m. from registration desk. Okay, 3 p.m. registration desk. Don't rush to it, all of you. Go one by one in batches. It will be, all there. Don't go all of you at the same time. Next, all of you who have registered, all the delegates and faculties, we have a special gift for you at the counter from ABP One Stop Wedding. Okay, just outside on your left, this ABP One Stop Wedding. You can collect a special gift. All the faculties and delegates. Okay. Next announcement is for all the faculties. You know, the lunch place is a little bit crowded over here, and we are a lot of us here. So the faculties have got a faculty lounge. So the faculties are requested only to go to the faculty lounge for your lunch. Don't rush with everyone else, otherwise it's a bit crowded over here. Okay, so that's all good. Next, let's move on to the important part, the inauguration ceremony part, the lighting of lamp. And we have our dignitaries, our important guests, and hopefully all of you are here. First, I request the president-elect of CNMC Alumni Association. Unfortunately, our president is not well, so he's not coming. We have got our president-elect, our very own, our beloved Dr. Shomoresh Guptu, sir. Shomoresh, please come up on the stage. The president-elect of CNMC Alumni Association. Next, we have our Didi, the Secretary of Alumni Association, Dr. Shormishta Vishwas. Didi, please come and take the stage. Next, may I request the organizing secretary of our 75th reunion, who is also the secretary for the update CME, which is happening today, Dr. Tanmoy Banerjee. Tanmoy has come over there. So a chair, please, if possible, for Dr. Banerjee. Next, we have the chairperson for today's program, chairperson for the update 2026, Dr. Sujoy Kundu. Sujoy, please take up the stage. And now I am honored to introduce you to our own guest of honor for today's program. Our guest of honor and our chief guest is our own Dada Dr. Taposh Chakraborty, sir. Dr. Chakraborty is here as our alumni, and obviously he is the current observer of West Bengal Medical Council. He has come as the capacity of observer, Dr. Chakraborty, and to tell you, he has been the past president of West Bengal Society of Indian Society of Critical Medicine, as well as Indian Society of Anesthetists. So that's your chief guest for us. We are honored to have you, sir, Dr. Taposh Chakraborty. Thank you.
May I request Dr. Umsuman to come on the stage?
Thank you, Sujoy, for asking. One of the ex-secretaries of our Alumni Association, Dr. Shujit Dey, he is with us as well. Thank you, sir, for being with us. And now I'll request all of you to start with Dr. Shomoresh Gupta, our president-elect, sir, Shormishta Dey, our secretary, ma'am, and as well as Taposh Chakraborty, sir, Shujit Dey, sir, and Tanmoy and Sujoy to please come and light up the lamp and inaugurate officially the program. I'd also like to request the members of CNMC Alumni Association, please, all of you, CNMC Alumni Association members, please come.
Extremely
Dr. Kaushik Shur, the treasurer of our PLATINAT reunion organizing team, is lighting the lamp. Thank you. Thank you, all our dignified guests. Thank you for inauguration.
I would request one of our senior alumni members to say something on this occasion. So, Mr.
It's my honor and pleasure to show me this respect in this gathering. So I'm Medico's 70. That means for last 56 years I'm attached to this college and attending all the reunions. So this is our 75th reunion. Will be very colorful reunion. This is our starting point, this CME. So fortunately, I'm the observer of this uh, CME. So I think from the very beginning it has started nicely, and I think it will end nicely. Thank you very much, and I wish all the success of 70th reunion.
Thank you, Tapusda, for your kind words. Please stay on the stage. I would like to request Dr. Rituparna Dotto, please come and felicitate President-elect Dr. Somaresh Guptu. Okay, Rituparna, 1 minute, please. Rituparna, 1 minute, please. I'd like to request our organizing secretary, Dr. Tanmoy Banerjee, would like to say a few words to us. Thank you.
Well, I'd just like to thank everybody who have joined today, all the alumni seniors, and all the students and students of CLMC, our batch and also junior batch, and especially the faculties and the speakers who have taken time out on Sunday to come here and enlighten us with their knowledge and their talk. And it's a very sort of happy occasion for us because this is the beginning of our preparation for the reunion celebrated in 2027. And all through the year, we have made plans for doing few things every month so that the preparation carries on over the year, not only for the only 3 days for the reunion, but all through the out the year. Thank you very much.
First, now I'd like to request our chairperson for the session for the conference, Dr. Sujoy Kundu, to say a few words.
First, my heartiest thanks to all audience present over here, my seniors, my juniors, my friends forever, who came and who spent a valuable time. It's a brain teaser for all of us. The multi-speciality conference we did it, and the foremost thanks, tremendous job by Dr. Tanmoy Banerjee, the organizing secretary of the reunion. Actually, on 2027, 5th, 6th, and 7th Platinum Jubilee reunion, and I request all of you to be present over there for the next gala reunion at 2027, 5, 6, 7. And it will be again a good brain teaser for all of us. It's a good seminar and good workshop will be done on that time. Thanks to all of you present over here again.
Thank you, Sujoy. I'd like to request our Secretary of Alumni Association, Dr. Shormishta Bishas, to say a few words.
Respected dignitaries on and off stage, my dear colleagues, friends, and juniors, I wish you all a very good afternoon. I'm very thankful to the organizers of this multi-speciality conference, the outreach. It starts our 75th reunion, which is going to occur on 5th, 6th, and 7th of February 2027, and I hope everybody will join it with enthusiasm. Already this program update is a resounding success as I can see, but I still wish you a grand success. Thank you.
Thank you, Shormishta. Shomarista, couple of words, please, of encouragement to us and all of us here.
Respected my seniors and my junior colleagues, it's a great effort. This is the first time during our pre-reunion CMEs, this type of conference is being done for the first time. And great applause, great applause from Moy and his enormously hard working team, including Sujoy and Inshu and all of you. And this is a grand start, and I feel that the actual reunion will be a few times more than this, and I expect and wish a grand success of our coming reunion. Thank you.
Thank you. Thank you, Shomarista. I'm absolutely sure it will be a resounding success. Now let's go to the felicitation part. Rituparna, please come and felicitate our President-elect of Alumni Association, Dr. Shoresh Guptu, sir. And I would like to request Dr. Sonali Sain to please come and felicitate Dr. Shobishta Vishwas, the Secretary of Alumni Association. Now I'd like to request Dr. Nirmala Vishwas to please come and felicitate our guest of honor, Dr. Taposh Chakraborty sir. Thank you. Now I'd like to request Dr. Orunima Mukherjee to please come and felicitate Dr. Sujit Kumar De, the past secretary of our Alumni Association and president, as past president as well. Thank you. And he's vice president of our union this year. Thank you. Now I'd like to request Dr. Amina Hawk to please come and felicitate our organizing secretary, Dr. Tanmoy Banerjee. I would like to request Dr. Shantosri Sengupta please come and felicitate the chair of this update CME today, Dr. Sujoy Kundu. Thank you. And I'd like to request Dr. Bani Hemram to please come and felicitate the treasurer, a very important man, treasurer of our Alumni Association, PLATINAT Alumni Organization, Dr. Kaushik Shur. Thank you so much. Okay, yeah, right. A somber announcement. We are just going to put an obituary. Please, Tonmoy. Our friends who were with us, Dr. Sanjay Mittal, Dr. Amitabh Chatterjee, Dr. Arindam Mukherjee, Dr. Kaushik Chatterjee, Dr. Rana Pratap Murmu, Dr. Suryakanto Soren, our dear classmates of batch of 91 whom we have lost, and we all remember the memories that we have, and thank you for standing up, and we give 1 minute silence of a minute, please remember. Thank you. Thank you. Okay. That concludes the inauguration ceremony. Lunch will be served outside in the foyer. Oh. Yeah, I'm saying lunch is served. And we have the national anthem to be played now. Please don't leave. I would like to request you to be here for the national anthem to be played, please.
The session will continue. They can have the lunch, working lunch.
Now we're having the national anthem.
जनगण अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल गंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you so much. As I said, the lunch will be served outside, but the sessions go on. It will be working lunch as we have many sessions to continue.
অডিও সাউন্ডটা কাট না করছে দেখতে পাচ্ছি না তুই দেখছে না কি তো কেটে দিবি তো মানে বসে আছে ওকে বলছি তো আমি কেটে দে
Hello, good afternoon. I would like to request everybody for the next session. Our next session is on recent advances in cardiac pacing and disease investigation. The speaker will be Dr. Dilip Kumar. I would like to invite the chairpersons, Dr. Chandan Mukherjee, Dr. Nitupana Latta, and Dr. Arup Dev. Dr. Nitupana, please. Is Dr. Arup there? Dr. Arup? So Dr. Sonali, will you do like that? I would like to request all the people to take their seat for the next session. I would like to request Dr. Pinaki Datta to come for the session, please, as a chairperson. Pinaki, please. Please proceed.
afternoon, everyone. Let us welcome Dr. Dev Kumar for his talk on leadless pacemaker, ready for the prime time.
Thank you, ma'am. And thanks to Tanmada for having me here. And my best wishes for the the reunion. So this is these are my disclosures. I'm a doctor for all these therapies, and I received grants and honorariums from these companies. And so I'm going to talk briefly about. I will surely make up some time for all of you guys. I will be talking about the advancements in pacemaker and really a decade back, pacing therapy was almost at a kind of stage where it looked static. There's two leads and pacemaker and it's all right, and people are happy with that. And it all started with, you can appreciate, a generator-like structure which used to give electrical pulses to heart. And then there was portable pacemakers, then there was implantable pacemakers, single chamber, dual chamber, AICs, and now we have capsules, small capsules, which can be there implanted in your heart and it will take care of everything. So why we are looking at leadless pacemakers? So pacing therapy, your pacemaker, it essentially gives heart a second chance to beat again. So almost dead patient, pacemaker implant, and he gets a new lease of life. And for last 70, 80 years, two leads were there, but it had some problem. Although it was life giver, but still there was some sort of infections which are happening, hematomas which are happening on the pocket, and with the leads, lead dislodgement, lead malfunction, everything was happening, and these were not less than 5 to 6% it was happening. So we had, a thought that if we can get away with this lead, it is going to be a great help for all of us. So we can get away with infection, hematoma, erosion, cosmetic concerns. Females don't want a kind of device in their, collar below their collarbone, and also we can you remove all lead-related complications like fractures, insulation breaks, and all of a sudden device getting malfunctional. I will show you where the journey started for us. So this was a lady who was mother of one of our staff in Medica, then Medica, now Manipal. And after 6 months of pacemaker, she developed, you can see the swelling hair, and then first started coming out. And she was so restless while the first pacemaker was done. On temporary, the temporary moved out 3, 4 times in the night, and patient had to be given general anesthesia, intubated, only just for having temporary, and tomorrow will go a pacemaker, permanent pacemaker. So this was the kind of, all things happened. So this time I didn't take risk. So my strategy of putting a leadless pacemaker first, followed by removal of every infected device, started from there. So you can see here a leadless capsule I am going to implant. This, the structure which you can see here is a catheter, and finally there is only capsule which is here, which is giving the heart the impulses which it requires. And when I remove all the leads, you can see that the heart doesn't have lead. And from there, to the world. It is from our side that this concept has come to, if you have infection in the device or lead, you can put a leadless pacemaker first and then get rid of leads, because the odds of putting a temporary pacemaker and removing all the leads and going for a reimplantation after 2 days, there can be lead dislodgement, temporary lead, and patient can die. So for dependent patient, and we are, our manuscript is ready, it has been reviewed, and it will be published very soon. This will be our study to the world, that how we deal with lead infection. This is again a patient you can see here, heart is full of leads and wires. So this gentleman had 3 times pacemaker done, both times patient had infection, both sides he had infection. One with lead coming out, one with device coming out. And we extracted all the leads one by one. You can see first we put the device, and then one by one we removed all the leads from the tight rail, from the groin, and then patient was free of infection. And you can see here the smiling face of this octogenarian patient. He was an ex-army person. He could withstand everything. And this gentleman did not have shower. He did not take bath for 1 year because of infection. And once I deployed, removed everything, put a leadless pacemaker. After 16 days, he took shower. He told me, "Sir, I got my new life back." I could take bath after 1 hour, 1 year. I was smelling and everybody, can you imagine the situation? So these are the basic, fundamental difference how leadless pacemaker, changes everything. So these are all examples of cases which we have done, which are unique to the, kind of, unique to the case, experience. And this patient has IVC filter. You can see here the IVC filter, and through IVC filter we have gone in and we have deployed leadless device. You can see I was proctoring this case in Delhi, a very reputed hospital, Kailash Hospital. It was a patient of my teacher, Dr. D.S. Gambhir, and the patient had IVC filter. There was no access from the upper side. Subclavian veins were not present, not patent, and then I had to go through IVC filter and I deployed the device. So leadless pacemakers now, it's not only as a rescue therapy it is looked at. It has got a whole lot of indications. We can go in patients where acute fibrillation requires single chamber, or in patients dual chamber also. Now we can have a implantation because we have got dual chamber leadless pacemaker with us. So the dual chamber pacemaker comes from Abbott's, Abbott company, and is how the leadless journey of Abbott has gone all along from 2009 to 2024, now to 2026. We have got this dual chamber leadless implant available in Calcutta last year, and now I think in India we have around more than 150 dual chamber implants have already been done. So these dual chamber leadless pacemakers come with new catheters and the LPS system. They have got a electrode inside the helix, and these are making the procedure very safe and effective. So we have two devices, one in atrium, one is right ventricle, and there is no circuit, no component, and the leads are not connected, at one place. So device has to communicate. So how they will communicate? One device will send small sub-threshold pulses, and the other device will sense it. Similarly, the other device will also, give small sub-threshold pulses, and other device will come to know. This is called implant to implant, contact. Eye to eye contact is not eye to eye contact. This is implant to implant contact and connection. And this has been validated, and which we have used in our hospital dual chamber pacemakers, and the atrial lead which we place in the right atrial appendage at the base, and the ventricle lead we place at the right ventricle septum. Because this large device, if you go to apex, there can be perforation, and patient can have mortality. So you can see the sheath and the capsule which is there inside the catheter. RV lead has been implanted, capsule has been implanted, and the RA capsule or RALPS lead placing pacing system. We are going and seeing in two projections, RAO, LAO. On fluoro, we can make out this atrial appendage site with the contrast, and then we look at some electrical measurements. If we are satisfied, then we look at the stability by pulling it, and finally we release the device, and you can see two LPS, lead pacing system. They are communicating with each other, and patient is getting dual chamber or AI pacing as per the need. So we have got some problem of concern about longevity, how these two devices, communicating with each other, how much battery is going to be draining. So we can put these patients in a mode called AIR with VVI backup mode. This will increase the longevity of these patients, and maybe 10, 15, 20 years patient can be without any risk of a need of anything, any concern. So there is nothing which will be visible from outside, a small two capsules and the needless pacing system which will work. And also these leadless devices can be retrieved. So we can retrieve these leadless devices with the efficiency of 88 to 99%. So retrieval success rate remain high regardless of implant duration. So irrespective if it is done 5 years, 6 years, 2 years back, we can take out these devices. And finally, these devices are rate responsive, and these devices also have a kind of MRI compatibility. So with this, the information I am stopping here. I hope it was little informative. and I made up some time for all of you. Thank you so much.
Thank you very much, Dr. Kumar, for your excellent presentation. I have one question for you. What are the chances of infection and hemorrhage in these patients?
These devices are very, very immune to infection. Basically, infection mainly we deploy this device and infection doesn't happen. And once we take out the previous leads and previous devices, patients are absolutely fine. So it happens because these capsules and leadless pacing system has a different kind of coating. It doesn't allow the bacteria and bacteria to grow. Second, the flow of blood in the RV is very, very strong, and RA also. So it goes in gush. So the infection doesn't stay there, and also the capsules, especially RV capsule, gets stained epithelium, growing over that. So it covers that. So infection rate is probably an outlier rather than something which is happening 1 to 2% in normal population, normal casemakers. With leadless, it's an outlier, just an exception. If it happens, you are unlucky. I haven't got any infection till now. I proctored more than 100 leadless devices across the country.
Thank you very much, Dr. Kumar.
Thank you, Dr. Kumar. I have one question. So, what is your comment? How come the should lead in the near future? What is the
So
future?
it's already there. It has potential to overcome the existing device already. All the merits are there except one merit, which is the cost. So yeah, once the cost comes down, I think every patient can be given a leadless implant. Yes.
Thank you very
Only
much.
the cost.
Thank you.
Thank you, Dr. Dilip, for an excellent presentation. I would like to invite Dr. Rajesh Pamanekar to felicitate the speaker and the chairpersons. Dilip Kumar. Dr. Rituparna Datta. And Dr. Pinaki Datta. Thank you very much. We move on to the next session, from heart to bone. The next session is on difficult to treat bone and joint gram-positive infections. The speaker is Dr. Shayan Chakraborty, and the chairpersons are Dr. Sumantu Sarkar and Dr. Nirmala Viswal.
So our next session is on difficult to treat bone and joint gram-positive infections, and we have on the dais Dr. Shayan Chakraborty, who is MD and DM from AIMS New Delhi, consultant Department of Infectious Disease, Manipal Hospital, Kolkata. So without much ado, I hand over the mic to Dr. Shayan. Thank you. Please start.
Good afternoon, everyone, and thank you, organizers, for getting me here to discuss about this topic: difficult to treat bone and joint gram-positive infections. So, what are the various bone and joint infections that we usually see? One is septic arthritis, very commonly. Prosthetic joint infections, we are getting a lot of knee replacement, hip replacement cases, and we get to see the prosthetic joint infections. Osteomyelitis of various kinds, spinal infections, discitis, vertebral osteomyelitis, epidural abscess, many cases of spinal infections that I am seeing now, and diabetic foot osteomyelitis also. Now, why are these infections difficult to treat? Firstly, because of the diagnostic dilemma, whether it is an infection or an autoimmune disease. Very recently, one patient was admitted. She was a daughter of a neurosurgeon. She came with a history of pain in the left knee, pain and swelling in the left knee. Everyone was thinking whether it was a septic arthritis, but there was no other feature suggestive of sepsis or any infection. It came out to an autoimmune disease. So it's a very difficult to diagnose sometimes. We are giving antibiotics, it's not responding. But when we give steroids, it responded really well. So that's becomes a dilemma. Difficult in identification of the positive organism. Most of the time we do not identify, we cannot identify the positive organism. Then the penetration of the antibiotics, which is mostly poor, is difficult to treat with the antibiotics. And secondly, the long duration of therapy. Mostly injectable, later on you can give oral, but the duration is really very long, 6 to 8 weeks or even more, up to 12 weeks. So, regarding the diagnosis, if we can get the synovial fluid or the tissue, we mostly send it for culture, we send it for gram stain, and otherwise, most of the time it comes negative. So there is one multiplex PCR panel where they have got so many targets, anaerobic bacteria, aerobic bacteria, gram positive, gram negative, yeast, with all the antimicrobial genes as well. So if you can send that particular synovial fluid or tissue to this multiplex PCR panel, definitely you can find out something out of this. And the report comes within 4 or 5 hours. So life is a bit easier with this particular panel. Now regarding the duration of antibiotic therapy, whether 6 weeks or 12 weeks for the prosthetic joint infection. So you do realize that giving antibiotics, injectable antibiotics for 6 weeks or 12 weeks, keeping a cannula in your hands and changing it every 3 to 4 days to one side or to the other. So it's really a difficult thing. Patient usually comes to us back with swelling in the both hands, and they tell us that there is no vein there left, so what to do next? So that becomes a problem. So this particular study was done in France. 28 centers were there, and they were receiving 6 weeks and 12 weeks of antibiotic therapy. So the persistence of infection occurred in around 18.1% patient in the 6 weeks group and 9.4% in the 12 weeks group. So definitely 12 weeks is a better option here, and non-inferiority was not shown in the protocol and sensitivity analysis. And higher percentage of unfavorable outcomes are seen in patients getting antibiotics for 6 weeks. Now, how about oral versus intravenous antibiotics for bone and joint infections? So there were 1,054 participants, 14.6% in the intravenous group and 13.2 in the oral group had treatment failure. And in incidence of adverse events were not significant. So final conclusion was that 6 weeks of oral versus IV antibiotics, the oral was non-inferior to the IV antibiotics at the end of 1 year in terms of treatment failure. So oral antibiotics can also be given. But anyhow, what I have seen that at least for the first 4 weeks, if the IV antibiotics can be given, after that you can change your to oral. So overall the treatment outcomes are better. How about the antibiotic penetration into the bone? That is also an issue. So there was an updated review. So good penetration was seen in most of these antibiotics, which we usually use in our practice: amoxicillin, piptaz, meropenem, even vancomycin, daptomycin, usually clindamycin and all. Dalbavancin, doxycycline, these all also have a very good bone penetration. Poor bone penetration is there in penicillin, metronidazole, and flucloxacillin. So, flucloxacillin, mostly used for MSSA cases, doesn't have a good bone penetration. So, this is one chart that I've taken from one particular article. There we can see that dalbavancin specifically has got a very good bone penetration, and there are other antibiotics as well. But dalbavancin has one good thing that you can use it once a week, very easy to use once a week. You can give it at home, or the patient can come to the daycare center and take and go back. Overall safety efficacy are very good. So I will discuss two cases. One the case is 52-year-old lady, no comorbidity, presented with a severe low back pain. But MRI showed a L3 to L5 spondylodiscitis with paraspinal abscess. So whenever a patient comes with a spondylodiscitis, everyone thinks that it is a TB, it's a pox. It cannot be anything else. So anyway, the patient was started with ATT, there was no response, and the patient's condition worsened. Eventually, surgeon said that okay, I'll do a laminectomy. The anatomy determination was done, tissue was sent for culture, and it grew up MRSA. So many times we have seen that tissue or the first from the taken from the spinal discothetic area grows something other than TB. It can be a MRSA, it can be even salmonella, it can be pseudomonas, it can be E. coli. So any spinal discothetic is not always TB. You have to try and find out what it can be. So this was the culture report. It showed MRSA. Now, what are the options for MRSA? So we have vancomycin, teicoplanin, linezolid, alba, ceftaroline, rapamycin, levodopa. In oral, we have linezolid, prednisolid, and levodopa. So these are the options. We have to choose out of this. This patient is going to take this particular antibiotic therapy for around 3 months. So that becomes a problem. So we chose to give dalbavancin. Why? Because again, once a week therapy, patient can easily take it at home or at a daycare center. It's very safe and it has got a long half-life. So once a week dosage is really good. We have used in multiple cases. I'm just presenting one of these, and it has got a very good efficacy. Patient compliance is also very good. So I've given it for once weekly for 6 weeks, and after that I have given prednisolone for around 2 weeks more. And the patient is doing well. Patient is still on prednisolone. So prednisolone is again a good option because you can use it for a longer period. And the problems with linezolid is taken care of by prednisolone because the chance of cytopenias are less and it doesn't have any interaction with the SSRIs. Because many of the patients might be having some antidepressants and that can cause a serotonin syndrome when given with linezolid. So that is also taken care of by prednisolone. Moving on to another case, she is a 62-year-old lady, diabetic hypertensive, bilateral osteoarthritis. She had a rash near her right knee and she was treated as psoriasis and planned for bilateral TKR. Response to treatment of psoriasis was mild. Bilateral TKR was done on the same day and after 1 month there was a pus discharge with a swelling from the right knee. First grew again a staph aureus and it was given linezolid for 5 days and extended for another 5 days. But there was no response and the pus discharge persisted. USG of the right knee, the power Doppler study was done which showed synovial effusion with increased vascularity of the synovium. So orthopedic surgeon said, okay, I'll do a stage 1 revision PKR with placement of the single spacer and some gentamicin, amikacin, daptomycin antibiotics inside that. So that was done. Tissue was sent with for histopath and. Now what was the problem? What problem really happened? So that rash which did not respond to treatment. Okay, so why was the only right knee was involved for psoriasis? Psoriasis is usually a bilateral symmetrical thing. It can both knees, both elbows. Usually the psoriatic rash is present on both sides. And there was a history of low-grade fever that was missed. So was that a superficial skin and soft tissue infection along with the surgery that was done, or it was a prosthetic joint infection? And what can be the probable organism? So these are the things usually we think. And that rash, that the doubtful rash, which probably was not psoriasis, the skin biopsy could have been done, and later on we could have taken a synovial fluid and tissue as well. And after the surgery was done, after the diagnosis of prosthetic joint infection was done, we can do MRI with a March sequence or a CCT of the right knee and taking the samples from the synovium or the synovial fluid, sending them for all kinds of tests like histopath, Ramsden culture, Zedelston, Genexpert, TB, fungal, everything. Now that organism that we got was Staph aureus. Now Staph aureus is not a single organism. It is either a MSSA or a MRSA. How can you identify? Look at the report. Try to identify oxygen is susceptible or not. You can see which oxygen is susceptible. So this is a case of MSSA, not MRSA. So in a patient who has got an MSSA, if you are giving teicoplanin all it is not going to work. We have got multiple papers where it is shown that it doesn't work that well. You have to give specific antibiotics for MSSA. So we gave cefazolin, which is having a good bone penetration. Another antibiotic would have been flucloxacin, but obviously doesn't have a good bone penetration. So better to choose a cefazolin in this case. And we have given it for minimum 6 weeks, and the patient will come back with some reports, and I will ask the patient to do again a USG Doppler study to see, and we have to extend the antibiotics for maybe up to 6 weeks more. I will change it to oral cephaloxime depending upon the response of the patient. And definitely I have to check for the these adverse events. Later on the histopath report, I was treating the patient for MSSA, but I got the histopath report. It came and showed that epithelial granulomas were there, Langerhans, xanthophyllus, and Page's necrosis. ZSA from the tissue showed no AV. Gene expert ultra showed a trace with foundation resistance indicated. So that rash present over the knee, that was actually cutaneous tuberculosis. So the patient now is receiving cefazolin with ATT for 1 year because the skin TB has gone inside the joint. So that patient has to take it for 1 year. And after 6 weeks, we'll change it to cefalexin. And stage 2 division TBR will be treated by minimum of 6 months because the TB needs to be cured first. So thank you so much for your patient hearing. Please use your antibiotics to clear all this. Thank you.
Thank you, Dr. Simon, for elaborative talks on this difficult to treat bone diseases. I myself is a pediatrician, so I will be interested in the incidence of pediatric bone diseases and difficult to treat infections. What is your experience? Please share.
In pediatrics, mostly we see septic arthritis. Mostly the septic arthritis is more common. What I have seen, I'm not a pediatrician, but I do see cases of pediatric infectious disease. So septic arthritis with ground constitution is more common in this case.
What about the spondylolisthesis, particularly from the psoas abscess, particularly in neonates?
Neonates are not in other cases, but in general pediatrics, I have seen some cases of spondylolisthesis with again MRSA or NSSA or even E. coli.
Do you consider the even in these pediatric patients, oral and IV drugs will be equally effective as you have told in adults?
In adults, definitely it works. In pediatrics, to check with the literature if there is available. And,
Most literature says the IV drugs are more having better bioavailability than the oral drugs, particularly the in pediatric population because the absorption of the oral drugs are very erratic in from the stomach. So that's the thing. Now the question for the audience. I have two questions for the audience.
I have a question.
Yes, sir.
It's a recent days actually. I have seen the Klebsiella, Indian race of Klebsiella are the most common cause of periprosthetic joint infection. I'm doing joint replacement since 2010, but recently last 3 years we are facing this problem. Could you please highlight from where is the source of infection, and second thing is what is the treatment protocol regarding antibiotics? So I know the treatment protocol that can be said, but regarding antibiotic, I want to ask you.
So you are getting this from one single center or different centers? Different centers. Okay. So usually the bacteria is same. Okay. So Klebsiella is common maybe in your practice because it is present in the OT or the patient might be having a UTI which is undiagnosed.
Yes.
Right. So mostly in the patients who are getting replacement of the hip or the
few weeks. It's
yeah.
late infection.
Exactly. So we always ask the surgeons to please get a urine ICS done before the surgery.
That we are doing regularly.
Yeah. So that is very important. If the patient is got a UTI, then there is a very high chance the patient might develop a infection in the knee or the hip. So that things needs to be taken care first, and your infection control strategies needs to be strengthened in whichever center the infection is caught up. That is very important. And the antibiotics, obviously, as per the sensitivity pattern, you can choose.
Regarding antibiotics, I have seen last few reports. It's a tigecycline sensitive Indian registered Klebsiella is very common. We use tigecycline initially, then after switching up to any kind of minocycline or doxycycline. What I've seen is my influence.
Yeah, tigecycline needs to be given for a long duration because there is some side effects. Patient will have a lot of GI symptoms, diarrhea, and becomes a problem.
For 5 days initially, then after.
It is excellent. Sorry to interrupt, Simon. It was excellent. I mean, surgical which I am always afraid of infections. But nevertheless, it was a good. Sorry, because we are running short of time. We need to proceed. Now I request Dr. Sujoy to felicitate the speaker and the chairpersons, please.
Thank you very much.
So, Dr. Sayan, please. Then our own Shmurko and Nirmala. And so on. Thank you very much. Now we move on to the next session. It is regarding the breast diseases, which is very pertinent these days. We are seeing a rise in breast diseases, benign and malignant both. The subject is approach to management of breast disease from diagnosis to treatment. The speaker is Dr. Arunima Mukhopadhyay. And I would like to invite the chairpersons, Dr. Novendra Vishwas, Dr. Joyanta Bhattacharya, and Dr. Amina Hawk. Chair.
Sample. So good afternoon, all of you. Well, the hall is almost empty because it is lunchtime. However, my talk is on a very relevant topic because I'm sure everyone present over here have to have patients with breast symptoms. So therefore, it is a relevant topic to discuss today. Now, when we are in the outpatient department, the patients who come to us with breast symptoms usually complain of mastalgia more than 50% of cases, or palpable breast lump, or both mastalgia and breast lump, sometimes nipple discharge. And believe me, every patient who comes to us has this query: Doctor, am I having breast cancer? Am I going to have breast cancer? If I do have breast cancer, can I be treated? Can I be cured and all that? So they are very anxious about it. However, what we see is that most of the people who come to us with breast symptoms, they are actually having benign breast disease with malignancy being only positive in 3 to 6% of cases. But our duty is actually to identify the benign breast disease and to establish the diagnosis in case of malignant breast. So international recommendation is every breast patient who comes to us has to be assessed by a triple assessment consisting of a history and clinical examination, that is one. Then the imaging, ultrasonography or mammography or both. And the last is the pathological assessment in the form of core biopsy. And in 99% of cases, if we are going through a triple assessment, we can establish a diagnosis confidently. So to begin with history taking in a patient of nostalgia, we ask for the onset duration, whether cyclical or not. For a breast lump, again the onset, the rate of growth. For both nostalgia and breast lump accordingly. For an associated ulcer, the site duration progress. For a nipple discharge, the character. Any swelling, that is a lymph node in the neck or axilla. Any systemic symptoms like chest pain, cough, etc. We ask for a previous breast disease history, a family history, a contact history of tuberculosis, and of course a hormonal history in the form of obstetric and gynecological history. This is a breast pain chart designed by AIMS in Delhi, and people who are coming with nostalgia, we ask them to fill up the chart according to their pain or the days of pain according to their menstrual cycle. So the physical examination, we have to respect the patient's privacy, and there are 7 P's. The position, the palpation, the pairs of fingers for palpation, the pressure, the perimeter, the tracking of the organ, of course the patient education. So the patient should be examined in upright position, arms by the side, arms raised over the head, hands placed over the waist, leaning forward, in a semi-reclining position, in a supine position. So there are different positions recommended as you can see in the diagram. You palpate the breast and the axilla. For palpation, the pads of the three middle fingers are used with three pressures, light, medium, and deep. Every quadrant has to be systematically examined. The examination should extend from the clavicle to the inframammary fold, from the sternum to the latissimus dorsi. And the methods, as you can see in the diagram, the concentric circle approach, the vertical strip or linear method, the radial scope or wedge approach. And when we are doing the physical examination, we have to in details examine the disease breast, the symmetry and position, the nipple, the areola, the skin over the breast lump, particular its fixation to the overlying skin, the breast tissue and the underlying structures, presence of nodularity if any ulcer over the breast. We have to examine the axillary lymph nodes, the supraclavicular lymph nodes, examine the arm for any edema, and we must remember to examine the normal breast, that is the opposite breast, the opposite axillary lymph nodes. So there are some red flag signs as far as malignancy is concerned. That is a rapidly enlarging lump, particularly if it's irregular and hard, skin changes, new onset nipple infection, bloody nipple discharge, axillary lymph nodes, and so on. For imaging, we go for ultrasonography as a first-line investigation. However, it is operator dependent, but there are parameters to distinguish between a benign and a malignant lump. Better is diagnosed in mammography, particularly if the patient is more than 40. There are different radiological views, and there are again some definite parameters to distinguish between a benign and a malignant lump. After the imaging comes a BIDAR scoring, and you can see the categories from 0 to 6, where 2 or 3 are benign, 4 and 5 are suspicious or suggestive of malignancy, and 6 is an established case of malignancy. For a psychological histological assessment, for a palpable breast lump, we go for an FNAC where we use a fine gauge needle to aspirate cells. For a true cut biopsy, we use a thicker needle to collect a core of tissue, and sometimes we use imaging as a guidance, either ESG or MRI, so that we can accurately localize the lesion and place the needle in accurate position so as to obtain the maximum amount of tissue for a very good informative result. Here again there are quantitative biopsy categories starting from B1 to B4 and B5, where B2 is benign, B4 is suspicious, B5 is malignant. And then there's a triple assessment score with a minimum score of 3, maximum of 9. And those who are having a score of less than equal to 4 are generally benign. Those who are having more than 6 are usually malignant. Now coming back to our symptomatology, and of course there are other diagnostic modalities like MRI, etc., according to the merit of the case. So coming back to our symptomatology, where we are talking about nostalgia and lambic and discharge and so on. Most of the cases who are coming to us are actually fall within the spectrum of what is nowadays called as AMDI, that is the aberrations of normal development and evolution. Now, when we were students, the terminology in the textbook was fibrocystic breast disease. This is the new terminology. And there's a wide spectrum of AMDI according to age. In the early reproductive years, it is fibroadenoma. In the mature reproductive years, it is cyclical nostalgia and nodularity. In the involution state, it is usually ductal or periductal mastitis. So when we are having a patient of nostalgia for a stepwise evaluation, we take a very good history and clinical examination, establish whether it is cyclical or non-cyclical nostalgia, and then follow up with the rest of the people assessment in the form of imaging and biopsy indicated to establish the benign and malignant etiology. So coming back to the patient of nipple discharge, again we see what is the and lamb, whether it is single or multiple duct discharge. Most of the cases who are coming to us are access like elevated TSH or prolactin levels because they need only medical management for the nipple discharge to subside. We have to exclude the physiological causes like pregnancy and lactation, and then evaluate the ones which we think as pathological by people assessment, and then again establish the benign or malignant etiology. So when to start treatment? Those patients who are coming to us with mild symptoms of pain, sometimes symmetric breast nodularity, with a physiological discharge. All they require is reassurance and follow-up with observation, and sometimes mild analgesics if required. But the ones who are coming with asymmetric nodularity, a definite lump, severe breast pain, a bloody nipple discharge, or a mastitis which is non-lactational, which is not responding to antibiotics, these are the cases which actually need a very good evaluation and then a very good efforts to be made to establish the diagnosis and rule out malignancy. So if we see the textbook and treatment of nostalgia, the recommendations are a huge list, starting from reassurance, ruling out malignancy, ordinary NSAIDs, evening oil of primrose, going on to tamoxifen, danazole, or meroxicam. All have their pros and cons, and particularly the tamoxifen, danazole, etc., have some undesirable side effects also. If we see the treatment of fibrocystic breast disease, it starts with analgesics, then evening primrose oil, then tamoxifen, bromocriptine or danazole, and finally comes the surgical treatment if other things fail. So it is recommended that there should be adequate breast support with well-fitting undergarments. There should be a fat-restricted diet. There should be evening primrose oil and gamma-linolenic acid, and there should be use of vitamins like vitamin E and vitamin B6. So coming to evening primrose oil, now this drug has created a huge evolution in the management of benign breast disease. It is a rich source of linolenic and gamma-linolenic acids, and there's a mechanism of action where it restores the saturated unsaturated fatty acid balance, decreases sensitivity of the breast to circulating hormones, it increases level of PGE1 with an anti-inflammatory action, and again attenuates sensitivity of breast tissue to prolactin, and it decreases conversion of arachidonic acid to pro-inflammatory leukotrienes. So there are some studies, or rather several studies, in different journals, international journals and national journals, where they have tried to establish the therapeutic efficacy. And it has been seen that EPO, that is the evening primrose oil, can be used in the treatment of nostalgia without significant side effects which are attributed to tamoxifen and danazole and bromocriptine and so on. And particularly, they are actually helpful in the case of the cyclical nostalgia related to the AMDI. There are some patients who have AMDI with cysts and nostalgia, particularly small cysts which do not warrant an excision if the malignancy has been ruled out. These are the cases where again EPO has been tried with good outcome. If you have a nipple discharge again, sometimes it is only due to AMDI. Here again you can put up the patient on EPO and follow up. If of course it is a pathological dangerous discharge which is suggestive of malignancy, then we definitely have to do a very good cytology or very good two-part biopsy, sometimes a ductoscopy, and establish the diagnosis of malignancy. We get patients within the spectrum of area who come to us with breast lump, and most of them are fibroadenoma, small fibroadenomas, maybe 2 centimeter, 1 centimeter in size. They can be again treated with EPO and analgesic side effect kind of observation. Most of the time they do not increase in age, in size. Sometimes if we see that the size is gradually increasing, it's becoming more than 3 to 5 centimeter, or a patient has a family history of breast cancer, or the FNAC is suggestive of dysplasia, these are the cases where we have to go for surgical excision. However, there are some advances in the treatment nowadays, like there are centers where they are using high intensity focused ultrasound, cryotherapy, vacuum assisted excision of the fibroadenoma, of course after ruling out malignancy each and every case. These are the patients who are not wanting a scar, they are very conscious about the prosthesis part. So for them is the fibroadenoma treatment. For a mastitis, particularly in the lactational age group, here again staph aureus is very common. Patient comes with a painful, tender swelling, and we have to start the patient on antibiotics, do an ultrasonography. Most of the time, we can go for ultrasound guided aspiration, and sometimes if the aspiration fails, or it is a multi-separated abscess, or the overlying skin is already necrosed by the time the patient is presenting to us, then we have to go for an incision drainage under general anesthesia. If we do not drain the pus, then the patient lands up with an antivenom, a hard lump where the pus is inside, over it is a fibrous cover, and then it is a very big differential diagnosis, that is malignancy. So we have to rule out malignancy, and for that we have to go for a diagnostic excision biopsy. Finally, the patient does have actually invasive breast carcinoma. Now that of course is a multidisciplinary approach where according to the staging, we have to decide whether the patient needs upfront surgery or neoadjuvant chemotherapy followed by surgery. And after the surgery, we have to decide whether the patient needs both adjuvant radiotherapy and chemotherapy. Then we first start the chemotherapy followed by the radiotherapy. And then according to the immunohistochemistry, patient may have to be giving endocrine therapy for 5 to 10 years. And nowadays, if the patient is HER2 positive, we start targeted therapy of trastuzumab for 1 year, which can be given concurrently with chemotherapy or radiotherapy or endocrine therapy. So a take-home message. So as I said before, that the patients who are coming to us are mostly having mastalgia or breast lump or both. And all breast lesions should be approached with a systematic triple assessment, observation and assurance, specific treatment as indicated, and follow-up. Although benign breast disease forms the majority of breast cases, malignancy should be ruled out in each and every case. The malignancy should not be missed at any cost, and sometimes we forget to ask the positive family history. And remember, patients who have a positive family history may come with a malignancy in the breast at a very young age, not like the age over 40s or 50s. Even we have got patients of 20, 25, 30 coming with breast cancer. That also bad grade PNBC sort of breast cancer, which is very difficult to cure. So one should not hesitate to go for a diagnostic excision biopsy if felt necessary. Now coming to the benign cases, it has been seen that most benign cases can be treated conservatively or medical treatment like EPO, etc., with very satisfactory results. So the malignancy, if unfortunately the patient is having a malignancy, the malignancy has to be treated following a multidisciplinary map. So thank you very much, and I must thank my academic partner, whose unique Windows soil has created a huge revolution and a huge difference in the management of benign disease. So any questions?
Thank you, Dr. Varuna Mukherjee, for your beautiful lecture and very systematic presentation. I think we all have enlightened. Thank you very much. We are running time short.
Arunima, I have got a, sorry, I need to, I've got a question. You just made a statement that if it is malignancy, you might go into a excision biopsy. It needs to be.
No. I said that so that we don't miss a malignancy, if necessary, we have to go for an excision.
This needs to be clarified to the residents. The excision biopsy is almost out these days. If you are doing, planning to do a breast conservation, you have to go it with the WAD, which is because I get a lot of patients as a surgical oncologist, which they have done a excision biopsy with a margin positivity, and there is no marking. So if we are, I'm conserving the breast, it is difficult for me. Number one, number two, there is these days we are mastectomy is almost out. These days we are conserving every breast if it is not locally, very locally advanced or maybe T4B, T4D. So I need to just for the of the residents, please don't go for an excision biopsy. These days ultrasound guided Tukat biopsy is easily available. You have to get hold of a good pathologist. That's all. And probably if it is Byrad's phone,
yes,
I'm thinking about it, then they should involve a good surgeon or a oncologist, surgical oncologist, who can plan the WAD, because doing a WAD
yes or no, just one thing. What you said is absolutely correct, only differs from center to center. So I'm working in a government medical college where the people who are coming to us, coming from a socio-economic background, there are two things. One is they are not bothered about the conservation of the breast. If you ask them, they will all say that I need to be cured for the disease. If you give them a doesn't, if you give them a option that you want to conserve the breast and you want to do MRI, they will all go for MRI. They don't bother about conservation of the breast.
I agree. And the Detroit breast study.
Second thing is, USG guided Tukat biopsy is very good if you are in a very well equipped center. In a place like medical college, there are thousands and thousands of patients coming every day. You don't have that USG guided Tukat biopsy. It's not possible. My resident is doing the Tukat biopsy in the surgery department.
I'm also in a hospital.
The Tukat biopsy is coming after 50 days and saying inadequate sampling, no comment can be. So what do you do? Again, you go for Tukat biopsy.
I know that, but it is the onus on you and me to improve the quality of care. I also work in a government hospital. I have a USG guided now. My residents are doing USG guided cooker biopsy themselves. Probably we have to work towards the better. Thank you very much. And now I request Dr. Sudeep Shah to come and felicitate the speaker and the chairpersons of this. Thank you very much. As we move on to the next session, the subject of the next session is role of triple bronchodilator therapy in advanced COPD patients. The speaker is Dr. Amartya Chakraborty, and the chairpersons are Dr. Anish Chatterjee, Dr. Prasoon Kar, and Dr. Tirthapatin Das. Dr. Anish, please. Yes, Prasoon is there, and Dr. Thank you. I would like to tell the chairpersons to just say a few words of Dr. Amartya, please. Thank you.
Good afternoon, everybody. It is a pleasure to introduce Dr. Amartya Chakraborty. Will present the topic role of triple therapy in advanced COPD. It is a challenging topic, and hope he will enlighten us, everybody, with this topic.
Thank you, sir. Good afternoon, everybody. And I thank the organizers for giving me this opportunity to give this talk. So, my topic is the role of triple therapy in advanced COPD. So, first, we should be clear that what do we mean by advanced COPD? So, this I took from the Gold 2026 guidelines. Now they have differentiated. Previously, there was a composite score, including both the FEV1 and the exacerbation histories. Now they have separated out the FEV1, the airway limitation part. So in that the gold less than gold 3, like less than 50% predicted of FEV1 falls under the ambit of advanced COPD, and the gold E classification, like the patients with more than one moderate to severe exacerbations requiring hospitalization in the past year fall under the ambit of advanced COPD. So my topic is actually how to deal with this kind of patients and how to optimize their care. So the most commonly the patients that we find in our pulmonary medicine OPD are the frequent exacerbator phenotype. So they contribute disproportionately to the disease burden, responsible for more than 35% of the total exacerbations, and an increase in frequency of exacerbations even by one per year, and is associated with an increased risk of mortality. and that the evidence suggests that microbiome differences in frequent versus infrequent exacerbations offer a new potential therapeutic target. And like again the same thing, I would just want to give some data. Like frequent exacerbator, it's more than two per year or more than once a year, is a key future risk predictor. More than two events in 1 year is likely to have 5.7 times the next increased risk of next exacerbation. And these patients are associated with higher comorbidities, higher requirement of NIV during hospitalization, intubations, and rapid declining lung function. So this was an interesting study, the EPIC-2 study, which looked at dealing disease progression in COPD with early escalation to triple therapy. In this study, they divided the study population into two groups. One group received the LABA-LAMA combination that we all know, tiotropium formoterol combination or formoterol glycopyridine combination, and the other group was after receiving LAMA-LABA for a certain period was shifted to the LAMA-LABA ICS group, and they found that escalation to triple therapy preserves an additional 376 ml of FEV1 in versus no pharmacotherapy, and around 217.3 ml of FEV1 versus LAMA-LAMA only. So just addition of an ICS to the LAMA-LAMA combination preserves around 200 ml more of FEV1 in this aged population, like the people who are gradually aging more than 45 years of age and less than 75 years of age. So this was a very important insight that normally when we were doing our PG studies, we were told that drug of choice for COPD was LAMA, and ICS for the drug of choice for bronchial asthma. But nowadays we are finding that even in severe COPD patients with risk of frequent exacerbations and lung function decline, ICS plays a very important role. So why combine these three drugs? To prevent bronchoconstriction, to prevent inflammation, to prevent mucus production, and to prevent airway remodeling. So this was a study which was published in the JAMA. We showed that suppose a patient is getting triple therapy, LAMA and ICS, salmeterol, fluticasone, and tiotropium. In this group of patients, if we stop the ICS, then the rate of exacerbations may not differ, but the decline in lung function in the group in which ICS was stopped was quite higher. So not only addition of ICS preserves lung function, and it is proved the other way around also that if we stop ICS in COPD patients, in the severe COPD category, it can further decrease the lung function. So which patients are suitable for single triple therapy? So these patients are symptomatic patients on dual therapy who are prone to exacerbations, and patients who had suffered an exacerbation and now we are trying to discharge those patients. So in those patients who have persistent symptoms despite dual therapy, they have a poor quality of life. 1/3 of these patients still face moderate to severe exacerbation risk, and dual therapy fails to stabilize patients around 1/3 of patients. And uncontrolled symptoms drive healthcare use and rehospitalization rates, and inadequate control accelerates the FEV1 decline. And there's a number of studies which have looked at the impact of exacerbations on lung function, future events, and mortality. All of them have found that baseline increase in baseline exacerbations predict more exacerbations in the future, more hospitalization rates, and increases the risk of mortality. Frequent exacerbator phenotype, more than 2 per year, have around 5 times more the risk of mortality in that year. Now the third category of patients in whom this triple therapy works is that the patient who has suffered an exacerbation and we are trying to discharge. In these patients, if we promptly initiate triple therapy, they have found that there is a 30% fewer total exacerbations in the following year, 29% reduction in the severe exacerbations requiring hospitalization. So patients can have moderate but not severe exacerbations. And also the 90-day all-cause readmission rate was much lower in those patients in whom we had started triple therapy at the discharge. And also 20% lower annual COPD-related healthcare costs. And even in the new guidelines in COPD Gold and also in Indian guidelines. So these are the guidelines that we have. Triple therapy for severe COPD, FEV1 less than 50%, and use if symptoms persist. The patient has an asthma COPD overlap or peripheral eosinophil is more than 300 per microliter. And these studies have also shown that triple therapy has a very good mortality benefit also. Previously, we only knew that only long LTOT has mortality benefit in COPD patients, but nowadays you are finding that triple therapy, NIV use, and LTOT can also decrease mortality rates. Yeah, this is a study made in the Indian context in which they have compared single therapy versus lava lama or just ICS lava. They have a significant decrease in the severe exacerbation and improved all-cause mortality also. This is a few examples of few important trials on triple therapy. The impact trial, which has shown FEV1 gain and also exacerbation reduction by almost 25%, and better health quality of life, health status and quality of life. And there's another trial called the Fulfill trial. Same thing. They have found around 171 ml of FE1 improvement, FE1 gain, around 44% in exacerbation reduction, and also improved quality of life. So all these multi-center RCTs have shown that triple therapy initiation helps improvement in the clinical outcome of advanced COPD patients. So there is another study published in the ERJ which have shown that in around 30% of COPD patients they have a specific phenotype in which they lose lung function at an accelerated rate. So this rapid lung function decline is independently associated with a higher mortality. And rapid decline in lung function is particularly noted in COPD patients with self-reported late onset asthma. When these patients were given the triple therapy, a clinically meaningful decline in lung function was seen in 25% patients treated with triple therapy, when compared with 56% in those patients who were treated with dual therapy, either LABA ICS or LAMA LABA. And the median time to lung function, clinically important deterioration, which was more than 100 ml of FeV1 loss, was longer for triple therapy, for around 169 days versus 31 days in those patients who required dual therapy. Now, a very important point about inhaler therapies is that there is a huge psychological resistance of patients towards using inhalers. They don't want to use the inhalers, and twice daily inhalers and multiple inhalers like LABA ICS and LAMA different inhalers. Patients are not keen on taking them, and there is a problem with the adherence. So studies have shown that with respect to multiple inhaler therapy, a single inhaler therapy has a significant higher mean proportion of days covered, 0.6 is versus 0.48, and a significantly higher mean proportion of days covered at even 6 months. And also longer median persistence of single therapy at 6 months uh, is quite high, and patients on single therapy are twice more likely to be persistent even at 1 year. And in market now, there are two kinds of triple therapy that we have at our disposal. One is a Vilantrol fluticasone umeclidinium combination, and the other is glycopyrronium formoterol and budesonide combination. And if we compare these two kind of triple therapies, we found that there is not much difference in the FEV1 exacerbation rates, but the Vilantrol combination, there is a reduction in the all-cause mortality by 11% versus the glycopyrronium group. This is my just a brief summary of all the things that I've talked about. The take-home points that 56.5% of Indian COPD patients are non-smokers, mainly present late with advanced COPD and echo features like asthma COPD overlap. Dual therapy often leaves inflammation or bronchospasm untreated, especially in high-risk patients. Single inhaler triple therapy improves adherence and ensures consistent delivery of all components. Triple therapy reduces exacerbations by, in different studies, from 15 to 25%, and in a Japanese subgroup, 36% reduction. And this formoterol, umeclidinium, vilanterol, fluticasone, umeclidinium, and vilanterol improves FEV1 by 180 ml and lowers exacerbation by 25% and improves HRQ. Early switch to single therapy improves lung stability and reduces disease progression. And early initiation of single inhaler therapy for patients who are being discharged from a previous exacerbation. That is the correct point to start the single inhaler therapy consisting of all the triple drugs. And when we compare the two market available therapies that we have at our disposal right now, VFU demonstrates an 11% lower risk of mortality compared to the glycopyrronium group at 12 months. So this is all for now. Thank you for your patience here.
Thank you, Dr. Chakraborty, for nice presentation. Now,
The incidence of chronic pulmonary or COPD is less because all of these drugs cause tachycardia.
Yeah.
So does it the aftermath of advanced COPD is chronic right ventricular hypertrophy? So this triple therapy, does it affect?
No, triple therapy is not associated with tachycardia or and it decreases the rate of exacerbation, so it decreases the rates of pulmonary also, right at finish. That
side
risk is
effects
more,
are less.
yeah, so that risk of tachycardia is much more with salmeterol than the other groups of beta 2 agonists.
Thank you.
Yes, sir, sure.
okay. So now I request Dr. Mukhopadhyay to felicitate the speaker and the chairpersons. Now we are moving on to the next session. The speaker is Dr. Ashish Mitra and the chairpersons are Dr. Chunji Datta, Dr. Arup Dey and Dr. Shormishta Chakraborty.
Thank you, Dr. Dr. Mitra, for delivering this talk on such an important, such a topic, an interesting topic, actually, the craze of the modern era. And I would like to thank Dr. Tormoy and his entire team for organizing this event so beautifully. And especially the time management is so commendable. I mean, this session was supposed to start at 3 p.m. and it is starting exactly at 3 p.m. And I have never seen such many events where the time management is so precise.
Thank you, respected chairpersons and my dear colleagues. This era of managing obesity and type 2 diabetes is basically the era of the GLP-1. So GLP-1 is basically the magic molecule. So it is not an anti-diabetic drug or an anti-obesity drug. It's basically the programmer of our basic pathology of the diabetes, that is obesity. So this is my interview published today in the Statesman. So that is basically the GLP-1 secreted by the our intestinal cell. So how we can boost our natural GLP-1, that is about this article. But now I'm going to talk about the agenda of today's talk, is the burden of the diabetes, that is the diabetes and obesity and the need for the holistic management. Why semaglutide is an ideal fit for management of diabetes. Ozempic is metabolic management of sugars. And so most important the organ protection. So why we are prescribing this kind of the positive molecule to the patient of diabetes? Because the main pathogen of the type diabetes is obesity, and diabetes does not come alone. This is associated with the MSLD, the fatty liver, the some form of the chronic kidney disease, some form of the atherosclerotic cardiovascular disease, and also this for the heart failure. So these are the complex diabetes, inflammation, weight gain, hypertension, and obesity, and the
Kishendu.
so
Kishendu.
don't
Oh, Kishendu.
the postprandial pathogens or AG1.
Oh,
So
Krishnendu.
we need to address the all aspects of the obesity and the diabetes and
চলে যাবেন আর কখন
associated
আপনাদের সার্টিফিকেট এই ম্যাডাম
and the
এই
macrovascular
পয়েন্টসটা দেবে
complications.
ডাক্তারতে
So as you know, the disease burden of the diabetes is gradually increasing. The most importantly, in spite of getting so many modern molecules to treat diabetes and obesity, 77% of our diabetes population is uncontrolled, and 90% is either overweight or obese,
ক্যান্ডেল
and
ফ্যান্ডেল জ্বালানো
85% of people die of the cardiovascular disease, and 44% of people having diabetes has some form of the CKD. So basically, the early intensive treatment is the most important. You know, from the UKPD side, so it is similar like the heat hard and heat fast to reduce the HbA1c around 6.5 to achieve the best glycemic control and to reduce both the microvascular and the macrovascular complications. So if you can bring down the HbA1c around 6.5, there is a 24% reduction of the microvascular complication, 15% reduction of atherosclerotic cardiovascular disease, and 13% reduction of the all-cause mortality. So how to optimize the weight, that is the or center obesity of our obesity is the main pathophysiology. And so if you address in a scientific way, so you can avoid both in the micro and the macrovascular complications. So what is the role of the GLP-1 receptor agonist? So GLP-1 receptor agonists offer the multimodal benefits in the diabetes and obesity. So it will address 7 out of the 8 pathophysiological aspects of the diabetes and obesity. So semaglutide is basically the potent GLP-1 receptor agonist, where GLP-1 agonist exhibits 94% similarity with our own endogenous GLP-1. Basically, the novartis RDNA semaglutide has been extensively studied in a different randomized control trial and the real world studies, and it is approved first in the USA, then in the diabetes Canada, ESC, and also in the different guidelines that the FDA recommend, that is include the patient after diagnosis of type diabetes and after doing the lifestyle modification and after taking the metformin, then you assess the risk factor if the patient has atherosclerotic cardiovascular disease or heart failure probably is the best molecule along with the SGLT2 inhibitors. So GLP-1 receptor agonist and the SGLT2 inhibitor act synergistically. So this is basically the bioengineered molecule. So I will not go into the details of how this will. So the Ozempic is a robust India development program. Over 20,000 patients were studied in the 17 different trials, and more than 100 2,000 patients were included in the different trials. There is a sustained one and the sustained rating, Japanese sustained 4, sustained 3 and the sustained 12. There are different some sometimes the placebo, sometimes the metformin, and sometimes the decrease, and also so I'm not going into details due to scarcity of the time. So significant Ozempic was semaglutide significantly beta reduction versus placebo and the active blocker. So before any kind of the consider the any kind of the oral hypoglycemic agent or insulin. So this semaglutide has the highest HbA1c reducing capacity that is being approved by the defined trials from the first aid 1 to first aid 11. So and also there is a highest HbA1c reducing capacity among the any available molecules up to 2.8% with the high baseline HbA1c. If the baseline HbA1c is high, the HbA1c reducing capacity is high. If the baseline weight is high, the weight loss is also high. So up to 80% patients with diabetes is a dietary recommended HbA1c less than 7% in sustained program. Similarly, it is basically revealed that there better body weight loss versus the placebo in the different study, and it has been compared with the other GLP-1 receptor agonists like the gulaglutide, exenatide, and also the liraglutide, and also this one compared with the SGLT2 inhibitor and also the insulin. So also better weight loss. So it can be combined with any kind of the oral hypoglycemic agent along with the insulin. So first of all, there is basically misconception that it is not a substitute for the insulin. So when patient of diabetes insulin required, you can prescribe the insulin, but to prescribe the GLP-1 receptor along with the insulin, the dose requirement and the number of weeks of the insulin will be reduced. So as you know, that there is basically better weight loss. So up to 8 kg weight loss in the semaglutide 1 milligram dose, and 66% patient with diabetes is clinically meaningful weight loss more than 55%, and most important, reduce the central obesity. So it will reduce the waist circumference. So main reduction of total fat mass is 10.2%, and also important, it will reduce the mean lean mass also 4.5%. So it is not that the patient has osteoarthritis and he is not moving, and you are prescribing the Ozempic or Wegovy, so there can be muscle loss as well. So before taking these kind of molecules, patient must be physically active. Otherwise, in case of the as you know, the lean mass reduction can be disaster. So ultimately, there will be increase of the lean mass 1.2% as a proportion of whole. So before prescribing, there should be optimal nutritional recommended take the 1.5 gram per kg per day protein, fiber more than 30 to 40 gram per day. Hydration is very important, and patients who undergo physical training in form of resistance exercise and at least 150 minutes of moderate intensity exercise per week before starting this medicine. So for the diabetic patient, the recommended maximum dose is 1 milligram, but for the obesity patient, the maximum dose is 2.4 milligram. There is two additional dose for the obesity, is 1.7 and 2.4. So there will be up to 80% weight loss and more than 50% weight loss in case of the 1 in 3 patients, and this is sustained weight loss over 4 years. So if you continue this molecule, there is a sustained 4 years weight and glycemic also there is a durable glycemic control. So there is a persistent glycemic control over a period of 4 years. Now, if you combine the semaglutide with the SGLT inhibitor, there is basically there is additional benefit like the 49% decrease of the ischemic stroke, 38% decrease of the MI, 90.4% higher probability that the patient's HbA1c will be below 7 and 48% lower risk of 3-point major adverse cardiovascular event and 47% lower risk of 5-point major adverse cardiovascular event and there is a weight loss more than 10%, there will be near about 300% chance. So there is basically complementary mechanism also. These are the type diabetes inhibitors in the if you combine GLP-1 receptor alongside the insulin inhibitor, as you know. So if you combine the semaglutide and the ACE inhibitor, so these are basically combination therapy, as you know. So this is much better. So appetite will reduce, body weight will be decreased, ischemic cardiovascular event will decrease, heart failure event will be decreased, insulin secretion, insulin secreting capacity of the vessel will be increased. And there is a minimal increase of the hepatic glucose output and the fetal body production, massive glucose uptake will be increased, and the diuresis or lactinogenesis will be increased, and the urinary glucose will be increased. So there is a neuroprotective effect. Now, coming to the different trials, there is a linear trial. Now, coming to the most important is the long-term protection. There is a type 2 diabetes and obesity. There is 67% increase in risk of the valvular infarction, 64% increase in risk of heart failure, and 51% increase in risk of stroke. So this is basically sustained the cardiovascular trial of, as you know, the key inclusion criteria of this study was the age more than 50 years with the established cardiovascular disease. That means the patient has the prior cardiac disease, prior CVA or peripheral vascular disease or heart failure or CKD. So these are basically the bad subgroup of the patients with the diabetes. Now, the most important, the semaglutide group, there is a 26% lower risk of the 3-point major adverse cardiovascular event, which is very significant. So basically, if you compare the other GLP-1, like your dulaglutide or tirzepatide, so in case of the major adverse cardiovascular event, so semaglutide is much better. It's a 26% reduction of 3-point major adverse cardiovascular event. So the semaglutide improves the cardiometabolic risk parameter. There is a 12% decrease of the pre-practice level, 14% decrease of the serum triglyceride level, 12% decrease of the serum VLDL concentration, and 8% decrease of the serum LDL cholesterol concentration. This is a different study. This is a full study. This is a kidney outcome trial with the positive. There is a similar type, this is the analysis CKD type 2 diabetes. The urinary aluminum creatine ratio was more than 300 EGFR or EGFR less than 25 to 50. This is the kidney subgroup patient, and the primary outcome results were more than 50% deaths of the EGFR kidney failure or CVD, and key secondary outcome was annual rate of the change of the EGFR and also the breast. So there is a 20% lower risk of the composite kidney outcome if we prescribe the semaglutide in this subset of patients in compared to the placebo, and 32% reduction of the urinary aluminum creatine ratio, which is very significant. And after the period of 2 years, at the end of the 2 years, and there is what EGFR decline in the semaglutide group compared to the placebo group. And most importantly, semaglutide will delay the end-stage kidney disease by 5 years. So what is the mechanism behind the renal benefits of the semaglutide? This is a remote study. So by study and the remote study, we can assume there is a significant benefit from the kidney aspect. Basically, they reduce the excess fat emitted around the kidney, including the kidney hemodynamics and stabilizing the cortical kidney fibrosis. So this is the mechanism of protection of the semaglutide in the kidney. the global guidelines which recommended semaglutide. So starting dose for the diabetic patient is 0.25 milligram weekly for 4 weeks, then to step up to 0.5 milligram weekly for 4 weeks, then stay 1 milligram weekly. And for the obesity, you have to increase the dose from 1.7 and 2.4 dose. And most importantly, our patient believes that it is a short-term treatment. It's a 6 months, 1 year period. To gain the cardio-renal benefit, you need to continue these molecules for years and years, at least 5 years. Thank you. Yes. Tablet is not recommended for the obesity. It is for the type of diabetes makers for that there is a 60 dose. 3 milligram, 7 milligram, and the 40 milligram dose. So you have to take this tablet in the empty stomach with 120 ml of water, and thereafter you should not take any food for at least 30 minutes. But some patients do not tolerate the oral form because there is some nausea and other GI side effects like the diarrhea or the flatulence. One second. Every day, right?
Thank you, Dr. Mitra. You have shown the brighter aspect of the new molecule, and nowadays the price is also reduced, so it is a very welcome jump. But one thing I have to ask you, the complications of ingestion or oral semaglutide, mainly gastrointestinal complication. Then do you recommend to continue the drug or to treat the complication? How long it will be continue?
So you have to escalate the dose very gradually. So starting with the lowest dose 0.25 milligram,
0.5
once it gets 0.5. So if the patient after increasing dose, patient still having GI problem, so stay with the earlier dose. Then you give another 1 month. So gradually increase the dose. So then most of the patients can tolerate. But yes, you are right. In some patients, at least 10 to 20% patients ultimately do not tolerate, and then we can withdraw this.
Is it the primary drug for type 2 diabetes?
No, primary molecule is the metformin. So after metformin, you have to assess the patient as the any history of the atherosclerosis, cardiovascular disease, or the heart failure disease, or the kidney disease. So in those patients, you can combine the GLP-1 receptor agonist with the SGLT2.
Along with that, I go for oral medication. And not only diabetes, obesity. They can go to hypertension also get non-diabetic obese.
No. So it has been seen in the different study. When your calculated body glucose level is around 70, the effect of that drug will stop. So non-diabetic patient is not going to get hypoglycemia. Even in the diabetic patient, unless you are combining with the sulfonylurea or other molecules which can cause hypoglycemia, alone the GLP-1 receptor cannot cause hypoglycemia. Only one side effect that it can cause is the some is in chance of the pancreatitis is there. So past history of the pancreatitis is contraindication for this one.
I have one question now. In your clinical practice of the newer molecule, you find muscle loss, volume of muscle loss after 3 months in use of semaglutide?
Yeah, sure.
How do you treat that? Because I am in a problem. I am asking you.
Yeah, sir, I've already told my slide that you have to increase your protein intake and you have to walk at least 150 minutes per week and weekly 3 days resistance training. So resistance training is very important to achieve the muscle strength.
Thank you. One last point. This due to the so advanced marketing and propaganda type, this semaglutide, it has become mitochondrial. It takes care of aging. It makes white gray hair black. It reverses prostate enlargement. It takes care of myocardial infarction back to normal. It reverses arteriosclerosis and melts the cholesterol lipid position inside the vessels. It can beautify. It is being used in beauty parlors and by cosmeticians, and it has now become ultimately it will go that it can also make a dead person alive. And this is the result of propaganda, and it will reach that if you give a few drops of Gongajol, this will take care of all cancer, even if it is anti-cancer. And it takes only thing there is some gastrointestinal problem which can be taken care of just by stopping the drug for few days. So above this, I think this will be the only medicine available after 10, 15, 20 years. So nothing should be included except give semaglutide, everything will take care.
No, 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 sir. The CGI has approved it. The CGI has approved it only for the obesity and the diabetes, not for your aging, not for your benign prostate hyperplasia, even not for the PCOD. That's why the DCGI has told it should be prescribed only by the internists and the diabetologists and the endocrinologists.
So it's being used by the beauty parlors.
It is not enough.
The celebrities, we can name here. Is it not so?
Dr. Ashish, that
Karan Johar.
Name the doctor. You should name the doctor who has prescribed it. You should name the doctor who has prescribed it. It is not the patient.
India's famous doctor sitting in Bombay.
Karan Johar will tell your pain is for doctor and he will prescribe it. So that is not science.
Okay, thank you very much. I would like now. So, Dr. Ashish, we have 2 minutes to stop here. Thank you for such an enlightening and such an interesting topic. Thank you so much. Now, I request Dr. Prashant Kapoor to felicitate speakers and chairperson.
Exchange of details. This drug or that drug. It has reached that stage. Due to the propaganda, everywhere.
ওই ওখান থেকে দেবে যেখান থেকে
Emergence of robotic surgery in gynecology. May I request Dr. Vikas Banerjee to honor us as speaker. The chairpersons are Dr. Ramna Banerjee, Dr. Tanmay Banerjee, and Dr. Rajeshi Banerjee.
Hello. Very good afternoon, everyone, to this post-lunch session. It's my proud privilege to present none other than Dr. Vikas Banerjee, sir, for his brief talk on emergence of robotic surgery in gynecology. In the gynae circuit, sir needs absolutely no introduction. He's an inspiration for all of us who does robotics. And sir, the stage is all yours.
Thank you.
good afternoon and my respect to the chairpersons and my respect to the organizers and my respect to the whatever audience is there. Thank you for a good organization. But at the initial stage, I was a bit confused. So many claps for the chairperson. Thank you. So, one simple question. What is the time level? Thank you. I'll comply within that. Emergence of robotic surgery in gynecology. The speech is on 31st July MA on update 2026 at Schedule Hotel. From past via present to future of surgery, many magic moments have happened. Some to make history, some to redefine future. Future is এত কথা বললে আমি বলবো না কিন্তু calm down from the request our disturbance is there. Some to make history, some to redefine future. Future is now being truly redefined. The history of development of modern surgery started about 2000 BC in Egypt. Heidelberg, Galen, and John Hunter, all are different stalwarts in different times. According to Heidelberg, Hunter transformed surgery from an empirical craft to science. Who first invented surgery? From Sushruta Samhita to Charak Samhita have described Sushruta is the father of the modern surgery. The Rig Veda, the earliest account of ancient surgery, Indian civilization, if we go, mentions that Ashwini Kumaras, known as Dev Vaidya, were the chief surgeon. Ashwini Kumaras had performed both homo and hetero transplantation during the very ancient time of Rig Veda, which is estimated about 5,000 years ago. The surgical skill has traversed through the ages ranging from Ashwini Kumaras, Chavana, Dharmantari, Atya, Agnivesh, Sushruta. And ultimately, Al-Jahari is considered to be the father of operative surgery. He is credited with performance of the first thyroidectomy. His comprehensive textbook was named as On Surgery. This is all about history of gradual development of modern surgery, the so-called open surgery. Open surgery is all about large cuts and large incisions. The hemostasis was dependent upon suturing, time, and providing knots. The era of big surgeons giving big incisions prevailed for few decades. Then electrocautery came. The electrocautery, which has given a total evolution in the concept of hemostasis in modern surgery. Gradually, with the development of various modes of electrocautery, the microsurgery or minimally invasive gynae surgery stormed in without delay. Now we can divide the gynae surgery as open surgery. There are two subgroups: abdominal surgery, vaginal surgery, and MIGS, minimally invasive gynae surgery, making small cuts and going inside the pelvis. This can be done by laparoscopy and by robotics. Now I divide surgery by two ways of doing it. Direct visualization of the object. That means you are looking at the object and doing the surgery. That is mostly open surgery. And indirect visualization of the object. You are not looking at the object or staying separate from the patient, but doing the surgery with your skill and expertise and with much training. This is surgery by direct visualization of object, MIGS, minimally invasive gynae surgery, laparoscopy surgery, and robotic surgery. What is laparoscopy? Laparoscopy is a type of surgical procedure that allows the inside of abdomen and pelvis without having large cut and incision, a tiny camera and light and body. Now, 1869, hysteroscopy was the first gynecological endoscopy procedure by Cantilini of Italy, when used cystoscope to identify uterine polyps. Then George Kelly in 1901 of Dresden, Germany, performed the first laparoscopic surgery in dogs. Then Hans Christian Jacobius of Sweden met this device
by performing the first laparoscopic operation in humans in 1910. The introduction of robotic assistance in the field of gynecological surgery, and specifically the introduction of surgical robotic system, is one of the most major breakthroughs in modern times. This is the history of robotic surgery. It was developed by Karl Popek. Basically, he was a Czech Republic, a Nobel laureate. He invented the concept of robo. There was a cinema called Metropolis in 1926, and the first robot was shown, and that cinema became a viral television, super duper. Then US military developed an invention that could send soldiers to battlefield. They invented a robot to send them to battlefield. Then US military noticed these robots were only masters, not taking any decision of their own. Then what is the need? They sold it to institute surgical. Then there was a severe lawsuit between institute surgical and computer motion institute surgical. Then US government intervened. Ultimately, the case was dropped. Huge money transfer was there, and the computer motion was phased out and merged with intuitive surgical. Since then, intuitive surgical is the pioneer robot company. FDA approval in 2005, just 20 years ago. Some of the specificities of MIGS, laparoscopy and robotic surgery. The monitors used in laparoscopy filter three-dimensional cues from the operative field, such as interpolation of overlap and lighting outline and texture. Regarding the limitations of movements, motion limitations, there are 4 degrees of freedom in laparoscopy, 6 degrees of freedom in surgery, open surgery, and there are 7 degrees of freedom in robotic surgery. But the only disadvantage, as there is no haptic feedback. Touch feeling is not there with robotics. A surgeon has usually two arms, but a robotic surgery, the surgeon can manipulate with 3 arms. This is a robotic step tool. I will just show few steps I go. This is fundamental there are 3 instruments. On the left hand is the bipolar, on the right hand is monopolar, and this is the progress which is holding forces. This does not have any electrical attachment with it. And there are 4 intuitions or 3 intuitions. We are doing the intravesical fold section. And going to, there is no blood loss, there is total amount of precision. The figure and the picture is so beautiful that there is no blood loss at all. Today is the operation. Today night the patient will be discharged, or tomorrow morning the patient will be discharged. These are the steps of hysterectomy in robotic surgery. There are 3 systems in the robotic surgery. One is the console where from the surgeon operates with the all the elements of electrosurgery, the hand control, speedy viewer, foot control, and ergonomic design. And the patient part, there are arms which is brought into the abdomen of the patient whose head is down, and that has been put inside the abdomen with 8 millimeter bore. And this is the patient part and fixed by a system called docking. Then there is a vision part, all electrosurgicals, air, insufflator, recording systems, all are there or to the side of the patient. This is called the vision part. So patient part, vision part, and console, there are 3 components of the robotic surgery. The technology consists of robotic arms that hold tiny instruments, a high definition camera, a surgical console, where the surgeon controls the instruments of the camera. The instruments respond to these movements and translate them to precise real-time movements inside the body. The robotic device, which have better dexterity and large motion, range of motion, then a human allows your surgeon to do successfully perform delicate surgeries in hard to reach places. Robot for surgical gynecology, we do robotic hysterectomy, robotic myomectomy, robotic ovarian cystectomy, and robotic conservative styling for pelvic endometriosis. What we don't do tubal ligation, acute ectopic, any diagnostic. The robotic styling is of styling, reduced length, lesser operative time, minimal pre and post operative blood loss, lesser overall complication, reduced readmission. Up to 350 or 400 cases, I have one readmission. Enhanced surgeon's comfort and lesser pain. The learning curve is very simple. You have to learn. You have to learn it and practice both in vivo and virtual. And it takes about 50 to 40 cases to gradually get control over the system and your confidence. Now, what is robotic surgery mostly used for? It is also used for other departments, general surgery, brain surgery, cardiothoracic, colorectal, gastrointestinal, of course, gynecological and urological. So change is the only permanent mode of life. If you believe me, you have to accept the change. Change is the only permanent mode of life. You look at the telecommunication, what was there on the landline, on the wall hanging phone, then came the another modified landline. Then came the garden phone, kitchen phone, go to the garden, cordless phone, then came the mobile phone. Ultimately, without your life cannot be thought of without the smartphone. This is the system. This is the telecommunication. Over 30 years, you shut your eyes and compare what is the science and technology over telecommunication. If you now go into the surface communication, in the last 75 years, you see what is the development of surface communication. The engine started from the coal, steam engine. Then gradually the steam went off. Came the diesel engine, then the electrical engine, then the faster train, super fast, diesel modification. After electric, gradually we saw the Vande Bharat. Then we saw the ultimate end is the till today as on date is the bullet. So as you see, there is tremendous development of science and technology in the field of telecommunication as well as surface communication over the last 75 to 100 years across the globe. So surgery should follow the same path. From regular times to robotic times. This is the robotic side. This patient is suffering from subfertility with stage 3 pelvic endometriosis, 33 years ready. We can't do, we could not do, I will never do this type of surgery in open surgery. We have to do the bilateral cystectomy. We have to clear a pelvis, POD or posterior compartment was not at all available to watch. It was plastered. Now at the end, what happens you see, at the end there is complete opening up the POD, and there are some boundaries. You have to conserve the ovaries, you have to preserve or enhance our fertility potential, and you have to do as much as you can. This is all about dissection in robotic surgery. You think yourself, any surgeon can think how minimal touch, minimal go. The surgery does not invite future. The POD is gradually becoming open. So robotic surgery is affordable now. It is acceptable. The patients are happy. We the surgeons are happy. So let's learn it. Let's do it. Let's enjoy it and let's love it. Let's teach it and let's propagate it. My take home message is make your own surgical team. In MIDS, maintenance of good efficient surgical team is more beneficial than the running after individual goals. Make your own surgical team. Thank you. Thank you very much.
Thank you very much, sir. Thank you for that excellent video as well. Thank you.
Any questions from the audience?
For example, I'm not a gynecologist, so I'm not asking anything. Ravana, any comments?
Sir, one question, sir, for yourself. Only if you would like to further improve anything in the current AG system, is there anything else you would think would benefit the surgeon and the patient?
Then my experience started giving out. तो नीचे से बड़ा ना हम तो बोल सकते actually sir लोगों को settle call and one side did I mean loud and even made put the
Makes it easy. Absolutely.
and it is I have done at least 70 cases. It is giving fantastic result. It is going home nature.
Thank you, sir. Thank you for joining us videos.
So now we are requesting Dr. Nishipana Doctor to present speakers and chairpersons.
একটাই বান্ডিল আছে না কিছু আছে ওখানে সাজা লাগিয়ে আর খোলাটা এই যে এখানে রেখেছি
Now we are moving on to our next patient on Flora and Speaker is Dr. Sumeet Roy, and the chairpersons are Dr. Parthasarathy Banerjee, Dr. Indranil Roy.
So, we welcome Dr. Sumeet Roy. It's a very important topic on suspected pneumonia and pneumococcal disease. Thank you, and a very good afternoon. Thank you to PLATINAT 91, Canada and India for inviting me for this topic over here. So, those who are basically working in the intensive care, they basically know that what is a ventilator-associated pneumonia, and it's basically one of the major problems in today's medical ICU as well as in the surgical ICU. So what basically the Indian scenario? So what we can see is like 9.7 to 40.1 case per thousand mechanical ventilator days. That is quite a high number, and it affects almost 6% to 46% patient in the Indian ICU. But the most important thing is the crude mortality rate that we can see is around 50%. And obviously, a loss that everybody knows is the average length of stay basically increases almost 21 days compared to the people who are not patients who are not having the
ventilator associated pneumonia. So what basically is happening? What is why this ventilator associated pneumonia is causing this sort of heaviness in the ICU setup? So one of the major things that today everybody knows about the antimicrobial resistance. So we have this thing like there are bad bugs, but we do not have much of the drugs, and there is no escape. So majority of the RAP is basically having with this escape organisms. So what are these escape organisms? So these are Enterococcus faecium, and obviously going back to the microbiology level on the third years, Staphylococcus aureus, Klebsiella pneumoniae, Acinetobacter baumannii, Pseudomonas, and Enterobacter species, some other bacteria over there. On the right side, if you can see that these are the basically the resistance mechanism that we basically see on a day-to-day basis in the ICUs. So what are the prevalence of the organisms of ventilator-associated pneumonia in India? One of the most common organisms is obviously the Acinetobacter baumannii. I do not know how many of you basically see it on a daily basis, but we do see almost 4 or 5 cases on a daily basis in our setup. The second most common and another most difficult one is the Klebsiella and Pseudomonas. So these are first three are the most important organisms that basically we face on a daily basis. And then the last thing comes from the gram-positive cocci group is the Staphylococcus aureus with the resistance of MRSA. That is the methicillin resistance Staphylococcus aureus. So what are the risk factors for India pathogens in VAP in ICU? Means cold patients basically can have ventilator associated pneumonia if they are there in the ICU. First of all is age more than 60 years. Duration of the mechanical ventilation is more than 7 days, and obviously most of these patients can get into a tracheostomy situation, prior antibiotic usage within the last 3 months, and presence of severe sepsis or septic shock at the time of ventilator associated pneumonia, obviously making it a difficult infection. ARDS specific the VAP, that means that there are few cases what we see is like there is a say viral infection and followed by there is a ventilator associated pneumonia that has happened over there. Renal replacement therapy, systemic corticosteroid therapy, and obviously if your institution is having a very high prevalence, that is more than 25% of MDR is there, then it can have an MDR pathogen in the lab. Now, classification of beta lactamase. This is a difficult thing for the clinicians. Most of the clinicians, why I have kept this slide, is because that wanted to show that the meropenem, imipenem, doripenem, whatever penems are there in the market, these are not basically very much effective today right now because of this carbapenems. So there are 3 categories. What we can see is that class A, class B, and class B. And everybody knows about class B because New Delhi metallo-beta-lactamase or the NDH that was in the news few years back, and it is still there very much in the ICUs. So if I see a carbapenem resistant enterobacteriaceae, that is the CRE, there are variable prevalence, obviously depending upon the ICUs, what is there. And most of the carbapenemase genes that we actually see on a daily basis are the NDNs and the OXA48, that is the class B carbapenemase over there. And some of them, there are basically classic KPC carbapenemase is also there. Now, what are the treatment choices? If you are handling, I think there is nobody there in the intensivist over here. Okay. Because I cannot see anybody's interest in this topic. Okay. Everybody is talking separately. So if you are there handling a patient in the ICU, these are the 2 most frequent genes that you are going to handle over there. One is this OXA48, another is the MDM. Okay. And sometimes it comes as a combination over there. Now, if you have got OXA48, everybody knows this name. That is a ceftazidime avibactam. is the B drug in the system right at this moment. And the another option where we cannot, patient may not afford this thing, we can go with the polystyrene polymyxin combination with meropenem or with aminoglycosides. But if it is an LDM one, then ceftazidime ivermectin is not going to work. There, basically, what we need to do is that there is a very new drug has come into the scenario is aztreonam avibactam that we are right now using. Previously, what we were using was the ceftazidime avibactam and aztreonam. Or there is another drug, also not available in Calcutta, is cefiderocol or polystyrene polymyxin, any of the things with a combination of tigecycline or fosfomycin and amikacin. These are some of the options for it. Now, if there is a co-production, this we do frequently see. If you can see this one, there is a 2% to 15% prevalence in the ICU. But in case of Escherichia coli, it is almost 8 to 55%. But fortunately, it is not in the respiratory infection, but in the urinary tract infection. So if there is a co-production, means both the enzymes are there, both these resistance mechanisms are there. So these are going to be our choices for the thing. Now there is another problem that has cropped up in the last few months, maybe around in a year. That is something what is called PDP3 inserts. In the particularly it is there with the E. coli, where this synergy nothing is going to work, and the choices are very less. And only some of the things like plasmomycin or phosphomycin may be an alternative to these things. So if you see this sort of things, say maybe a synergy negative E. coli or Klebsiella, then probably this is going to be your choice. So treatment of some of the KPC producing enterobacteriaceae. There are some new drugs, meropenem, vebrobactam, imipenem, cilastatin, velibactam, and all these are something what is called BL-BLI combination, beta-lactam inhibitor combinations. So these are some of the things that we can utilize over there. Carbapenem resistant Acinetobacter, that is another issue. So almost 40 to 75% in my practical experience, it is more than 95%. We see that this carbapenem is resistant. But the problem with this Acinetobacter is that ceftazidime avibactam, we cannot use it over there because Acinetobacter produces something what is called OXA23. So it may not be effective over there. So what are the choices? It is mostly related to sulbactam, durlobactam that has already been launched in the West. We do not have this over here. But some of the things like minocycline, tigecycline, there was one publication in the IDSA that even tigecycline, if it is less than 2 microgram per ml MIC value, then probably we can use that one in combination with obviously with the polymyxin or polystyrene. The preferable drug is polymyxin because of a little bit we can handle polymyxin better than polystyrene. So carbapenem resistant pseudomonas. Unfortunate thing is that we do not have much of the options over here. Only for the polystyrene and polymyxins, and particularly if a patient is having some bronchiectatic changes and some of the things, they are heavily colonized with this sort of carbapenem resistance pseudomonas. And if you look into the data, the polystyrene resistant pseudomonas is slowly creeping up. Treatment options. So here are some of the treatment options for carbapenem resistant pseudomonas. Ceftolozane, tazobactam, but in my practical experience, it's not in vitro sensitivity is not very good for this ceftolozane tazobactam at this point of time. So here are some of the new BL-BLI combinations, although the slide is a bit hazy. So some of the new things that is basically coming up. And here is another list of new BL-BLI combinations. These are coming up. Mostly targeting, some of these are targeting Acinetobacter, some of the targeting this Klebsiella. And probably in few years we can get it into the ICUs. Methicillin resistant Staphylococcus aureus, another in multi-drug resistant organism. So if I look into the option for the VAP, one of the best options is likely the teicoplanin because of better penetration into the lung tissue. So that we can use. Dactomycin, you need to remember that it cannot be utilized in case of a respiratory tract infection because it gets inactivated by the lung surfactant. So right-sided, say, infective endocarditis, as well as for the lung infection, dactomycin is not a choice. Another problem with the MRC is the creeping MRC. So MRC, how we do see the thing, 0.25, 0.5, let's say doubling the thing, 1, 1.5. If you see that there is 0.5, the clinical rate changes when the MRC goes to 1. So it is very important that whenever you send your culture, ask for an MIC based report, antimicrobial susceptibility report, that will help you to decide what should be the dosing of the vancomycin. So decreasing that molecular diagnostic, what basically we do, we use something called the syndromic approach, and this is something, suppose for example, biofile is one of the things that we go for, the thing, the pneumonia plasma. And if you see this, there are various organisms, and obviously the genes are also there, antimicrobial resistance genes. So whatever we are talking about, OXA48, MDM, and everything, we can take a decision within few hours. Now we do not have to wait for the culture for about 48 hours. So these are the antimicrobial resistance genes that we look for. This provides a semi-quantitative result. You need to understand that respiratory tract is having a commensal organism. So if anything coming positive, it may not be the pathogenic one. So the cutoff is usually more than 10 to the power 7 copies that we basically look into. If you have used biofile, you are very much comfortable with this system. Another system, those who are doing this phenotypic one, this is an AI-based system coming up with the pattern recognition. If the first one is a ESBL, the picture is a bit hazy, but with this pattern recognition system, we can now actually from a phenotypic result, we can conclude that whether what should be the resistance mechanism over there. So in summary, so some of the things that has been already given, and if for the diagnosis, serum procalcitonin should not be used as a diagnosis for the VAP, but for the monitoring of the VAP. In case of MDR GLBs, where ceftazidime avibactam very high risk, there you can use a combination. Polymyxin B is preferred than cholesterol, and obviously the last one is that a deep sample is always better in case of diagnosis of the VAP, and rather than like bronchoalveolar lavage. Multiplex PCR is another thing that we should be including into the diagnostic system. So with this, I just like to thank you for the patience.
Thank you, sir, for your elaborate insight into that. And finishing in time, could you please give us some tips regarding the prevention of that?
So the prevention of VAP is one of the major part of the hospital infection control program over there. So many times just giving you some of the example. Open suction system. Suppose for example a VAP is there is a secretion is happening inside the lung, and intermittent suction is going to be required. Now what I have seen, a small office nurse is going for the suction, opening the thing, and the suction catheter is almost one length of her hand. Okay. So they are touching it everywhere in the environment, and then she is putting it over there and just doing the suction. So these are some of the things that is not there. So there are some preventive strategies like the pressure, balloon pressure, so that there should not be microscopic aspiration. The VAP bundle implementation that basically we look into on a daily basis, that whether that has been implemented over there. So these are basically an integrated program inside every ICU. Most of the big hospitals are basically following those things.
I have one comment.
I was just wondering if you could tell us if you are getting any cholesterol resistant bugs in your ICU. Yeah, cholesterol bugs are coming very frequently, but mostly concentrating on the pseudomonas. Okay, and the picture is a bit different. Like say, beta lactam is sensitive, but cholesterol is resistant, and expecting a pouring channel related some sort of a resistance mechanism is there. But okay, at this point of time, it is making it. We are not getting very bothered about the thing, but some of the times it may be in a month, 2 or 3 patients we are getting on the pan resistance, over there, particularly with the pseudomonas, not with the other things, not with the Klebsiella E. coli at this point of time. But pseudomonas is going to be a difficult one in the future. Thank you.
Any question or comment from the audience?
So now we are requesting Dr. Rajat Banerjee to present our speaker and chairperson. We are moving on to our next session on lipid targets in primary and secondary prevention. And the speaker is Dr. Arindam Pandit. And the chairpersons are Dr. Parindranath Malik and Dr. Suparna Bhattacharya.
Good afternoon, everyone. Welcome to the session of lipid targets in primary and secondary prevention. Welcome, Dr. Arindam Pandey. He's the director of Cath Manipal EM Bypass. Let's hear him what he has to say. Please, sir. Stage is all yours.
Thank you very much for having me. I'll be talking on the targets in lipid management. We all know lipids are very important. Probably it is little more important than your sugar and blood pressure, because in different cohort studies it is found that probably it is only cholesterol which is most closely associated with the development of atherosclerotic plaques. So for that we all should know the target of our cholesterol treatment. Now, we all know the foundation of lipid risk. There are multiple foundations, and how the thing starts. It starts at a childhood, when the people are still at school age. Then it is actually developing. It starts with a fatty state, and then gradually more and more cholesterol deposition and atherosclerotic plaque formation. But the problem is, only one value of cholesterol is not important. Nowadays, we are talking about one concept of cholesterol years. So if your cholesterol is elevated, how long it is elevated, that is probably more relevant than a particular single value. So keeping that in mind, it is important how nicely you control your cholesterol overall throughout your life. That will explain the development of heart attack, stroke, and multiple other things. How this shows, there are multiple trials to show that if we can reduce the cholesterol, it will definitely translate into benefit, particularly
many different streams of physicians who are present over there. So I wanted to make it very simple so that everybody can actually remember what is the LDL target, because target is very important. Now overall, someone who is considered high risk for primary prevention. Primary prevention, what does it mean? The patient is not to develop any heart attack, no brain stroke or no heart cardiovascular end event. There we are trying to prevent the first event. So for that, if there is multiple risk factors. Patient is diabetic, hypertensive, strong family history of premature atherosclerosis, then LDL has to be less than 70. If the risk is borderline or moderate, then a good target can be less than 100 milligrams. So that is the rational target. Now, primary prevention at the same time, along with LDL cholesterol, there are multiple risk enhancers. Say, for example, we do not focus on triglycerides, but triglycerides may be important, particularly in Indian scenarios. Similarly, someone who is having chronic kidney disease, so CKD is considered as risk enhancer. So if they are present, then probably we need to be little more aggressive for our lipid target. Now, secondary prevention, what does it mean? Already the patient is having one heart attack or brain stroke, where the LDL target has to be more stringent, because the chances of second event is always very higher. So, similarly, you can see the LDL target irrespective of the other risk factor. Anybody who has already one event, LDL has to be less than 55, and we should be little aggressive in the management. So this is the summarization in a nutshell. For primary prevention, multiple risk factor 70 is a reasonable target. Moderate risk factor 100 is a reasonable target. For all secondary prevention, less than 55 is a reasonable target. Now, there are something beyond LDL, because if we can achieve the LDL target, still some patients will develop heart attack. So researchers they try to find out what else can be there. So I mentioned about triglycerides. Similarly, because triglyceride trials are very controversial, because the different trials with the different results. So there was a new concept of non-HDL cholesterol, which actually includes some form of triglyceride. So if you find a patient with high triglyceride, so you can actually, after target of LDL is matched, then you can go ahead with non-HDL target. Generally, the non-HDL target is 30 millimeter more than the LDL target. So you can see the high risk, moderate risk, accordingly, it is around 30 millimeter high. And sometimes in diabetic individual, it is very reasonable to go for ApoB, because in diabetic individual, there is something known as small dense LDL. So the LDL level overall is not very high. But if we can measure the ApoB directly, then we can probably get a better understanding of the risk factor, so we can target ApoB in those cases. Now, having said that, these are the overall easy to understand, easy to remember target for lipids. But it is said that in India, we developed heart attack and all of the cardiac events around 10 years, that is one decade earlier than our Western counterparts. Why? Because of our tremendous high genetic susceptibility. So that is why many people, many schools, they say that in our country, this lipid target should be even more stringent. So I will show you some of the targets. First I will show you beyond just blood parameter. There is something known as coronary artery calcium score. So if your calcium score is 0, you are fine. But if it is more than 100, it is abnormal. And if it is 100 to 1000, that can be another indication that you need at least moderate intensity lipid lowering. If it is more than 1000, then you have to be very aggressive. Your lipid should be less than 55. Now, it is not a routine to look for coronary artery calcium. Why do we look for coronary artery calcium? Where we have some confusion, doubtful situation, where only the lipid parameter or lipid profile is not giving us a proper solution. There, in this borderline kind of situation, we can look for coronary artery calcium score. Similarly, lipoprotein lipidase is also very important. It is said that whoever is receiving treatment for any lipid disorder, at least once in a lifetime, he should look for lipoprotein lipidase. Because in South Asian region, some people have very high lipoprotein lipidase. Fine. So at least one measurement is important. Now there are dedicated therapies for lipoprotein lipidase
form of pelacarsen, but those are very expensive. So what I advise to my patient, if your lipoprotein lipid is also elevated, then probably you have to be more aggressive with your LDL target. If your LDL target was 70 as per your risk assessment, at the same time your lipoprotein lipid is elevated, then probably you can think about further 15 to 20% reduction of the LDL target. So that we can jolly well do, but to understand that we should at least get one value of lipoprotein lipid. And this is the Cardiological Society of India 2024 guideline. As I mentioned, we Indians we are at a high susceptibility for premature ASCVD events. So we can see the target for Indian population has also been lowered by Cardiological Society. And there was another association known as Lipid Association of India. They are in fact even more aggressive. You can see in some of the patients very high risk. Say for example, polyvascular involvement. Patient who has developed stroke, same patient has developed heart attack as well, or recurrent event at a very young age, or strong family history. We get this kind of patient. So in those kind of situations, a very stringent LDL target of less than 30 is proposed. You can see the algorithm. So you actually should assess the patient on the basis of risk factor and number of events, right? How do you reach to that very stringent LDL target? For high intensity statin, we have two options. One is rosuvastatin, another is atorvastatin. So with that, you can expect a 50% reduction of LDL. But some patients actually with this event, 80 milligram of atorvastatin, your LDL target may not reach. So there, one molecule known as ezetimibe 10 milligram, you should add. So this is very easily available, very low cost molecule. And nowadays there are combination of atorvastatin as well as rosuvastatin with ezetimibe. So single pill can be sufficient. But if it is still not controlled or target is not met, then another oral molecule in the form of bempedoic acid is there, which is easily available in India. It is available at a dose of 180 milligrams. Some companies they have come up with a combination of ezetimibe and bempedoic acid as well. So we can use that. But very fraction of patient, around 10 to 15% patient will be there, where after using all the three oral medicine, your lipid target may not actually be achieved. There we use injectable molecules. There are two options in injectable molecules. One is PCSK9 inhibitor and second is inclisiran. Inclisiran is a very novel medicine. The dosing pattern is initial dose followed by 3 months, then every 6 months injection. Whereas the PCSK9 has to be given twice in a month or at a higher dose once in a month. But they are all injectable. They are very expensive as of now. Probably in future the price will come down. But it is better to go for expensive injection for prevention rather than having a heart attack at a young age. Lifestyle intervention is very important, but it is very effective for triglyceride lowering. We should be very clearly understand that LDL actually cannot be controlled on the basis of lifestyle alone because it is mostly genetically determined. You can mostly do around 10 to 15% reduction of LDL by lifestyle modification, not beyond that. So most of the patients with high LDL, they are candidates for pharmacotherapy. Now, I am talking about target of LDL which is very low. Most of the guidelines suggest anybody who has a heart attack should have LDL of less than 55. Our own Lipid Association of India consensus statement suggests we should achieve a LDL of less than 30 in some of the patients. Now the question comes, if you go that low LDL cholesterol, is there any harm to the body? So that is also important. We should try to understand that. So there are many proposed side effects. Say for example, hemorrhagic stroke, cataract, new onset diabetes. Many people say if you go reduce the LDL to that great extent, there can be dementia. So let us try to understand. This is the high intensity statin. So you can see there are some genetic variation, and there are some ethnicity of the world. Say for example, Eskimo, they have a very low LDL irrespective of age. In young people, everybody has a low LDL, but in Eskimo, their LDL is less than 25 throughout the year, throughout the adulthood as well. And it is said they have very high risk of heart attack and they live very long. Their life expectancy is very long, and throughout their life, they do not experience any problems. So this is a natural example. At the same time, there are some
genetic mutation. Say for example, PCSK9 loss of function mutation. There you can find the mean LDL is to the tune of 14 milligrams. Is there any problem with those individuals? There is no problem. There is benefit. They do not develop stroke, they do not develop heart attack, and they do not have any other issue. Yes, there are some congenital problems. Say for example, abetalipoproteinemia. Their LDL is also low, but at the same time, because of a problem in the absorption of the fat soluble vitamin, they develop many neurological problems. But only low LDL actually is not a problem. But at the same time, you should also understand all the cells they require cholesterol for the membrane, cell membrane. But the issue is all the cells of our body actually they are self-sufficient to produce their own cholesterol. They are not dependent on blood cholesterol. Fine. So that is important. At the same time, we talk about dementia and higher chances of hemorrhagic stroke, but you should be understanding that none of the lipoprotein they cause the blood-brain barrier. So whatever your blood cholesterol is, that should not have any effect in the central nervous system. Fine. So these are all actually myths. So actually the benefits are counterfeit. The risk is very, very low. This is one of the meta-analysis which suggested the liver dysfunction, hemorrhagic stroke, dementia, all these are actually not true. It is not found in real world situation. But the issue of new onset diabetes actually is true. If you use high intensity rosuvastatin, there are signals that suggest if you use 20 to 40 milligrams, the chances of new onset diabetes is higher. But the issue is whether they are actually problem for the patient or not. Because people say actually it is unmasking of the diabetes. All the people who develop diabetes with high intensity statin, they are actually happen to be diabetic after 2 3 years. So basically it is unmasking. So you get good option, good opportunity to treat this patient. Because in type 2 diabetes, actually the people they develop most of the problem and complication before the diagnosis of high blood sugar. Because it's a continuous process. So if you get an opportunity to treat them, because there are multiple new good medicines. You have SGLT2 inhibitor, you have GLP-1 analog. And if you get this kind of high risk patient, you can initiate those medicines, probably the risk will come down. So future is very bright. I think I should stop here. So what I wanted to say, LDL is very important. You should not ignore your LDL. And always try to achieve a LDL target which is suitable for your patient. And that is the only way out. You can prevent many of the heart attack and stroke because those are very devastating. Thank you.
Thank you, Dr. Pandey, for making very easy about lipid targets for us. Any questions?
Lipoprotein should be done in the very first go when you do the keto. Do you agree? For the very first time,
You can do that. You can do that. But the problem is India is such a huge country. We have 144 people. So if you want to do lipoprotein A to the all the Indian population, then it's a very huge cost. So that is why we suggest anybody who is a candidate for lipid lowering drugs, any therapy patient is receiving, then at least one lipoprotein lipid measurement should be done. That is rather more cost-effective way of looking at it.
second is how low is too low for LDL? Because beyond which level there is no extra added benefit. Is it 0.23? There is no extra added benefit.
So it is very hard to say. We cardiologists, we now see LDL cholesterol as like eradication of polio. If you can eradicate polio, you can eradicate LDL, there is no issue. But most of the trials, evidence suggests if you can reach less than 30, beyond 30 there is not much of additional benefit.
So if there are no more questions, so we'll end this section. Thank you so much, Mr.
Doctor, hang on here please for a second. Dr. Rajesh Pawar is going to facilitate Dr. Pandey and the chairperson.
Thank you.
Thank you, doctors. For the next session, I would like to invite Professor S.N. Sarvadikar to the stage. Professor Sarvadikar will speak today on how best can AI tools be utilized by healthcare professionals. And to chair the session, I would like to welcome to stage Dr. Sudhir Saha, Dr. Bhuvul Bhukachukay, and Dr. Anand Das. Dr. Khalil, Bulbul, Bulbul, Dr. Khalil, Dr. Khalil, সবাই এই সব জানে সবাই
Teaching, I believe, sir. Dr. Shubhendranath Sarvadikari. It is an honor to have him here because his talk is basically a shift out of the core topics that we have been discussing today, the requirement of AI for clinicians. Sir, the stage is yours.
Thank you very much. And thank you for inviting me here. So, what am I going to talk about? Say, healthcare professionals can best utilize the AI tools by integrating them to mostly automate the administrative tasks. That's the simplest, easiest, and least harmful. Second is for enhancing diagnostic accuracy. And of course, to personalize patient care so that you can get more human interactions. In fact, there's often a complaint that the patient is not being talked to, the doctor is looking at the computer or the phone like that. So key applications include using AI for medical imaging analysis, predictive analytics for early diagnosis, clinical documentation tools, and virtual patient engagement assistance. I'll skip these parts. Essentially, what it is, we never had actually a healthcare 1.0, but it's in retrospect we look at it. So the third generation of healthcare, the electronic health record came, remote care, telehealth. Now we are into the fourth generation healthcare, smart health, connected care, personalized medicine, precision medicine, and AI is very much an integral part of it. So AI is essentially an umbrella term, and it is more to do with whether a machine can act like a human being. And of course, machine learning is one of the tools through which we can apply AI. Now, AI, what we are applying is in the field which is now known as digital health. Digital health, the division of digital health was formed by the World Health Organization as late as 2019, but just before the COVID-19 pandemic. So, COVID-19 pandemic is supposed to be the CTO, the Chief Transformation Officer, which made the world adopt digitalization in a big way. And two of the domains which were affected the most include health and education. One of the first things that this digital health division of WHO did was brought out this global strategy on digital health 2020 to 2025. And here they defined digital health as a field of knowledge and practice associated with the development and use of digital technologies to improve health. Digital technology was earlier known as ICT, or Information and Communications Technologies. So this is a pretty simple definition, but actually it's a very huge spectrum. It covers e-health, that means applying the internet for healthcare, m-health or mobile health, and of course telehealth. So that includes telemedicine, telesurgery, and all the branches. A few other terms which need clarification. Digitization is simply converting the analog to digital. So when we were kids, we used to see analog televisions, but now we don't see it anywhere. Everything is digital, even the clocks and watches and so on. Digitalization, and don't confuse it with medicine or cardiology term. Here, digitalization means the process of using digital data to simplify the work. That means the organization, work culture, everything changes. But what we are really looking at is digital transformation. That means a complex, multifaceted, and disruptive way of changing the way healthcare is delivered, of course, centered on public health needs.
This particular slide is from the National Health Authority from the ABPA, from Biodigital Mission. So the challenges they mentioned first is the ecosystem, that means non-standardized processes for digital health initiatives, lack of digital records for accurate delivery of health services by restaurants. It's not yet legally mandatory in India. There are also technical challenges. Engagement between providers and patients are dictated by the platform, so we are very much dependent on the vendor law, and generate those standards and infrastructure. All those standards have been recommended by the Minister of Health and Family Welfare since 2013, but still it's not really followed to a great extent. Even if you look at the National Medical Commission or the erstwhile Medical Council of India, they brought out the CBA, the Competency-Based Medical Education in 2018. There, one of the goals for the Indian medical graduate is to become a leader and member of healthcare team and system with capabilities to collect, analyze, synthesize, and communicate health data appropriately. But details are not there. For this, what you really need is you have to have health data literacy. So we need the human resources for healthcare. They definitely must be technology enabled, but at the same time, they must be safe and ethical. So there have been some guidelines for that. The Indian Council of Medical Research and the National Academy of Medical Sciences both brought out some guidelines in 2023. I was the co-chair of the task force on AI for healthcare for the National Academy of Medical Sciences. In the legal field, the National Health Policy Act talked about the third edition, 2017, talked about the setting up National Digital Health Authority. But that was ultimately withdrawn in favor of what is the DPDP Act, or the Digital Personal Data Protection Act 2023, under which Digital Data Protection Board is supposed to be formed. It has been notified, but it's not yet fully functional. Then another law which is applicable, that is Medical Devices Rules 2017 and under 2020. Their software as medical devices included, and these require approval from formal approval from the CDSCO. Another thing, the Government of India has brought out this year in February, strategy for artificial intelligence in healthcare, that is SAHI. So this is the law DPDP Act on the left, and on the right you can see the SAHI, the strategy outcome. So this is the theoretical background, but where do we actually get the real-time applications? So I'm skipping this part because initially it was supposed to be a 20-minute talk, but we are showing only 14 minutes. So initially, how are we progressing to artificial intelligence? Initially, when we are getting the information at a small amount, we were using descriptive analytics, going to diagnostic analytics. But now with the computational power, the AI capability is increasing so much, we are going for the predictive analytics and prescriptive analytics. So this is what we are trying to move towards, this general artificial intelligence. Now, any data, medical data, clinical data is multimodal. And therefore you have to go through all text data, sound, audio data, images, then the electronic health records, the signals like EEG, ECG. Then we now also get the omics data, the genomics data. It's affordable, and of course, based on that, lots of research is going on. Literature is available. From that, we go to clinical decision support systems, and these are some of the various applications. So, if we talk about a clinical decision support system, again, there are various classifications for it, but this one I think is a good one. So, for preventive care, there are clinical decision support systems for immunization, screening, disease management guidelines, for secondary prevention. For diagnosis, there are solutions for possible diagnosis that match the patient signs and symptoms. Then for planning for implementing a treatment, drug doses, recommendations, especially drug-drug interactions, drug-food interactions, drug disease interactions, and so on. Then follow-up management, all reorders, reminders. Then for hospital providing efficiency care plans to minimize the length of stay order sets, and cost reductions and improve patient convenience by reducing duplicate testing alerts and so on. So one of the issues with AI is if it acts as a black box, how can we trust it? So one of the methods that's being overcome is by this XAI, or explainable artificial intelligence, where the AI system actually tells you how is it reaching a particular inference. So here it's shown exactly how it does so, and there are lots of publications on this. So what exactly is XAI doing? It is telling why this particular thing happening, why not the other way? What if this happens? Or how to do that and stuff. So this is how the XAI systems work. Of course, for XAI also there are certain issues, limitations, and work is going on, a lot of research is going on for developing better predictive models. Now I'll give some examples of the real world use cases of AI in world healthcare. One of the areas where a lot of work is going on and a lot of commercially available software systems are available for sepsis management. In the standard protocol, what happens? You measure lactate, give fluids, and so on. But AI monitors the vitals continuously to detect sepsis even before overt symptoms and can auto-order the lab support detection. Then for antibiotic stewardship, we have heard a lot about those multi-drug resistant organizations. In the morning, you heard about pharmacovigilance. So normally it would be review antibiotics after 48 hours. Whereas AI-enabled systems can analyze culture results at 24 hours to suggest de-escalation or cessation automatically. Then in oncology care, AI calculates the body surface area from scans and record checks for drug-drug interactions specific to the regime. In maternal and child health, AI can track blood loss visually and trigger the PPH protocol when thresholds are exceeded. So what's the difference between the traditional protocols versus the AI-enabled protocols? In the traditional protocol, we can see the trigger is a human memory or manual checklist, whereas AI-enabled protocol is automatic data trigger. You can get directly from the electronic medical record values. Personalization is low in traditional, high in AI-enabled. Compliance is variable, prone to error, prone to fatigue. But in AI-enabled system, it's high. Automated measures on hard stops. Updates are slow in traditional methods. Guidelines take 3 years, 5 years. Whereas AI-enabled is a real-time dynamic advancement. Complex cases often fail because expert consult with traditional methods, but AI science protocol adaptation based on the similar cases. So what are the common AI tools? As I said, the common things where we can apply is for reduce administrative burdens, improve diagnostic accuracy, and enhance patient care. And this can be done by integrating with the EHR so that the doctors can focus on ambient clinical documentation, using analysis, decision support. So what are the tools available? I think Nuance Dragon ambient experience, many of you are familiar with, can average those real-time transcription and summary generation with explainable AI highlighting the information source. Then Suno.ai, specialized in creating clinical document drafts from conversations and capturing lab imaging orders. And free automates clinical documentation works in real time to generate summaries. Then what are the available tools for imaging and diagnostic support? The second set of eyes. AI doc focuses on emergency radiology, analyzing images immediately to track the critical findings like strokes or infected hemorrhages. Wiz.ai uses AI for detecting suspected diseases, particularly stroke indicators and notifying clinicians in real time. Luminetics Code, the former name is IDX that's an US FDA approved AI for diagnosing diabetic retinopathy at the point of care, so that immediate reference can be done. With GI Genius, it's a backup camera for colonoscopies that highlights suspicious polyps in real time. And there are some others like AI Rat Company and Geekmatic and so on. What are the common tools for clinical decision support and research? Consensus AI, Dimensions AI, their search engines tailored for doctors. OpenAI is used. Research is an agentic AI can act as a research assistant. Regard integrates with EHRs to analyze patient data, assessing differential diagnosis or autogenetic clinical notes. Actropos Health delivers real-world evidence insight for clinical questions. And of course, our own very familiar ChatGPT plot. They can summarize patient history, assistant coding, provide quick evidence-based answers, also be used to develop research questions, methodologies, counter arguments, and so on. For data management or analytics, the common tools available are DataSphere, DAnswer, Dimensions AI. For specialized research, Consensus, QuestionWell, Google Notebook LM, and for writing well, SageSpace, Gemini AI, ChatGPT, Cloud, Gemini Perplexity, all are used. Then the very important thing, which is absolutely essential if you want to use those LLMs, like ChatGPT, prompt engineering. That means drafting precise instructions for the AI models to enhance the clinical workflows, summarizing the patient notes, generating clinical documentation, assisting in diagnosis. So how do you can do that by specific inputs. So here are some examples. For patient education, you can give a prompt like act as a physician, explain the mechanism of action for lisinopril to a patient with 8th grade literacy level. For documentation, it could be something like summarize the following patient interview with the standard SOAP note format. Then for research, summarize the key findings of this article focusing on the limitation of the methodology. So what are the best practices and limitations? Iterate, go on doing it repeatedly, not one time only. Data security, never input personally identified information because that will violate the DPDP Act, GDPR, HIPAA, those laws. Verify, always verify the generated content for accuracy of hallucinations, specificity, avoid ambiguous queries, detailed context-rich queries in better results. So essentially, at all phases, as a healthcare professional, whether you are collecting data, training, using the data to train the AI model, developing it, refining it, making a better response, and verifying it, because validation has to be both clinically as well as technologically. Brain and computer together is always better than either alone. And therefore, AI is not going to replace the healthcare professional, but definitely doctors who are not going to use AI will be replaced by doctors who are using AI. And that's the end of my talk. Thank you.
Thank you, sir. I personally in favor of AI, but my HOD, he always says that you don't use it. Definitely it makes mistakes, but if you give the inputs that I am a doctor or I am disqualified, I have seen AI giving a much more better prompt than just not giving inputs. I have definitely. I've used it for my research and all that. It's really helping in research and making PPTs, PowerPoints, and also to get the answers for questions because we now go to go for examinations and checking answers. Actually, we have forgot everything. We have to get the MCQ answers. One shot it gives the answers very quick. So one who is using AI will be definitely beneficial. Definitely, as you said, one who is not using will be replaced by a person who is using AI.
To use only after verifying so that the information is not as correct. Verification.
But always, sir, when we are putting the MRIs and all that, it doesn't give always the correct answer because the inputs are, I think, so not correct. I think. So if I don't give the inputs.
Image analysis, why can an AI system do better? Because see, the amount of processing that it can see the number of images, the points in the whole scan, it can see in that time. No human brain can do it. It's physically impossible for us. So definitely machine has its advantage that we should take, right? Like right now the medical knowledge base is advancing every 50 to 60 days, in less than 2 months. It is humanly impossible for anyone to keep track of all the knowledge that is up to date. So we have to take support from that. But as I said, we have to trust but verify.
About health service, and really AI is now usually approached in health service too. Because the modules, the chart that they use as per community medicine department involving the gynae department. So that is really changing the modules capacity and the outcome of knowledge that is bringing up nowadays. That is gradually what you say, meet up the gaps, which we will know later, come by books. That is coming very fast. That is, and to sum up, the algorithms are very simplified in each language, which are understandable to the common people. That is also very important nowadays because charts were previously mostly in English, but now also in common language, explained to them, which is not even needed by us to demonstrate and also explain. They are just wanting a proper answer for one reason, that is it. So AI is gradually intervening into the common people too, either through them, because the questions are also from them to us in the health services system, in the secondary tier, tertiary tier. They are also asking directly questions which were previously used to explain. So thanks to AI nowadays, which have gradually reduced in whole. Thank you.
To sum up, I'll just say there is immediate challenge to people in medical education. There are a lot of faces out here who are in medical education, sir. As we mentioned in the 2024 CDME, in the first year itself, phase one itself, our core competency is AI in our subject.
That's an elective.
No, not elective, sir. In the phase one, we don't have electives. It is core competency, sir. And the point is there now the biggest challenge to all of us here who are in medical education to frame the SLOs for those AI. Unless you have SLOs, we cannot go for assessment or we cannot go for teaching. Thank you so much, sir.
Thank you, Professor Savali. NLC has a lot of catching up to do. That's a sad thing. That's a sad fact.
Thank you, Prof, for this very time appropriate talk. I would request Dr. Sumita Datta to facilitate you and the chairperson. Thank you. Ladies and gentlemen, very quickly, we are coming towards the end of this very academically interesting day. For the next section, I would like to welcome Dr. Viplav Dole on the stage. Dr. Dole would deliberate on basic management of orthopedic trauma patients. And to chair the session, I would like to request Dr. Gulab Murtaza and Dr. Sumit Gulati, please.
I also hope so. So in the previous talk, we have heard about AI. Honestly, I am also taking the help of AI to prepare my talk. After listening about latest treatment in different discipline, now I am taking it back to a basic MBBS base. If any road traffic accident happens or if patient falls in front of you, as a medical professional, you need to provide some basic care that can save a life, even in sometimes can save a limb. To know about triad of trauma care, your first importance would be to preserve a life by taking care of ABC, that is airway, breathing, and circulation. Next important point would be to preserve the limb. You need to check the distal pulse. If there is any vascular injury, then you have to refer the patient to a specialist so that you can save the limb. Last comes the restoration of the functions where rehabilitation specialists will take upper hand. We also know about the golden hour. You need to start your treatment within 1 hour. You can reduce mortality rate up to 10%. Whereas if you delay your treatment more than 10 hours, then mortality rate would be as high as 75%. So you have to initiate your treatment within 1 hour. Which patient you can treat at your clinic or at your small setup when the patient is hemodynamically stable and suffering from simple fracture, there is no neurovascular deficit, and patient is not having any medical comorbidities. Whereas the patient is having unstable pelvic structure or spinal injury, you need to refer the patient to higher setup. If there is associated head injury or vascular injury, again you need to call for specialized treatment in a tertiary setup. You know about AQLS protocol. You need to take care of airway breathing circulation as a primary survey. As an orthopedician, our third role comes in secondary survey. We need to assess whether the patient is having any life-threatening injury or not. If he is having any fracture, you need to immobilize with the help of plaster of Paris. If the patient is having any kind of dislocation, you need to reduce it. Then again, you need to immobilize it. And then you need to ask for X-ray and CT scan depending upon the situation. If the patient presents with a trauma, you need to take detailed history. What is the modality of injury, whether it is a simple fall or a road traffic accident. Then you need to do clinical evaluation, palpate the area, evaluate whether there is any tenderness or not, check the range of motion, look for any underlying fracture. You will usually get some critical or abnormal movement at the trauma site. Check the distal pulse, neurological examination, look for any compound fracture, whether there is any overlying soft tissue injury or not. On X-ray, you should be able to identify whether the patient is having fracture or dislocation. In the first X-ray, patient is having elbow dislocation, and the second X-ray, patient is having ankle fracture. These are the basic things you need to identify in the X-ray. Then you need to assess whether the fracture is a closed fracture or open fracture. Management of these two fractures are completely different. In closed fracture, you can immobilize it with a plaster, whereas in open or compound fracture, you need to refer the patient to a higher setup where patient needs immediate debridement and external fixation to stabilize the fracture. What are the emergencies clinical issues? If the patient is having excessive internal hemorrhage, particularly in pelvis fracture, you need to stop that by applying some compression bandage. In case of open fracture, when there is external bleeding, again you need to clamp the blood vessels. You need to restore the pulse by manipulating the fracture. If there is any compression in open fracture, you need to irrigate and debride it and look for any compartment syndrome, which is another limb-threatening situation. If the patient is having compartment syndrome, you need to address that immediately. We have the various forces acting on the bones, which can lead to fracture depending upon the amount and direction of force. Your fracture geometry would be different. It may be transverse fracture if there is any bending force. If there is any torsional force, again there will be oblique fracture. How to describe a fracture on X-ray or in clinical situation? You need to assess whether it is a traumatic fracture or pathological fracture or a stress-induced fracture, because treatment are different for different mechanism of injury. Then which bone is involved? Is it a tumor or is it a tibia? You need to identify the anatomical area. Then whether it is intraarticular or extraarticular, what is the amount of and direction of displacement, whether there is articular surface involved or not. Look for any soft tissue injury. If there is any soft tissue injury, again your treatment modality would be different. How to read an X-ray? When you are advising for X-ray, then you need to ask two plane, that is AP and lateral view, two joint, that is one joint above and one joint below. Also, which area is affected? Is it epiphyseal area, metaphyseal area, or is it diaphyseal area? Again, treatment modality are different. What are the basic strategy? If the patient is having a fracture, you need to stop the bleeding immediately. Then you need to immobilize it. You can use for immobilization whatever available in front of you. If plaster of Paris is available, it's okay. Not available, you can use stick, paper, or umbrella to immobilize the fracture. If the patient is suffering from simple strain, that is ligament strain, we know about ice therapy, that is painkiller, rest, ice compression, elevation, so that patient becomes comfortable. How to do splinting? We know that how to apply plaster of Paris, it will reduce pain, it will stop movement at the fracture site so that it can reduce subsequent damage to the soft tissue. Traction, next mode of immobilization, it can be surface traction or skeletal traction. Surface traction usually we prefer in pediatric population, or a skeletal traction where you can put excess amount of weight is preferable in adult patients. Another mode of immobilization is external fixator. This is preferable when there is associated soft tissue injury or compound fracture, particularly. Another mode of immobilization is external fixator. This is preferable when there is associated soft tissue injury or compound fracture, particularly. Another mode of immobilization is external fixator. This is preferable when there is associated soft tissue injury or compound fracture, particularly. Another mode of immobilization is external fixator. This is preferable when there is associated soft tissue injury or compound fracture, particularly. Another mode of immobilization is external fixator. This is preferable when medically immobilized patient for long prolonged duration may suffer from compound syndrome. Patient who have excessive pain in the limb, on clinical evaluation, you will see there will be increased pain on passive stretching, there will be paresthesia, paralysis, pulselessness. These are the clinical signs for compartment syndrome. If the patient is having compartment syndrome, they need immediate fasciotomy within 6 hours, otherwise there will be irreversible changes. This is all of our patients presented with proximal tumor, proximal tibia fracture, or locate there was compartment syndrome, compartment, distal walls are reduced, we have to do immediate fasciotomy, subsequent surgery, and cover the area. Flash injury, another serious injury, again, whole being flash, particularly after road traffic accident, we need to apply it, we need to immobilize it with the help of external fixator, need multidisciplinary approach, including plastic surgeon, general surgeon, orthopedic surgeon, limb and mechanical surgery. In this fracture patient, hemorrhage is usually devastating. There will be intrapelvic hemorrhage, sometimes that may be life-threatening. We need to put some compression bandage around the pelvis to reduce bleeding. If you are successful, then it's okay. If you are failing to control the bleeding in spite of your best effort, then you need to apply external fixator. At the end, you can do embolization of the bleeding vessels by the help of interventional radiology. This is one of our own patients presented with pelvis fracture. He was having excessive bleeding inside. We had to do immobilization with bandage. To fail to control it, then we put external fixator. In spite of that, he was bleeding inside, and we had to do particular immobilization. To stop the bleeding. Then you need to balance whether you are going for damage control orthopedics or early definitive care. Depending upon the practice geometry, overall situation, you need to check which one would be better for the patient, whether damage control orthopedics or early definitive care. Manual extremity, again, whether early amputation or limb salvage procedure, individualized approach, multidisciplinary approach. Sometimes early amputation can give better result, but if you want to save a limb, you need multiple surgery over a prolonged period with the help of plastic surgery and others. To study the age of a patient, relative hip fracture is usually associated with multiple comorbidities, but if you operate within 48 hours, your overall result will be good. If you delay the surgery more than 48 hours because of medical ground, then your mortality rate will be very high. So you have to operate within 48 hours if a pediatric patient is suffering from particularly hip fracture. Another extreme age group, pediatric patient suffering from supracondylar fracture. If a young kid fall in front of you, suffer from elbow injury, the first thing you need to do is the distal radial pulse. If the pulse is absent, it's a life-threatening situation, then you need to refer the patient immediately to a catheter to save the limb. Then you need to look for coagulation abnormalities. Fat embolism, another life-threatening complication of orthopedic patient. If the patient is having long bone fracture, you need to do early surgery. This is the definitive way to prevent fat embolism, otherwise there will be life-threatening situation. So the optimal management of orthopedic trauma require more than individual surgical skill. It usually needs institutional support to get optimal result. Thank you.
Thank you, Vikram. It's a very good and nice presentation. So now it's time for the open questions. Is there any question? No question. So there are this number of audience. So with this, we'd like to conclude the session. Thank you. Thank you very much.
We are not concluding the session. There are a couple more sessions here. I ask Dr. Santanu come and do the presentation. Hello. Dr. Santanu Malik, can I ask you to come and do the presentation? Thank you, Biplo. For the next session, we would like, can I request the Rajesh Prabhanik on the stage? The topic of his presentation today is kaleidoscope of back pain, and this session is being chaired by Dr. Subhashi Sarkar. Dr. Subhashi Sarkar, please, and Dr. Santosh Chenurto.
Good afternoon. It's a very interesting topic. We all need this advice, at least after sitting for prolonged time today. Many of us will need this advice. Rajesh, please start.
Good afternoon, everybody. When Tanmay asked me to speak on approach to a patient with low back pain, so at that time I thought it's very difficult to speak in front of the students at this age about the algorithm or approach. So I changed it. So the back end of the day, I know that everybody is quite tired now. So just I will share few of the cases. All these cases, they are either the patients, either doctor or the patient's family is a doctor. This patient actually, she is already পরের বছরের জুনিয়র 47 years ফিমেল পেশেন্ট 5 বছর আগে হঠাৎ করে সকালবেলায় ফোন আমাদের আপনার কাছে যখন ফোন করলো আমার বইয়ের প্রচন্ড ব্যাংকে So when I examined the patient, she is in severe pain. When actually I examined the patient, Vasco was quite high, 8 upon 10. So she took one diclofenac, 7 whatever the features available. They have taken all those things, and one of the few source of vomiting, and one of the source of hematosis. So it was probably a syndrome, and on examination, spine was absolutely essentially normal, but she looks quite exhausted, and most important that pain is actually out of proportion to the clinical finding. So I examined the parenchyma, and it is simply multi-site positive. So ultimately came out to be case of multiple polynucleosis. So this is the scenario. She is a doctor, her husband is also a doctor, and landed up to my clinic with that ultimately operated. Again, this patient, this patient is 65 years old female. Her son is working at Tata Cancer Hospital. So one of my colleagues senior actually called me to see this patient, and she was suffering from severe back pain and treated by multiple doctors in several hospitals. On examination, Inner is about T10, D11 and L4, but she was with anemia. I mean agony actually. On X-ray there are multiple ways of fracture. And this John said, okay, we have already, she is on denosumab injection for osteoporosis, but on the X-ray scan actually it's severe osteoporosis. And hemoglobin is 9.2. She came with a big eye. I got every investigation over there, including MRI, but no ES are actually done at that time. So I already asked for ESR and a CRP. ESR came out to be 112. So ultimately, provisional hemolysis is done, and M band was positive, and elevated fetal microglobulin. So ultimately, she was under treatment at Collections now for 1 month. And this is the patient, again, 62-year female patient, having severe back pain, not responding to any conservative management. But there is a significant nocturne of death. On examination only, there is muscle spasm around the dorsal area. And on the available investigation, she is again osteoporotic. But T score is minus 4.2. Severe osteoporosis, and J score is minus 3. So it is definitely a secondary osteoporosis. So patient was on already chemotherapy. In current day practice, patients are getting rampant with denosumab along this medicine. But interestingly, most of the time, the causes of other secondary osteoporosis been missed. So on both procedures, there is weight 3 kg variable, 5 kg weight loss in 3 months time. I didn't get anything, so I asked for a PET CT, and PET CT saw the small as well. With thyroid gland, and which ultimately came out with molecular CA of 10. And this patient died actually. Actually, there is a whole list of causes. Secondary osteoporosis, which need to be excluded whenever there is a clinical signs are suggesting. So this is very, very important, which is sometimes missed in our patient. And this patient again, one of my PGP, now he is working in Netherlands. He said that my uncle is suffering from severe low back pain, but I have treated with all the conservative management, I have given everything, he is not responding. This patient was also suffering from nocturnal pain. On spinal examination, there is tenderness of the L3, L4. X-ray is almost normal. But the problem is that he didn't examine clinically his uncle fully. When I examined the patient, I got a depth stone also. So we ultimately on investigations came out to leprosy. So actually, an MRI also came out to be leprosy. This is another case. He is a IAS officer, though he is a doctor. His father was suffering from severe pain. His father was a farmer from Bihar. So it was a chronic inflammatory low back pain without any peripheral arthritis, but partial response to influoxetine. And on examination, SMR was false positive in left side, and left esophageal tenderness is positive. On examination, ESR raised, CRP raised, EGFR is negative. So this is the MRI picture. You can see the left esophageal is quite okay. On all questionnaire, there is no constitutional symptom because pox is quite common in our country. On other clinical examination, no constitutional symptom. So we just give the differential and then ask for hepatitis B, C. All this is a negative, but IgM antibody for brucella is positive. And again, first questionnaire, here given the history of taking raw milk. In this childhood, there is no. So nowadays, we are getting good number of brucella cases. So this is another thing that we should have. So special attention in back pain actually given particularly for those patients where pain is out of proportion. When the clinical examination is then we need to give special attention. And nocturnal pain is another very, very alarming sign. This is the case, 67-year-old man. Suffering from, he is a senior doctor. I think our Dr. Day and Dr. Hadar see, know him. He has a nursing home at Behara area. Now he has sold it to nursing home. Suffering from severe diabetes. And seen by several doctors, all the investigations done with additional calculations, ECG, echo, coronary angiogram, everything was normal, HSC normal, MRI dorsal was fine, normal. And he came to me at SSKM. So when examining the patient, I got only hypomyocyte band over interstitial linear infrastructure. He used to sit the television and other things, lying on a sofa in a poor posture and develop this thing. So I just ultimately I did the giggling over there, local instead of steroid and dopamine, and then he was absolutely fine. So sometimes actually simple clinical examination means lot of things. Like this patient, 18-year-old male patient, chronic non-inflammatory low back pain, X-ray is essentially normal, MRI there is a big spot. This is another thing nowadays is a very common practice. Due to the free MRI also, there are a lot of MRIs going on, and most of the time MRI is false positive. So clinical examination is very important. On examination, there is a hamstring tightness and ITD tightness, tightness, and he was just suffering from lumbosacral strain, nothing else. So it's a clinical diagnosis. And on stretching and other few little community management, he responded quite well. So sometimes, even this patient, she's anesthesiologist, senior anesthesiologist, currently the also practicing, severe back pain, and MRI shows VIVDL for L5 and L5 as one. So one anesthesiologist, interventional pain specialist, he has treated with transfemoral epidural steroid injection without any pain relief. When I examined the patient, NCS was absolutely normal, but there is a pyrogenic test is positive and fat test is positive. So we have just given a peristaltic nerve block, USD guided, and she responded absolutely fine. So Pyrogenic syndrome and others, there are a lot of other entities which may be the differential. So most important is clinical diagnosis is the key. We should not treat the investigations, we should treat the patient, and MRI findings are many times coincidental or misleading. This is another case. 35-year-old heavy manual laborer presented with chronic left-sided mechanical low back pain, no radiation, no systemic features. On examination, SNL feels there is a tenderness of the leg, bottom, and iliac crest. Actually, MRI was minimal disc bulge again. So we have diagnosed the patient as fluvial neuralgia. Fluvial block, diagnostic block, followed by a therapeutic block. So this is another entity, fluvial neuralgia, very commonly missed. Is it, but the prevalence of fluvial neuralgia in axial low back pain is from 1.6 to 14% cases of low back pain. So generally is to miss it. So it is very easy to block this fluvial neuralgia by ultrasound. Just we need to see the posterior, that's fine. It's very near to the posterior, that's fine. You can see the needle there. So this is a target point. You can see over there. So fluvial neuralgia, another entity is sometimes most often missed, and especially for the female patient, this patient is dyspareunia, treated by multiple gynecologists for PID, and repeated USC, no endometriosis, but for clinical examination, tenderness found to be at the ischial spine. The patient is suffering from pudendal neuralgia. This is another entity. Pudendal neuralgia, most of the time is missed in our setup. So, therapeutic block followed by intervention is fine. So, just want to mention that nowadays, only minimally invasive procedure like epidural block is quite okay for radicular pain. Surgery most of the time is not needed. This is the patient we generally do superior hypogastric plexus block and ganglion ether block for pelvic pain, particularly for ovarian cancer, endometriosis, or other type of patient. It works very well. We have a lot of gynecologists there, and they are also getting this type of patient. And this is another entity is facet arthropathy.
একদম সাইজটা কি হবে এটা আপনি জিজ্ঞাসা করতে কারেক্টলি গেল না
Patient actually suffering from facet arthropathy and it is not being treated. So we do initiate a diagnostic block of medial branch block, then followed by radiofrequency ablation. One radiofrequency ablation treat it. This is the RMA going on or facet
if there is no red flag sign, we will do RFO biopsy. We just put that actually probe in between the disc and that just burn it, denatured. So this is the RFO, and it's quite kit is costly. Biopsy kit is around cost is around 90,000. So that is on the bit. Otherwise, it's quite effective. And you know the other blocks like we go for chronic pancreatitis, pancreatic CA, all those patients suffering from severe back pain, when there is no available management substitute in the practice, sugar pressure suffering a lot. We do sugar pressure block and sugar pressure for most of the patients. That patient actually does very so, and basically, I'm sure that our October friends are doing bioplasty, so we are doing bioplasty also. But one thing I would like to mention, sometimes teriparatide works very well in bioplasty, but simple gray-amide communicants block. It's quite effective to reduce the pain, relieve the pain immediately. So it lasts at least few months in between the teriparatide works. So yeah, you know the patient due to breast compression suffers lot of pain. So this simple gray-amide communicants block is not a difficult task to do it. So it is easy to do it. It helps the patient. So to conclude, specific diagnosis is the key for management of back pain. Integrated management is very, very important, and targeted intervention nowadays are very much helpful. Thank you.
Thank you, Rajesh. Any questions? Sure.
For RFA, most of the time it lasts quite a bit, maybe 2 to 4 years. Like acid plant RFA works very well. But different types of ganglion, generally, one time injection is sufficient, and one time block is sufficient. Maybe this sugar contaminate the other types as well. But for radicular compression pain, generally it may be repeated. But endometasis we do a diagnostic block followed by RFA. And generally 2 to 4 years time interval.
Any more questions? Okay, thank you. Thank you, Rajesh, for the lovely presentation. And to end it, I think the take-home message from his presentation was that many a times after our years of experience and clinical practice, pain ceases to be a diagnosis and becomes more of a sign and symptom, which actually is, but we think it's a diagnosis. So often we would treat it even on the telephone with just a medication. So we need to put our caution on that ground and treat it properly, get into the details and make a diagnosis before treating pain. It was a very good take home from there. Thank you, Raj.
For this session, I would request Dr. Vidut Biswas to felicitate Dr. Rajesh Pramani and the chairpersons. Thank you, Rajesh, and the chairpersons. The next and the final session of the day is optimizing osteoporosis management from diagnosis to treatment, represented by Dr. Sujay Kundu. Dr. Sujay Kundu, please take the stage. The session is to be chaired by Dr. Tapas Sheikh and Dr. Biplab Dubey.
বলছিলিস
We are all tired, brain, minds and legs off. I'm going to close it, wrap up quickly. Today the osteoporosis is a basically silent epidemic of our society. We cannot treat osteoporosis in time. There is a fractures, immobility, and even paralytic state. Compromising on the management, the diagnosis of treatment and diagnosis. There is osteoporosis we all know. That is what are characterized by documentation increase risk of fracture. One and osteoporosis. One in three women over 50 age. One in five women 8 to 62% risk of women. 8.5 to 24%. Mostly for the women the osteoporosis prone to fractures and like male smokers and smokers and those who are taking alcohol may they are getting osteoporosis day by day. Pathophysiology of osteoporosis. Osteoporosis is an imbalance occurs between bone resorption and bone formation. Is imbalance might occur as a result of combination of following factors like increased bone resorption and decreased bone formation. A major imbalance occurs as a result. The pathophysiology of osteoporosis is bone remodeling depends on sarcophagus like trabecular bone has a bit more turnover than cortical bone like vertebral, proximal femur, distal radius, the more prone to osteoporotic fractures. The osteoporosis on the right side, left side, they are showing the trabecular bone getting wasted. This is a normal bone. How osteoporosis is diagnosed? The detailed medical history regarding this was to go back to the exact different history of fibromyalgia throughout the body. The physical examination like spectrometry, few investigations. Legal criteria for osteoporosis is mostly what we know. Normal is 1.0 and low is 1 2.5 and below 2.5 is osteoporosis. Less than 3 minus 3 is a severe osteoporosis. Based other than exercise, what involves capping the head scanning, peripheral external radial, thyroid scanning, calcanium scan, aorta marker, P1, usually we do the P1, P osteocalcin. There are various markers, not tested regularly. Related to the activity of osteoclast and osteoclast. The management of osteoporosis non-pharmacological therapies and procedures, nutritional recommendation, pharmacological therapy. So, few non-pharmacological therapy for osteoporosis, regular exercise, suicide level 2, busy practitioners, like more common IT professional and bankers, those who are working in this throughout the day in chair and throughout the day in the AC. They are more the fall prevention, awareness, tobacco use, and limit your tobacco use and limit your alcohol consumption. I don't know how. The nutrition recommendation, we are taking regular calcium and vitamin D in the morning. One doctor from Harvard told the regular taking of calcium is the main device to make. I have suffered of
calcium and vitamin D, the supplementation, regular need of vitamin D, 1000 to 2000, regular dose. If these are low vitamin D, less than 5, then you can start with the injection and 6 lakh and all like this. Higher dose of vitamin D, necessary in some cases like malabsorption, diabetes, and obesity. Counsel the patient maintain the adequate dietary intake of calcium, rich substance, calcium rich food. The treatment options are bisphosphonate, the ultimate drug from very long, they are using alanine, triazole, nowadays Ivanovan and glutamic acid also. Hormone therapy in estrogen might guide using osteoporosis regarding estrogen and ACR and like relaxable. And we, the newer generation, osteoporosis treatment is a RANKL inhibitor. Is there also what is RANK? The basically rapid acting nuclear modulator of kappa inhibitor basically. Another is like teriparatide, the anti-sclerotic antibodies like bromosolimab, bone remodeling cycle, and the big cycle. There is ultimately is a reduce the osteoclastic resorption and increase the osteoclastic activity. This corresponds to the more things like use apoptosis of the osteoclast and thus slows down the hypertrophic resorption in osteoporosis. By slowing on that, you are basically apoptosis of the osteoclast. So how this works, what is the efficacy of this bisphenol? The increase in BMI 4 to 9% in blood test after 2 years of the treatment, increase BMI, similarly, increase BMI at heat, risk of reduction. How could you diagnose the serial X-ray or CT of that part like heat, vertebral polygon, like scapula? There's a risk of reduction of vertebral fractures. The bisphosphonate is a 40 to 50% over the 3 years of oral bisphosphonate therapy. And 70% of glutamic acid therapy after 3 years is a reduction of vertebral fractures. Bisphosphonate is a gastric pain, which is called gastric irritation. You have bisphosphonate, then you have to take empty stomach once in a week. You cannot lie for 2 hours. You have to take 2 glasses of water. It's a common renal impairment patient. You cannot use urinic acid. Acute phase reaction, IV bisphosphonate, Ivanovan and IV use is a common problem in the long run osteoporosis of the jaw. And there is atypical femoral fracture shown on the graph. Normally, yes, just below the metaphyseal area, there could be chance of fracture. These are adherence, these are commonly, it's a non-continuous, you have to use the bisphosphonate, and it's dependency either to again the bone marrow, DEXA scan, or reveal the osteoporotic after stopping of bisphosphonate. Estrogen, I don't have experience on estrogen, like 0.625 estrogen levels, prevention of the postmenopausal osteoporosis, which is high risk of fractures. Definitely, those who are intolerant of non-estrogen product, they can use low dose estrogen therapy as a hormone replacement therapy. Raloxifene is one of the only used drugs in osteoporosis, 16 mg once daily. We talk about many raloxifene safety and risk of renal increased risk of death due to stroke, the common adverse heart disease and expenses. Teriparatide mechanism of action is works since 2013 with the teriparatide injection of vertebral fracture and flu. operated fractures, recombinant PPH with the synthetic PPH stimulate the like osteoblastic activity and reduces the osteoblastic activity. So both way they are job and ultimately increase the bone remodeling. I have used it to prevent the fracture patient osteo the recombinant PPH and credit I have used, and I have a 4 to 5 international journal publication on osteoporosis regarding that the fractures, osteoporotic fractures also. Pericardial indication dosing and administration. The most important thing is if you have the osteoblastic tumor or any kind of Paget disease or like you cannot use pericardial as because it has osteoblastic activities. You cannot use in those patients. The treatment of osteoporosis post-menopause in women having increased risk of fractures. Treatment of osteoporosis with sustained systemic glucocorticoid therapy. You can use teriparatide, glucocorticoid, use osteoporosis in women. Men increased risk of fractures. The 20 mcg is the only dose daily. The pain, the preferred syringe, so the pain international unit of 20 mcg daily. You can use teriparatide for at least initially I have used for 6 months, then to increase in vertebral fractures or to reduce the vertebral osteoporotic fractures. I used it. You can use for 2 years at least. Role and efficacy. Significant reduce of risk of vertebral fracture and non-vertebral fractures. Efficacy of teriparatide is at almost 19 months of 24 months. The mean increase of 9%. Relative risk of reduction of vertebral fractures is 65%. Here all study is there, different studies on that. Relative risk of reduction of non-vertebral fractures is 53%. Teriparatide is a good choice, but you cannot use in Paget disease or osteoblastic tumor having patient, and there is you cannot use in renal compromised patient also, CKD patient or any kind of renal compromised patient. You cannot use teriparatide. It could be chance of renal failure. Yes, injection side reaction, nausea, pain, headache, is a common. Then you're coming like newer generation factor in osteoporosis and denosumab. How does it act? It acts on the rank receptor. Ultimately, the goal is to reduce the osteoclastic resorption. The denosumab is a stimulator of osteoclastic maturation and bone resorption of the osteoclastic during unlike the post-menopausal osteoporosis. Denosumab basically fully monoclonal antibody against the rank acts to prevent the rank from interacting with the rank receptor told the ultimately it is a basically acts on osteoclastic accessions. There is a showing in the picture. Ultimately approved indication in India of denosumab is a post-menopausal woman osteoporosis. Another series of 2 year using osteoporosis with a high risk of fracture patient, even in post-fracture patient. Treatment to increase the bone mass in men in osteoporosis. There is a glucocorticoid induced osteoporosis that use denosumab 60 mg supplied every 6 months. Guideline and recommendation of the most easiest FDA approved. UK and Canada also approved the denosumab. In India, we are using, there is a frame study going on osteoporosis. Continuous treatment of the denosumab help more than 80% of the women are non-osteoporotic. The score increases with the denosumab. Child freedom study. Denosumab in care renal function. You can use in compromised renal concentration. Denosumab. The fracture risk reduction changes the renal function. Mechanism of action just told it's a highly humanized monoclonal antibody. It acts on sclerostin. It does dual action on bone formation and increase bone resorption. The indication is recent fracture, multiple fracture, very low peak score like less than 3, while very high fracture probability individuals, fracture acute osteoporosis, fractures, medication on skeletal risk patient high, and high fall risk patient like old age people who can use rheumatoid marbles are basically basically molecules started in India last few months, almost 1 year, and using in 6 patients have a good, but the reservation in cardiac patient is the most important contraindication patient with EMI, and within 1 year you cannot use even in IHD patient. You have to use processing most common the joint pain headache. The side effect essential point to risk high individual, risk individual, particularly those previous fractures, which postponed and postmenopausal women high risk of fractures. More combination therapy of denosumab and rosnilimab is second study is going on. I have used teriparatide and denosumab along with 3 patients osteoporosis. Is administered inside the abdomen, thigh, and arm. The same stone treatment of very high risk patient. So basically, study is going on both. Thank you.
So you let us know the time. There is no more question in this session. We can conclude this session here.
Thank you, Sujay. To felicitate Sujay and the chairperson, I would like to Dr. Dipanshu Bosu-Lole to come over the stage. Bosu Choudhury to come over the stage. With this, we end the academic part of this very lovely Sunday. Hello? Shomo, can you put on the slide? So, we are coming to the end of the session, but the academic session, but not the end of the day. We still have a meeting amongst our batch, so I would request everyone to stay back. We played a new video song that we have made for our batch reunion as well as CMC series reunion 2027. Before that, I'd like to thank our sponsors, BDR, Mankind, Zydus Vibration, Incus Antima, Incus Acquida, Tyler, Torrent, Johnson Architect, Orchid, Universal Beauty Sciences, 9M, Zydus Perizit, Vision and Vector, Idea Cure, Cyclostem, Gufic, Giants, Agnos, Lupin, Sun Pharma Classic, J&J Meditech, Incus Aliman, Sun Fedutouch, AB Wedding, Juventus, Sigma Montreal folks. And also the Redis, and I think missing that. That's what. So with that, I'd like to thank all the sponsors. Thank you very much for supporting this academic program. Now, I'd like to create a song, music video song for our
ফিরে আসা দিনগুলোকে মন আমার আজকে খোঁজে চিঠিগুলো গল্প হয়ে উড়ে যায় কোন আকাশে ফিরে আসা দিনগুলোকে মন আমার আজকে খোঁজে চিঠিগুলো গল্প হয়ে উড়ে যায় কোন আকাশে স্মৃতিগুলো হেঁটে হেঁটে কি একটুকু চিনে কোথায় বন্ধুত্বের কথা সব জমে আছে মন ঠিকায় বৃষ্টি ভেজা পাতা মুখ বল বন্ধু চল গল্প বল হাত ধরে ওই পাঁচিলে বসে বন্ধু চল গল্প বল বন্ধু চল গল্প বল Hostel life ওই করলো পাঁচটি ধর্মতলায় ফেরকাস আর ভালো লাগা স্বপ্ন কালে যাওয়ার আজ সেই হারুর বাগান ক্লাস পান্তুরে হুল্লোর পান ছিল অনেক বেবিকার দাম স্বপ্ন কালে যাওয়ার
না ঠিক আছে এবার এটা অফ করে দিতে পারো সাউন্ড সিস্টেম নাই হ্যাঁ এটা বন্ধ ব্যাকগ্রাউন্ডে বাচ্চা আপনার একটু ব্যাকগ্রাউন্ড থাকুন হ্যাঁ আপডেট করো
রেডি হলে বলো সামনে ব্যাচকে বলো নিঃশ্বাস একটু নিঃশ্বাসে গুলিটা ঢুকিয়ে
মাইক ওখানে একটা মাইক ওখানে রাখাই আছে
attention please, electronic সবাই কিছুক্ষণ ওয়েট করে যা। প্লিজ সামনে চলে সামনে চলে। আচ্ছা হ্যালো, সো বেসিক্যালি অনেকদিন পর আমাদের কাছে একজনকে পেলাম একসঙ্গে, তো সেজন্য একটু ডিসকাস করে নেওয়ার দরকার আছে যে হাউ টু গো অ্যাহেড অ্যান্ড প্ল্যান ফর আওয়ার ইউনিয়ন, যেটা তিন চারটি ইম্পর্টেন্ট কথা বলার ফার্স্টে। ফার্স্ট অফ অল যে আমরা যেটা করলাম এখান থেকে ভালো একটা মানে আমরা কালেকশন হয়েছে, that will give us something to start with. Platinum account of মোটামুটি contribution 91 people have contributed, and amount যেটা আছে সবাই তো আমরা যেটা শেয়ার করেছি কারণ 55 ক্রস করেছি। এইখান থেকে আজকে আমরা কালেকশন আমার ধারণা 27 to 28 হবে, আর খরচা হচ্ছে around 4.5-5 lakhs, so 20 to 22 lakhs we will save from এরকম আরেকটা আমরা করার প্ল্যান করছি সেপ্টেম্বর অক্টোবর, সেটা আজকে পোস্টার হবে। এছাড়া কলেজের রেগুলার সিএমই তো এখন চলবে, কলেজের সিএমই গুলো আমরা সিনিয়রদের বেশি করে এনকারেজ করতে হবে তারা যাতে সে করে, কারণ আমাদের কাছে এই কালেকশন করছি এই প্রোগ্রামের জন্য, এটা কারণ এক্সস্টেড হয়ে যাচ্ছে, এরপরে কলেজের সিএমই করার মতো স্পন্সর আমাদের হাতে চেনাশোনা থাকছে না। আউটপুট ভালো ব্যাটিং করে যাচ্ছে, ফিল্ডার ব্যাটিং করে যাচ্ছে, তো এই একটা পার্ট। সেকেন্ড হলো যে টপ আপ কন্ট্রিবিউশনস, সেগুলো গ্রুপে লিখেছি, সবাই একবার সেকেন্ড টাইম কোডিং দিয়ে থাকে। থার্ড হচ্ছে যে আমাদের কিছু কমিটি তৈরি করতে হবে, ইট ইজ ভেরি ভেরি ইম্পর্টেন্ট। অগস্ট জুলাই আগস্ট অনওয়ার্ডস এই কমিটিগুলো ইন্ডিপেন্ডেন্টলি কাজ করবে উইথ লাইক মাই নলেজ, মানে আমি টিচার ধর ধর মানে ইভেন্ট সিএম তারা একাডেমিক কমিটি, একাডেমিক কোন টক সেশন থাকবে, একটা কমিটি হবে রিসেপশন কমিটি, একটা কমিটি যেটা ফুড দেখবে কত কি খাবার মেনু হচ্ছে কি হচ্ছে সে হচ্ছে সুভেনির কমিটি, সেরকমই ইভেন্টের যে কমিটি আছে যেরকম গুগলরা করলো যে সেই ম্যানেজমেন্টের জন্য কমিটি করতে হবে। এবার ইভেন্ট রিসেপশন কমিটি উইল ডিসাইড অলসো অন দ্য চিফ গেস্ট, because we will decide on the chief guest. আমরা সবসময় এখন গেস্ট আর্টিস্ট নিয়ে ভাবছি, চিফ গেস্ট নিয়ে ভাবতে হবে। তো চিফ গেস্ট কাকে আনা যায় এ নিয়ে সাজেশন অনেক কিছু নাম টাম আসছে, যে গভর্নর, কেউ হচ্ছে রাষ্ট্রপতি, কেউ হচ্ছে প্রেসিডেন্ট, এরকম ডিসকাশনের স্টেজে রয়েছে, এখন তো কিছু ডিসাইড হয়নি। আর গেস্ট আর্টিস্টের ব্যাপারে আমরা যেটা ভেবেছি যে কলেজে ফ্রাইডে আমরা একটা মানে মোটামুটি বাজেটের কন্ট্যাক্ট করবো 8 to 10 lakhs এর মধ্যে, আর সানডেটা আমরা প্রেফারেবলি বাইরে করবো, দিন থাকা হবে। বলিউড সিঙ্গার এখন নাম বলতে হচ্ছে বা করা যাচ্ছে না, কারণ বাজেটের উপর ডিপেন্ড করছে। আমরা বাজেট নিয়েছি স্টার্টিং ফ্রম 10 lakhs to 1 crore, যেমন ধর অভিজিৎ আছে, সান, তারপরে তোর না তোমার সঙ্গে আরো করে 20-30 lakhs এর জায়গা আছে, সুরেশ বসলে, কবিতা কৃষ্ণমূর্তি, এরপরে হ্যাঁ এরপরে ট্রাই সে আমাদের রেট খুব বাড়িয়ে দিয়েছে, এখন 1 crore নিচে করছে না, 1 to 1.5 crores। কুমার শানুর অ্যারাউন্ড 60 lakhs, 60. Sale 1 to 1.5 crores. Solo income around 80 to 90. Sunil Chauhan around 1. All is শেয়ার করবো পরে আমরা ডিসাইড করবো কারণ অগস্ট সেপ্টেম্বর বাজেট সি আমি গতবারের বাজেটটা দেখেছি গেস্ট ছাড়া 80 to 90%. হ্যাঁ কোয়া ধরে চল মানে গেস্ট সার্ভিস ছাড়া সেটা ডেকোরেশন কেটারিং ইভেন্ট অ্যারেঞ্জমেন্ট ইভেন্ট ম্যানেজমেন্ট সব কিছু করে এরপরে গেস্ট সার্ভিস সুতরাং গেস্ট সার্ভিসের বাজেটটা আমরা এই মুহূর্তে অ্যারাউন্ড 50 লাখ ধরে চলছে তাহলে 1.5 এই বাজেটে শেয়ার বছর বা ভাবা যাচ্ছে না অবভিয়াসলি তো ছেড়ে গেছে এখন বাজেট বাড়ে কেন এবার আরেকটা প্রপোজাল আছে থার্সডে ইভিনিং একটা প্রোগ্রাম করেন সেটা ওই সভ্যতা বলেছে একটা স্পন্সর করে দেবে ওই দিনের প্রোগ্রামটা ওখানে সিঙ্গারটা নিয়ে আসবে তাহলে ক্যাকটাসকে বলতে পারি শনিবার ওই করছে অস্ট্রোবৃহস্পতি শনিবার আমাদের হচ্ছে বেলা ডিনার এটা আমরা বুক করেছি হচ্ছে পালিয়ে ময়দান মানে গুলিশোদা ওটা আমাদের পাশে ওইখানে হচ্ছে আমাদের বেলা ডিনারটা হচ্ছে ওইখানে অস্ট্রোবৃহস্পতি করছে আর আমাদের ব্যাচে বা কলেজে যেটা কিছু গান করবে তারা এর সঙ্গে প্রপোজাল আছে থার্সডে যে আমরা বেস্টটা কিছু করি তার আগে 2 ঘন্টা থেকে 3 ঘন্টা আমরা বিভিন্ন ব্যাচকে 8 ঘন্টা করে টাইম দিয়ে পারি তাদের নিজেদের প্রোগ্রাম করার জন্য নতুন নতুন মানে হ্যাঁ এবার ধর না ওই দিকে ধর আমি বলছি আমাদের সিনিয়র ব্যাচের থেকে অনেকে তো পারফর্ম করতে চাইছে অনেকে টাইম দিব না না আমাদের গান করে দেখা যাবে প্রপোজাল মানে ভালো হচ্ছে দেখ ব্যাপারটা তো ইনফ্রাস্ট্রাকচার থেকে তো অলরেডি পেয়ে যাচ্ছে ফাইলটা তৈরি হয়ে যাচ্ছে শেষ এই জন্য না ওই দিন তো মোস্টলি মিউজিক্যাল যারা অর্গানাইজিং নিয়ে কমিটি খুব রোল নেই মানে তো সাউন্ড সিস্টেম মডেল সেট হবে যারা গান করে গান করে দেবে হ্যাঁ তবে তবে বলছি থাকতে হবে না কোনো হ্যাঁ হ্যাঁ ওয়াকাথান নভেম্বর করা আছে ঠান্ডা হ্যাঁ আমি বলা হয়েছে যে আপনি আসতে পারে
if you do not be offline meeting কখনোই কিন্তু আমাদের মধ্যে বন্ডিং হবে না যখন আমরা এখন মেইন ডে 5 6 7 তখন দেখা গেল আসছে ও আসছে না so we can understand the pulse is going to be present on 5 6 7 that's very important 3 days for all of us আর এখানে শুধু কমিটি করলে দেখা গেল কমিটি দিনে আসছে না সে it will be very difficult for Torma to get people that day so it has to be that everyone আমরা এই 2 মাস অন্তর এমন করে অফলাইন মিটিং না করতে পারি মানে 2 মাস মানে বন্ডিংটা বুঝতে পারবো কে সত্যিকারে সেদিন থাকবে আমি ইচ্ছা বাট সেদিন খুব কারো ইমার্জেন্সি হলো কলেজে তো সেমই হয় সেকেন্ড এন্ড ফোর্থ
ফোর্থ স্যাটারডে করে একটা স্যাটারডে মেবি প্রশাসন প্রতি মাসে আসে ইউজুয়ালি সেকেন্ড স্যাটারডে অ্যালুমিনি সিলিপি থাকে ওই দিনকে করা যাবে না করে লাভ তাহলে ডাইভার্সন হয়ে যাবে ফোর্থ স্যাটারডে যদি আমরা সিলিপি ছাড়াও গ্যাস্ট্রিকটা রাখি এভরি ফোর্থ স্যাটারডে অফ দ্য মান্থ কলেজে তাহলে কিন্তু সবাই যদি ওইটা ব্লক করে রাখে হ্যাঁ 3 p.m. I think সবাই বুঝে দেয় সবাই এভরিবডি অ্যাকচুয়ালি কি হচ্ছে যে একজনই কথা বলে অনলাইনে অন্যরা কথা বলে আজকে যদি সবাই বুঝে যায় চাকরি ফোর স্যাটারডে সিএম করতে স্যাটারডে করতে হবে তো যেমন মানে সেটা করতে হলে রিল্যাক্সে আসতে হবে না আমরা এটা হয়তো একটু সেশন কম করে
what happened is ওদের যারা ছিল ডক্টর সৌম্য and some people they are not really ওরা আমাদের ল্যাঙ্গুয়েজ বুঝতে পারছিল না অলদো আমি না পুরো লিখে লিখে দিচ্ছিলাম they were not really understanding the language একটা ডকুমেন্ট আমাকে 5 বার ঠিক করতে হচ্ছিল point 1 point 2 event management team should have a printer in house and should be accessible to us 2 days before the conference যেটা আজকে সকালে বুক আপ হলো we got the registration desk list at 9:30 okay जबकि আমরা কিন্তু ফাইনালাইজ করে দিয়েছি কালকে সন্ধ্যে 6টার সময় so this is a very major move up and you need to tell the event management team that this has to be in place this is a very important thing okay and second হচ্ছে এই speakers যে talks all the speakers their content was very good I really cannot say anything about it content was fantastic all of you but the point is some of you had to hurry through the PPTs যেটা হয় একটা বড় content if you have to deliver in 15 and 14 minutes rather you were giving 14 minutes time so you were really hurrying so next time আমরা যখন conference করব না next time তো union না তার আগে তো Spanish another conference না সেখানে my appeal to the speakers যে 14 minutes compatible একটা topic choose করা so that you don't have to hurry আমাকে অনেক সিনিয়রই বলছে যে we would have loved it if you had given us time to have a discussion session okay সবাই অনেকই আমাকে বলেছে তারপরে কি হলো 20 minutes was right that is because we got more sponsors and more speakers to accommodate that it may be enough for you, it may not be enough for somebody else.
This is a national conference 12 plus 3
Exactly, that's what I'm trying to say. You choose your